Uh, we are going live. So in about 10 seconds, you can start speaking, Sai sir.
Yeah.
The virtual background fine with me?
Yeah, it's good with you.
Sai sir, unmute yourself when it's time.
Good morning, dear friends. A very warm welcome to all of you to this wonderful webinar on intravitreal injections. I'm Dr. Sai Kumar. I'm president of the Cochin Ophthalmic Club, and we are extremely glad to host this among the series of webinars that we have been doing almost every Sunday, about 3-4 webinars a month. We have a big array of luminaries in the field of vitreoretinal surgery in this panel. Dr. Gopal will be formally introducing all of them. We also have 2 wonderful keynote speakers. One is Dr. Ravi from the US, and my own teacher, Dr. Shobha Shivaprasad from UK, along with luminaries like Dr. Lalit Verma, Dr. Giridhar, Dr. Gopal. You can now formally introduce the speakers. I also welcome my KSOS president, Dr. Meena, who will be taking part in this meeting as faculty, and as she'll also be officially inaugurating this CME program. Dr. Mahesh is here. He is the General Secretary of the KSOS. Dr. Unni is here. So Gopal, you can please take over and start the proceedings.
Thank you very much, sir. At the outset, let me welcome each and every one of you for this wonderful webinar on intravitreal anti-VEGF injections. As you know, intravitreal anti-VEGF injections have become one of the most commonly done procedures in ophthalmology. And there are many situations like age-related macular degeneration, diabetic retinopathy, myopia, ROP, retinal venous occlusions, in which anti-VEGF forms the mainstay of treatment. And as far as a comprehensive ophthalmologist is concerned, we have to have a very clear idea regarding indications, when to start, when to continue, when to stop, when to slow down, when to move more rapidly, and what to speak to patients. And is there any problems? What are the safe methods, as well as what are the legal tangles or complications that you can jump into? So to address this huge area on intravitreal injections, all aspects of it, we have none other than Dr. Lalit Verma, who was the scientific committee chairman of the All India Ophthalmic Society, my teacher, and Dr. Mahesh and Dr. Thomas, who will be moderating this program. And the speakers are actually luminaries in their own fields, right from Dr. Giridhar, Dr. Meena Chakrabarti, Dr. Rajesh, Dr. Alai Banker, Dr. Mallika Goyal, Dr. Unni, Dr. Dipendra, Dr. Dinesh Talwar, Dr. Chaitra, and 2 keynote speakers, Dr. Shobha Shivaprasad and Dr. Ravi Keshavamurthy. So without further delay, I would I would ask Dr. Lalit to start the proceedings by starting the debate.
Meena madam can tell a few words.
Yeah. And this program has been kindly supported by Bayer. Meena madam, please.
Good morning, friends. It's nice to be here and meet all of you virtually. On behalf of Kerala Society of Ophthalmic Surgeons, who is co-hosting this meeting, I declare this meeting as inaugurated. It's a very, very important aspect because anti-VEGF injections, like what Dr. Gopal said, is one of the most commonly performed procedures in our country. And I'd like to lay emphasis on the fact that it is not just to inject. The post-injection follow-up is much more important than the injections that you give. And we see a lot of patients who have received 1 injection or 2 injections and never reported for a follow-up. And most of their eyes do badly. So this webinar meant for the comprehensive ophthalmologist with very clearly written guidelines on when to inject, what to inject, how to inject, what to speak to the patient, will definitely have a take-home message for the comprehensive ophthalmologist. I'm very happy to declare this meeting as inaugurated. Carry on, Gopal.
Good morning, everybody. You see, this topic, intravitreal injection, concerns everybody. Whether it's an anterior segment surgeon, posterior segment surgeon, he should know some degree of ophthalmology, that's it. So today, I believe that it has become bread and butter for retina surgeon. And even for anterior segment ophthalmologist, everybody wants to give injection, whether he understands the disease or not. The sad part is people keep giving injection without understanding. So that is what bugs me the most. You see, giving injection is not difficult, but understanding when to give and not to give, how much to give, how to make it cost effective for the patient, and what is a good technique, what dosage plan we should be following without getting yourself entangled in the legal issues. So I will introduce this topic by a couple of slides and then ask the various speakers to go about it. The plan is that first part one will have all the paradigms, whatever are what the controlled trials have taught us in 6-7 common diseases. And all these luminaries will tell us about ARMD, DME, what are the treatment paradigms which one should be following. These are based on clinical trials. And part two, what Gopal and me did was that we brought in practical issues. Are these translatable into real life scenarios or not? And we have two very good keynote addresses who will try to compare and contrast clinical trial versus real world scenario in ARMD and DME also. So thanks to Cochin Ophthalmic Club for conceiving this idea and KSOS, and my regards to all the office bearers of KSOS as well as COC. We know that VEGF is produced by the body whenever it requires formation of new blood vessel. And this man, I think all of you know, Napoleon Freire, he and his colleagues at Genentech long time back, I think they were one of the first to isolate this VEGF. And Philip Rosenfield, in one of the American Academy meeting, you see, had introduced Avastin. Initially, observation was intravenous Avastin could result in some resolution of ARMD. Then local intravitreal was introduced. The production of VEGF, we all know, is required in all our bodies for a lot of normal physiological processes, which includes injury, healing, because without the blood vessels, nothing can work. VEGF is also involved in a lot of pathological processes, like tumors within the eye, formation of new blood vessels in the eye, like in ARMD. Also in vascular disease like diabetic retinopathy, vascular blocks, CNVMs, ROP, and a whole lot of other conditions. So hence, since VEGF is involved in so many pathologies, and hence the role of anti-VEGFs. Avastin, Lucentis, Fovista came with a bang, now went away. Brolucimab is the latest thing which got approved in the last American Academy meeting. Allergan, as you all know, has withdrawn the Abicipar because of intense inflammation. So wheresoever there is an issue of new vessel formation or there is a permeability issue, these are two situations when everybody is forced to think of anti-VEGF agents and the common diseases we'll be discussing. It all started, Macugen, was the first anti-VEGF to get approval. Then came Avastin, then came ranibizumab, then aflibercept, brolucimab. And this shows the chronology of development of various anti-VEGF compounds. You see this statement by Philip Rosenfield, one of the pioneers. It is said, he said, it's very rewarding time for caring for patients because we have plethora of these anti-VEGF agents available, so that now not only we can halt the progression, we can look for improvement in vision in a lot of diseases, or sometimes we can alter the course, like in diabetic retinopathy of diseases. So they have truly revolutionized the treatment for plethora of ocular angiogenic disease processes, and has become virtually first-line management in a lot of these conditions which are listed here. So without much ado, I think we'll move on. Part one will discuss the treatment paradigms, what clinical trials have taught us. Part two, we'll go into practical issues. So I'll request Dr. Giri to please upload and start sharing his slide. Dr. Giri, you know, is a very, very senior VR consultant with us, and he does a lot of work on, he's very well known for, apart from VR surgery, for IPCV and parafocal telangiectasia. A lot of publications are there. So I request Giri to please share his, and I will stop sharing now.
Thank you, Lalit. And thank you, Lalit, for that very nice introduction. So, good morning to you all, and good morning, Dr. Lalit, and to all the panelists, to the speakers from all over India, and also from across the globe. What I'm going to do in the next 10 to 15 minutes, because Dr. Gopal Pillai requested me to cover anti-VEGF in PCV also. So I may take about 3 or 4 minutes on that. But what I'm going to do is share some of our experiences, and as Dr. Lalit Verma said, as to how we can translate level 1 evidence into our clinical practice. I hope I'm audible.
Yes, Giri, you're audible.
Thank you. So actually, I mean, this is my presentation flow. How do we diagnose wet AMD? Because that's very important. Basically, I personally feel that when a treatment-naive patient comes to us, at the time of the initial visit, it would be advisable to do a fluorescein angiography and indocyanine green angiography if it is possible. Apart from the OCT. OCT is the hallmark both in terms of diagnosis and follow-up of patients with wet age-related macular degeneration. But invasive procedures like fluorescein angiography and ICG will be able to help us to identify the type of neovascular membrane, and probably that helps us in educating our patients about the type of disease and also regarding the long-term follow-up. So my talk will actually focus on current evidence, what has changed in the last 10 to 15 years, and how that, I mean, what are the new things that have come, and how this can be put forward in our practice. Because today, basically in the treatment of wet AMD, what we are looking at is how we can retain visual acuity with less visits, and as Lalit said, looking into the socioeconomic impact of the management of this chronic disease. So, I mean, we need to know the history, because basically it was in 2000, a landmark year, when we had the first approved level 1 evidence treatment for the management of wet age-related macular degeneration with vertiporphin photodynamic therapy. But unfortunately, although PDT was effective in treating the neovascular membrane, visual acuity improvement was not seen following PDT treatment, and recurrences were quite frequent. Therefore, it required periodic intervention with a repeat photodynamic therapy. The landmark development, of course, was the first anti-VEGF drug, that is pegaptenic, in 2004. And as Lalit said, the first off-label use of bevacizumab and the ranibizumab, which came into treatment way back in 2006 when it received the FDA approval. There are many landmark studies, and I tell the youngsters who come to learn medical retina, it's very important to read some of these papers, because it's not that it's not possible for you to remember everything that's written there, but then it gives you a guidance as to how you can educate your patients regarding this particular disease. So this is the first most important study, that ranibizumab for neovascular age-related macular degeneration. And what we all know, that for the first time we had a treatment where at least 1/3 of the patients showed visual acuity improvement during the course of the treatment. And this probably is a very, very important slide, which has been shown across the world so many times. What does it tell us? One is intervention on a monthly basis shows visual improvement after the initial loading dose. And what is the natural course of the disease? This is what we need to educate our patients. What happens if you don't treat? So if you have a patient with a very good visual acuity, and if they are left untreated, there is progressive visual acuity loss. And this is the two most important take-home messages from this first earliest landmark trial. It's very important for all of you to read this particular article, the path to intravitreal bevacizumab, a landmark development in the treatment of wet age-related macular degeneration. And the development of bevacizumab, or the introduction of bevacizumab, made this treatment available for a common man, especially in countries like India, developing countries like India. And this was really one of the revolutionary developments in the treatment of wet age-related macular degeneration. And this is a very interesting article as to how Philip Rosenville got the necessary permissions from the university to test this particular drug, initially intravenously and subsequently intravitreally. Apart from this, there are a couple of other trials which are very important. The importance of the CAT trial, which I'm showing you here, is basically in the initial trials, all of them had the monthly treatment, but then that's not feasible in a fixed monthly regimen in practice. And therefore, there are a lot of studies that looked into what we call as the PRN treatment, or as needed treatment. And one of the trials that looked into it is the CAT trial. Now, if you look into the CAT trial, the 2-year results of the CAT trial, although it looked into the comparison between the ranibizumab and bevacizumab, and also into the safety of bevacizumab, but also it looked into the PRN treatment, and monthly follow-up with PRN treatment did not have the similar visual acuity results as monthly intervention. But nonetheless, it was quite effective in the long-term treatment of wet age-related macular degeneration. Therefore, although the number of injections decrease in a PRN treatment, patients need to be followed up on a monthly basis. The 5-year results of the CAT trial is very important when we talk to the patients. There are 2 important messages from this trial. One is, when you see the 5-year or 5.5-year follow-up, 82% of the patients still have active disease. They have fluid in the retina, meaning thereby this is a chronic disease. And number 2, 50% of the patients still maintained a visual acuity of 20/40 or better. This again is a very important message to some of our patients. Subsequently, we had a lot of trials which looked into what we call as the treat and extend regimen. That is, we tried to reduce the number of interventions. And one of the earliest studies that looked into the treat and extend was the VIEW study, the later part of the VIEW studies, which looked into the use of aflibercept. And if you look at the 96-week result, initially all patients received the bi-monthly treatment, but then between 52 and 96, there was a cap where patients received treatment at the end of 12 weeks, but then they had the treatment was a little bit stretched into something like a capped treat and extend treatment. And this important trial tells us that in spite of the reduced number of injections with aflibercept, visual acuity improvement, which was achieved at 52 weeks, continued at 96 weeks. If you see this particular side, the number of injections during weeks 52 through 96 was lower, and it was only about 4.7 to 4.2 injections. Therefore, by reducing the number of injections also, they could retain the visual acuity improvement in this particular study. And this is what gave us an idea as to the implementation of the treat and extend regimen in practice, in clinical practice. So today, these are the drugs that we have. Pegaptenic is not being used now, but ranibizumab, bevacizumab, aflibercept, and brolucizumab, and these are the dosages of the various drugs that we have, and this is the frequency at which they are administered. So translating early trials into practice, we have the initial loading dose where initially we need to give on a monthly basis till the macula gets dry, and subsequently a maintenance phase. This maintenance phase is what is very, very important. And to achieve a good maintenance phase, we need a good patient education and counseling. I tell the patients 2 or 3 things. One, it's a chronic disease like diabetes or hypertension or ischemic heart disease. The only difference is, whereas those diseases you need to take medicines every day, here you may need an intervention every now and then. But just like you see the doctor very frequently when you have the other diseases, you need to come and see your doctor as and when the doctor has requested you to come. And if you do that, there is a reasonably good chance that over a period of 10 years, you may have reasonably good visual acuity. And of course, the economic impact of treatment. Therefore, this is a case example for you where the patient is having the induction phase, the treatment naive patient with initial 3 injections. The macula is now dry, and subsequently the patient enters the maintenance phase. Now, in the maintenance phase, you can have 3 forms of treatment, what is known as a fixed treatment on a monthly basis using ranibizumab or bevacizumab, or a bi-monthly basis using the aflibercept, or there will be a lot of studies that have tried the quarterly regimen, which is not probably that effective when compared to the other forms of treatment. The most common form of intervention in our country is the PRN, because I've been attending various webinars, and I find that most of the doctors in India practice what is known as the pro re nata. I do some treat and extend in my practice. I will just highlight that because there's a separate talk on that later in this program. Therefore, once you reach after the initial loading dose, I tell that nowadays I follow the patients on a monthly basis. Earlier, many years ago, I used to call them on the next visit after 3 months. But I realized within 3 months, many patients come back with significant drop in visual acuity. Therefore, once I finish the loading phase and the macula is dry, I initially, for the next 3 to 6 months, if the patient is willing, I call them on a monthly basis and I do the OCT. And this is where the patient counseling becomes very, very important. And it's very important that we decide the patient counseling and the follow-up on a case-by-case basis. But nonetheless, in all patients with wet AMD, I feel after the initial loading dose for the next 3 to 4 months, they need to come on a monthly basis. So what is PRN treatment? I'll show you an example of patients with very long-term follow-up, 5, 6, 7 years. So I have patients coming to me for nearly 10 years on a regular basis. So this is one of my very old patients. He's being treated by me in both the eyes. Now, if you see the color photograph, a classic case of wet age-related macular degeneration, you have a fibrovascular pigment epithelial detachment, you have drusenoid changes, you have a small hemorrhage there. Therefore, this is a classic picture. And on OCT, you see the fibrovascular PED with intraretinal fluid here. And basically with 3 doses of ranibizumab, you can see there's a very good response. Even the PED has collapsed. That's a very good indicator that this patient has responded very well to the treatment. Subsequently, this patient comes to me on a regular monthly follow-up. And after a gap of about 5 months, he has a recurrence, he has the injection. So this is what is known as a PRN treatment, where we treat pro re nata. So after 5 months, he receives an injection. And again, he has a regular follow-up. He is treated as and when necessary. Visual acuity continues to be good after nearly 1.5 years of treatment, still 6/7.5. But somewhere down the line, the patient is lost for follow-up. You see here, he does not come to me for nearly 5 months. And when that happens, there is a dramatic drop in vision. IRF has increased significantly. And again, of course, the patient is treated. And again, he does improve. He is fortunate to happen. That happened. But very often, patients who lose vision never regain what they have earlier. So again, for a second time, he has been lost for a follow-up between 218 and 618. And again, there is a recurrence. So in a PRN treatment, in some of these chronic cases, it is necessary that need to come on a very regular basis. Therefore, this is a patient who needs a very frequent intervention, very frequent recurrence. And therefore, in a PRN treatment, he needs to come on a very regular follow-up. Therefore, after nearly 4.5, 5 years of treatment, the patient still has got a visual acuity of 6/24. Somewhere down the line, he received 1 shot of bevacizumab. because basically because of the cost of the medication. So after 5-year follow-up, 13 injections, visual acuity 6/24 from 6/12, a little bit of, you can see the photoreceptor losses there. There is a little bit of foveal thinning also, but still this patient is continuing under my follow-up and maintains a visual acuity of 6/24 with about 6 years of follow-up. Therefore, I'll come to the discussion later. This is my second case. This is a second case. Now you look between the first case and the second case. Now this is a patient who has been coming to me for the last 9 years. Now, if you see the initial picture on the left eye, there's a one-eyed patient, the other eye has got a scar. You see a slight irregularity in the retinal pigment epithelium here. So this, we know today by looking at the OCT that he'll be harboring probably a silent type 1 neovascular network. And this patient was regularly followed up. You can see this particular area, the irregularity and the length is slowly increasing. And there's a slight, thickening of the choroid and the Pachy vessel here. And slowly the patient is developing a type 1 neovascular membrane. You can see the subretinal fluid here, and he receives 1 or 2 injections. And after that, the macula gets dry. And subsequently, again, he was on a PRN treatment using ranibizumab. He was on a PRN treatment on a very regular basis way back in 2014. He was responding to the treatment very well. The difference between the first case and the second case I'm showing you is that this is primarily a subretinal fluid. The other one had recurrent intraretinal fluid. So when you have just a subretinal fluid, you can see here the visual acuity continues to be very good. But what I would like you all to observe in this particular OCT is this particular area where we have the neovascular network. It is getting more and more longer, and the hyperreflectivity within that particular area is slowly increasing, thereby telling you that the neovascular network is, periodically growing when compared to what it was initially. And that is why after a few doses of Accentrix, the patient became showed a poor responder to Accentrix. So you can see here, in spite of 5 injections, there is hardly any response. At that moment, I shifted him to bevacizumab. Why did I shift him to bevacizumab? Unfortunately, in our country, basically socioeconomic issues become very important, and some of these patients are not willing for expensive drugs initially. So for this patient opted for bevacizumab, but unfortunately there was no improvement with bevacizumab also. And again, he went back to ranibizumab, but again, there was no response to ranibizumab. Just to tell you that once there is a poor response to either bevacizumab or ranibizumab, it may be better to switch to a different molecule like aflibercept. And finally, this patient agreed for aflibercept. He responded well to aflibercept. And then I switched him back again to the Accentrix, because basically for 2 reasons. There are some patients who, after a poor response, when you give a different drug and then come back, they may respond. But then in this particular case, there was no response to ranibizumab again. But what I would like to again make you understand is this particular area, which is getting more and more prominent. Just to tell you, this disease is getting more and more active. So finally, again, he went back to aflibercept, and now this patient on a regular treat and extend with aflibercept, he continues to have very good visual acuity of 6/9. So what do these 2 cases tell us? Number one, intraretinal fluid has got a worse visual prognosis than subretinal fluid. IRF results in dramatic fall in visual acuity. Switching should be much earlier. In the case that I showed you, switching was quite late, nearly 3-4 injections. Switching should be much earlier, and basically probably 2 injections within the course of treatment. The results are poor, you need to switch. And when you switch, probably better to switch to a different molecule. And again, with counseling and patient education, you can retain your patients on a long-term basis. What is treat and extend? Now, this is one other patient of mine. You can see the neovascular network in indocyanine green angiography. Now, this patient received ranibizumab practically on a monthly intervention for a long period of time. He received 14 injections in 21 months, meaning thereby he receives an injection either every month or every 6 weeks. So at that moment of time, I shifted him to convince him to shift to aflibercept. And here now he has been shifted to aflibercept. And in aflibercept, I put him on a treat and extend regimen. So how do I do that? Initially, I gave him 1 shot, the macula is dry. And then subsequently, I gave him one more shot. Now slowly I extended from 1 month. I increased it to 2 months. You can see here some 17.7 to 11.9, 2 months. And from 2 months, I tried to increase him to 3 months, but it's coming back. So probably 8 to 10 weeks interval. If you are able to give the injections, he may continue to have a dry macula. Therefore, there are 3 reasons why I shifted this patient into a treat and extend. Number one, we know this is a chronic disease requiring frequent injection, frequent follow-ups. Therefore, in such a situation, I want to give the patient a treatment where his number of injections decrease, number of visits decrease, but at the same time, I do not sacrifice on the visual acuity. Therefore, summarizing my presentation, I've shown to you that ST-OCT is a very useful biomarker, not only for diagnosis, but also in the management of these patients. That's what we have learned in these 10 years. And how to reduce treatment burden without compromising on visual outcomes. Number one is that basically we need to look at, identify patients who are having a genuinely chronic disease and try to help them effectively by giving medications that give you more protracted effect. And probably in such situations, aflibercept may be, like for example, in the first patient whom I showed you, if this patient had come to me today, I might have injected aflibercept much earlier than what I did in the particular case, because basically at that period of time, we did not have so many choices in the management of the disease. And we need to develop a rapport with your patient. This is very, very important. And we have now learned how to run an efficient medical retina clinic. Patient comes to you, he has a best corrected visual acuity, he goes and gets the OCT done, he comes to the retina specialist, and then he advises what is to be done, and the injections are given if it is done and necessary, and the patient goes home. And very, very important to run a small low vision clinic, because ultimately what patients want is better visual acuity, and many of these patients can have a better near visual acuity with small low vision ads, which are not expensive, but at the same time improves the quality of life. 2 or 3 minutes on anti-VEGF monotherapy in PCV, just about 3 minutes. We all know a lot about management of polypoidal choroidal vasculopathy, but then what is the current status of anti-VEGF monotherapy? Basically, now we all know, now this is one of my patients here, very old patient again. You can see the photograph here, serous macular detachment. And of course, this is a polypoidal disease. You see this pigment epithelial detachment here with a little bit of a notch with a subretinal fluid. And you can see the polyp here in the ICG angiogram. Now, this patient was treated with multiple doses of ranibizumab with little poor response. You can see here, in fact, the size of the PED has increased. And if you repeat the ICG, actually, you can see the network is getting more prominent. Therefore, this is a poor responder to ranibizumab. So we do see that with conventional anti-VEGF agents like bevacizumab and ranibizumab, a sizable number of patients with polypoidal disease show a poor response. And this is a situation at that period of time, many years ago, patient was switched to PDT. Therefore, we used to switch some of these patients who are on monotherapy to PDT when the response is poor, and the patients really respond extremely well with a photodynamic therapy. You can see the post-treatment ICGA, where there is a complete regression of the polypoidal network. And this patient actually had a treatment-free duration of 42 months after one cycle of PDT combination therapy. Therefore, this is one of the advantages of this sort of a switch in some of these patients, where you get a treatment-free duration ranging from 24 months to 36 months, or sometimes if the patient is lucky, a little longer. So this is what is the advantage of switching from anti-VEGF to PDT in selected patients of polypoidal disease who show poor response to the conventional drugs like bevacizumab and ranibizumab. This is again another patient of mine who had multiple injections of bevacizumab with poor response, and again this was switched to PDT combination therapy, and he did well. Of late, probably the anti-VEGF drug that is effective against polypoidal disease is aflibercept, and you can see here with this is a patient with peripapillary PCV. The patient received 3 doses of after 2 months, after 2 injections of Eyelia, you can see here the ICG complete regression. The macula is also dry, but then it's not long. I mean, it doesn't stay for long. It just comes back. Therefore, patient has to be on a regular anti-VEGF injection. It's not that we give 2 or 3 doses and after that the patient has a treatment-free interval of 1 year or something like that. So here within a very short period of time, there is a recurrence of the polyp. At that period of time, of course, I shifted him to a combination therapy because he was not able to afford Eylea on a long-term treatment basis. And again, I could give him a longer treatment-free interval. So you can see here the effect of PDT. Therefore, when you treat patients with polypoidal disease with monotherapy with anti-VEGF, you will have to treat them on a regular basis. And probably this is one indication for a treat and extend regimen. And this is another patient of mine who was initially on ranibizumab and then shifted to aflibercept. And with aflibercept, I'm able to give him an 8-week free interval when he comes to the hospital and has the treatment. He's been under my care for now 8 or 9 years. Visual acuity is still remaining very good at 6/9, but nonetheless, he is on a T&E treatment with aflibercept. Therefore, in conclusion, the most ideal anti-VEGF probably is aflibercept at this period of time. We can shift some of these patients to combination therapy because that gives you a treatment-free interval and you look at the cost and decide and explain to the patient. And many of these patients, especially PCN, that is the type 1 neovascular network, maybe need a treat and extend treatment. Thank you all for your kind this opportunity, and I hope my presentation was useful to all of you. Thank you, and thank you, Lalit.
Thank you, Giri, for very, very lucid presentation. You see, what I like the most in Giri's talk always is his practical, illustration with his own patients. This is how we can relate. And that's the whole purpose, I think, of these webinars. I think all of us can Google the information which is available. But once Giri shows follow-up of 9-10 years, that becomes much more compelling kind of evidence. So a couple of questions, Gopal, if you allow, we can take 1 or 2 questions and then we move on.
Yes, sir.
You see, honestly speaking, he has made it so clear, but a couple of practical questions. Giri said that, case number 1, once you said that you want now a monthly follow-up with your patient. So do you or your counselors or somebody ring them up and ensure that they come, or how do you do that practically? Is Giri there, or has he? Gopal?
I think he has, he is not there, I think.
What's the question, sir? There was this problem with the internet. The question, please?
The question I was wanting to ask was because he made a statement that he likes to see these patients every month now.
Yeah.
Every month. So you see, in US, I know, in fact, Ravi can, also pitch in here. US, all these counselors and nurses, they will keep bringing up people. How do we ensure in our country that, you ask these people to come? I think Giri is there now.
Yeah. I'm sorry, my laptop, the power went off. Yeah.
Did you listen what I asked? You see, my question to you was that you said in the beginning that now you want you to see your patients every month.
Yeah, initially, I mean,
initially, how do you ensure? How do your people come? Do they ring you? Do your people ring them up, or how do you ensure? Because in this country, follow-up is very difficult.
Yeah, now in our hospital, actually, when they fix up the appointment on the day they have the checkup, they fix up the appointment, and basically the appointment is fixed up on that particular day itself. And we have a system that, some of these patients, a few days prior to the appointment, an SMS goes to them that the date is due and they can come for the checkup. So
what we need from senior people like you is to publish some kind of data that how many times you are successful, that how many patients will come back based on SMS or email, how many response.
I think basically, the thing is that, Lalit, I think it's basically apart from that, I think most important is how much we are able to, educate them and convince them that, it is, see, here I also have dropouts. But basically, we need to how to convince them that, look here, this is necessary, and if you don't do it, then, your disease may worsen and you may lose whatever vision. Because I tell them that if you lose vision, we can treat the disease, but the vision will not come back to your previous level. So
the other question was related to your, you made a statement about toleration of fluid. Intraretinal fluid versus subretinal fluid in ARMD. Out of the 4 or 5 things which we all teach everybody, that visual acuity drop or appearance of new fluid, appearance of hemorrhage or symptom, what to you is the most disturbing feature? Is the OCT signs more disturbing? Visual acuity, hemorrhage? What disturbs you more in the presence of in this follow-up?
I think
the combination.
Yeah, in the follow-up, I think the worst combination is the presence of PED with intraretinal fluid. Presence of pigment epithelial detachment with intraretinal fluid. Because once the intraretinal fluid is there, then vision has already, it will drop, especially if it is subfoveal. So presence of PED along with, because PED also, if you see, actually my concept is that the geographical atrophy is more related to the fibrovascular PED.
Yeah.
So patients who have fibrovascular PED are more prone for GA over a period of time because that membrane shrinks and there is an atrophic patch there. So for PED along with IRF are the two, I think, dangerous alarming signs in patients.
So Mahesh and
yeah, sir, one question. Actually, suppose you have a fresh AMD, the patient had 2-3 weeks back one cardiac event.
Yeah.
It is not DME or CRVO. Recently I had one patient. So what should we do? This is one thing. Recent major cardiac event, like a patient had angioplasty, all this stuff. So
the thing is, in such a situation, basically there are 2 things. One is it a one-eyed patient or is it a patient where the other eye is having normal vision? And is it a type 1 neovascular network or is it a type 2 or type 3 neovascular? If it is a type 1 neovascular network, I think even if it is a one-eyed patient, I may tell him you just come after 1 month, we will see. Because I know that in a type 1, within 1 month, 2 months, it's not going to progress at all. So the issue arises only with a type 2 and type 3 neovascular network. And if it is type 2 or type 3 and it's one-eyed patient, then I'll give a letter to the cardiologist and ask them whether it is safe to give an injection. So on based on that, we will take a call. But basically, so we need to look at the morphology of the membrane and also the type of the patient. And if the morphology is favorable morphology, I think we should not be bothered. We can call the patient after 4-6 weeks and wait for that interim period of 2 to 3 months and call him once or twice in the middle to make sure that that's a question of giving confidence to the patient.
Mahesh, what did you do? What did you do with the patient? You said you saw this recently.
Yeah, actually, I advised aflibercept after 2 weeks. I gave a letter to the physician, cardiologist, just for completion of medical legal this thing.
Do you ever consider first-line PDT then resurgence?
Not very confident in cases where there is fresh hemorrhage and it is like this. I think this was a type 2 only. So I can't wait too much.
On a low dose kind of Lucentis.
Sir, I want to say that aflibercept in protocol T, aflibercept had aflibercept versus ranibizumab in terms of thromboembolic effects.
Yeah.
There was a 4-time higher incidence of thromboembolic events with ranibizumab as compared to aflibercept. So that I think is a little more safer in this particular regard. And to what Dr. Giridhar was telling, I will also add the activity. If it is not very active, definitely type 2 intraretinal fluid, these are all more activity, as sir said. And so in those cases, we may consider doing early, whereas if it is only a PED with some subretinal fluid, little subretinal fluid, we may wait.
Yeah.
Yes.
Okay. Right.
Can I ask a question to Dr. Giridhar?
Yeah.
So, regarding PCV, there's no doubt that aflibercept is the first choice of injection. When it comes to AMD, especially the second case which you showed, you started off with ranibizumab, then used bevacizumab, then switched to aflibercept, and you got good results. When you switched back to ranibizumab, again fluid reappeared.
Yeah.
So, is aflibercept always the first choice of injection in a case where there is no financial constraint?
Yeah, I think so. I think today, aflibercept may be a good choice. I mean, in most patients with wet AMD, probably the patient can afford and he is ready to get into the particular scheme that we have without any, I mean, what do you call, proprietary interest. Probably aflibercept may be a good choice in most of the cases of both neovascular AMD and PCV to start patients on treatment.
I think I agree with Giri, because now that the aflibercept from economic point of view also, you see, when it was costing us nearly 65,000 rupees, then my usage of aflibercept was around 20% to begin with. Now to begin with, it has crossed 50, 60%.
Yeah.
Because of the economic reasons also.
See, as far as the second case is concerned, I feel that I would have, started him on aflibercept today, because this is 2011. So at that time, we didn't have all this. So today, if this patient had come as a treatment name, 100%, I would have started him on aflibercept, because it's a type 1 neovascular network. They respond very well to aflibercept.
Yeah, Malika?
There are two things. One, for PCV, I think we should not be spending any time on bevacizumab or ranibizumab if there is a possibility at all.
Yeah.
As for AMD, I don't think that we really have to think of aflibercept every case when we start, because there are many who, even with 1 or 2 injections, have a good response for 4 months, 5 months. So there, possibly we could give them the economic benefit of using other drugs. So these are the 2 points.
No, forget economy. Now that aflibercept is in fact cheaper than Lucentis today. You see today, because of that scheme, what they are giving us.
Not across India, sir.
So even with the scheme,
yeah.
Even with the scheme, initially you pay double the amount initially. Then the second one becomes okay, but the second one may not be required. In many of these patients, we see that with 1 injection, there is a long respite. And then you may give another one after 3 months or 4 months or 5 months.
No, that second injection, as far as the scheme is concerned, you don't have to do it immediately. It can be done much later.
Initial investment was double.
No, I mean, these are, Malika, I agree with you. I mean, these are basically, I always tell in any presentation that Lalit will also agree. It's like, treating a patient with diabetes. Now, you've got a whole lot of oral anti-diabetics. Now, one person may say it's like a phaco nucleus chop. One fellow will say, I do like this. Other person says, I will do like. So it's like that. So basically, these are individual choices. But probably what we are looking at it today is that how we can reduce number of visits in patients. So from that point of view, probably aflibercept stands a little better chance because it has got a longer period of action.
No,
so basically, from that point of view, especially now, with these difficult times, basically.
I'm not denying, no, that is not denied. That is not denied at all. But what I'm saying is, in a given patient, it's possible that Lucentis or ranibizumab would work well also.
Agree with you. Yeah.
Okay, I think with this, we will move on. We'll move on to.
Thank you, sir. Thank you.
Thank you, Giri. Thanks a lot. We'll move on. We'll keep asking questions to all the panelists in between also. But our prime job is to finish these presentations also. So we have with us Gopal Pillai. He will tell us about the paradigms in DME.
Yeah, thank you very much, sir. I would be talking on the current trends in the treatment of diabetic macular edema. The outline of this talk would be what did we learn new and what are the key treatment options, what are the current preferred approach, some illustrative cases and pitfalls in practice and initial dialogue, how to keep him motivated, and then conclusion. We know that good, tight metabolic control is very important in the management of diabetic macular edema. We have laser, we have anti-VEGFs, we have steroids, and in some cases where there is a tractional diabetic macular edema, and for some recalcitrant DMEs, there is vitreous surgery. So this is an outline of the different treatments available: laser, steroid. You can see the evidences from which it came from: anti-VEGF and vitrectomy. Now, laser photocoagulation for DME was the standard treatment before 2005, and it helps to slow fluid leakage and reduce the amount of fluid. And the aim of treatment was basically to stabilize and prevent further vision loss. These are, age-old slides. Dr. Lalit's patient, I had taken these pictures. Focal leakage, focal laser, post-focal laser, do a repeat angiography in the pre-OCT era. Now, this is a diffuse leakage, diffuse grid laser, and angiography later to see that the leakages have reduced. There was no OCT at that point of time, but there were a lot of limitations to laser treatment. It does not eliminate the possibility of further vision loss. And usually you do not continue doing laser again and again every 2 months, 3 months. So we do once in 6 months, maybe once in, like that only we will do. An improvement in visual acuity was fairly uncommon in that time. And complications when you are coming closer to the fovea, including permanent damage, scar extension, moving on to the fovea, were also there. And cases like this, where there's a massive edema in the center with a lot of hard exudates, it was not possible to do laser to improve vision at all. So came injections, and there was a lot of scientific evidence. And I think Dr. Ravi will be talking about scientific evidence versus real-time evidence. So I'll just touch upon few trials. RISE and RIDE were the monotherapy for ranibizumab, and that showed that there was a significant improvement, like 40 to 45% patients gaining 15 letters in the RISE and the RIDE trials. And the Diabetic Retinopathy Clinical Research Network, the protocol I, told us that the prompt laser versus a deferred laser, the deferred laser arm had maximum improvement in visual acuity. This also told us that the number of injections needed in the first year was about 9 injections. And even though triamcinolone initially showed good response, over the next year, actually it reduced vision, probably because of cataract generation. And then came steroids like Ozurdex and Iluvien. The MEET study was there. You can see that again, 15 letter increase was seen in about 20% of patients and significant reduction of edema. And Placid trial. So then came protocol T, where they calculated the differences between aflibercept, ranibizumab, and bevacizumab, and actually found out that aflibercept and ranibizumab was cluttered together without any statistical difference between them, but it was much better than bevacizumab. Now, when you looked at patients with good visual acuity, actually it wouldn't make huge difference. But in patients with poorer visual acuity, the difference between ranibizumab and aflibercept was also better in the first year. But that significant difference of about 4 to 5 letters reduced by the second year. So how do you now treat diabetic macular edema? After an assessment, if we find that it's a mild to moderate macular edema, especially non-center involving macular edema, then we can consider focal laser treatment to the microaneurysms involved. And if it is moderate to severe with center involvement with very good visual acuity, like 6x6 or 6x6 parts, patient is asymptomatic, then probably you can consider observation. Or if there is a microaneurysm which is responsible for the hard exudates around the fovea, then you could consider a focal laser. If vision is below 6/9, and then you can start on anti-VEGF therapy, and that is how we manage this patient. Now, anti-VEGF therapy, usually what we do is we will assess at 1 month, 2 months, 3 months, and see how the response is. Neil Bressler says that we should wait for 6 months for a response or no response, but generally in our patients it becomes very difficult. After 2 or 3 injections, we have to decide about response or non-response, decide about switching the injection or moving to steroids or something like that. Now, my protocol would be, if there is a center involvement with vision affected, I would basically tell the patient that metabolic control is very, very important. Get his hemoglobin A1C, send him to a physician, get the blood sugars and cholesterol and hypertension under control, and usually start an anti-VEGF therapy, ranibizumab versus aflibercept, or bevacizumab in economized situation. And then we will do monthly retreatments till edema comes below 300 microns or vision better than 6/9 or 6/6 or equal to 6/6. And once edema disappear, then we can consider OCT monthly and slowly reduce the frequency of visits. If it recurs, probably we will have to repeat injections or laser. And if number of injections increase, patient fatigue, poor response, then you can think about switching from one drug to the other or to steroids. If there is a very recent heart attack, stroke, thromboembolic disease, then I may consider Ozurdex as the first choice, especially in pseudophakic patients. And in Ozurdex, I consider PRN from the start and try to reduce steroid to 4 to 6 monthly and add anti-VEGF to basically increase the duration of Ozurdex. If there is an increasing IOP and cataract, may require anti-glaucoma medications or trabeculectomy, phaco, etc. And Ozurdex will be required before a cataract surgery. If tractional component, definitely consider vitrectomy. Let's go to some illustrative cases. Here is a patient where vision is 6/6. There's a hard exudate clump, which is as a result of microaneurysms here. This is away from the fovea. You could consider a focal laser, and you can see that the hard exudates have completely resolved, and hard exudates don't progress onto the macula. Now, ETDRS holds good when CSME involves thickening and hard exudates away from the fovea and focal macular laser to leaking microaneurysms. If hard exudates are there right in the center, like this particular patient with 6/12 vision, you consider repeat injections, and after 4 or 5 injections, you can see that the hard exudate has dissolved and the vision has improved to 6/6. If there are central hard exudates and it's a start, systemic control and intravitreal injections can benefit the patient in the early phases, definitely. More severe macular edema with 6/18 vision, these are all long-term follow-ups or 4 or 5 years. And you can see that slowly with injections, like this was the patient's initial OCT, later on moving to something like this after 4 or 5 injections. And then over the year, you can see that the edema reduced, but we had to use an Ozurdex. He developed a cataract. Then, after cataract surgery, it became much better. So in a center involving macular edema, we should understand that the DRCR.net protocol I had a median of 9 injections in the first year, 4 in the second year, and 2 in the third year. So you must upfront tell the patient that the number of injections that you require in the first year may be significantly high. This is a patient in whom again we have a 10-year follow-up. So this is the initial part of it, which is not significant. Then hard exudates developed, and at this point of time, when the patient was on 18 or 19 anti-VEGF injections, we shifted to Ozurdex, and suddenly this significant hard exudate reduction occurs. So there are some patients in whom steroids has a definite role. If one anti-VEGF fails, then probably you can switch to another anti-VEGF and also to dexamethasone long-acting implants. And in some patients, definitely it will benefit. Now, this is another patient in which there is bilateral diabetic macular edema of equal magnitude to 6/18, 6/24 vision. This is a patient in whom I may consider anti-VEGF in one eye. See, you can also consider simultaneous or the same day anti-VEGF in both eyes, which I do not do. You can do sequential anti-VEGF, one eye followed by the next week you can do anti-VEGF, which means the number of visits for the patient increase. And I consider one eye anti-VEGF and the other eye steroids and see which eye is doing better as far as the patient is concerned. You can see that both eyes responded. And in bilateral CSMEs, we can plan for anti-VEGF monthly in one eye and long-acting dex implant in the other eye, and look which of these is more effective, and as per patient preference, we can move. Cataract with diabetic macular edema is one topic which we are covering. So we have to basically make sure, like this patient after cataract surgery went in for a bleed. So we have to make sure that it is a stable diabetic retinopathy before doing cataract surgery. A fluorescent can tell us how much is the ischemia and the severity of diabetic retinopathy also. Not just the macula, but the peripheral retina also needs to be looked at. An injection prior to cataract surgery in these severe non-proliferative or very severe non-proliferatives or early PDRs can help in select situations. If you look at the costing, like if you look at each of these strategies, like Rice and Wright strategies, 14 letters, 12 injections in a year, costs in Kerala about 3.5 lakhs. Whereas these are the different letter gains and the number of injections per year that is required and the cost. So that is something that we have to always keep in mind. The patient wants to know whether he will improve in vision. Is there any chance of deterioration? How many injections are needed? Which injection to take? Are there any side effects? I had a stroke or heart attack. And if I'm not improving, why? And what should I do? And all these questions should be addressed. And the pitfalls are basically poor diabetic control and economics of injections. Many patients won't be able to afford the injections, or they may not have somebody to bring them, like no bystanders, mental fatigue. So it is always important to counsel and educate the patient and family in the initial dialogue itself with DME booklets or a PPT, that you have to explain about long-term treatment. You can't just say that we will do one injection and see. No, you should look at 3 years, 4 years and talk to him. What did the protocol I said, 9, 4, 2 in each of these years? We have to have multi-pronged approach with long-term prognosis with and without treatment. And we have to also discuss, we have to make the patient understand regarding diabetic control of hypertension, quit smoking, and regular eye checkups. And we have to keep him motivated. So if the patient, if with injection, the edema is coming down, the OCT shows reduction in edema, he gets motivated. Vision is improving, he's motivated. Especially in the first 6 months to 1 year, patient is very motivated if the results are good. And then by that 6 months, you should educate the patient regarding further treatment and reducing the follow-up frequency slowly and reducing the number of injections and changing to long-acting injections, etc. To summary, first choice in anti-VEGF is anti-VEGF, definitely ranibizumab or aflibercept. And in poorer vision patients, consider aflibercept. When an alternative in cases of pseudophakic patients, in cases of patients with recent heart attack or thromboembolic events, Ozurdex, non-approved were aflibercept and Avastin. And how often, how much, etc. would be there. And responder versus non-responder, we have to make up based on his response over the 3 months or 4 months and decide on that. Future directions would be which patients can we predict a steroid would be better, which patients brolucizumab may come in. So all those things are future directions which we'll do. To conclude, intravitreal injections are the mainstay. Multiple injections are needed. We have to tell this patient straight away. And systemic control, continuous follow-ups and decision making and dialogue in each visit is important, and may need to change the drug or add laser to the same and look for alternate diagnosis and development of tractional component. Thank you very much.
Thank you, Gopal, for very nice and sweet and adhere to time also. You see 942 rule, you talk to the patient?
Yes, sir. In AMD, I talk about the 7-up study. And in DME, I talk about the protocol IA for 5 years on my initial dialogue to the patient. That makes the patient aware that we are not looking at 2 injections, 3 injections. We are looking at treating you for the next 5 years.
You see, in this country, last 4 slides, what you showed that have a dialogue, keep him motivated and whatever. In this country, believe me, patient goes by what doctors tells you. Even if I am a patient and Gopal Pillai is my treating physician, so I tell Gopal, tum batao kya karna hai. So patient goes by what you tell. So you have to be yourself convinced and motivated more than the patient. So if it is your gut feeling that what you tell the patient, where you take aflibercept, you take Ozurdex, you will be better off than if you take, say, Avastin or this thing. So what I want to know from you is, what do you tell the patient? In the first patient is presented to you for the first time, forget he is about to become pseudophakic, or all these patients ultimately become pseudophakic because the age group is around 50s only, most of the NIDDMs. So your first dialogue is what? Patient will ask you, Dr. Sahab, meri nazar kam hai. What do you advise? Kitne injection? So what is the first response?
Yeah, so sir, first of all, I would prefer an anti-VEGF to start with.
What you tell to the patient?
Yeah, I will prefer an anti-VEGF to start with. And we need to also talk about economics to the patient and how much he can afford. For a patient who cannot afford the aflibercept, there is no point in talking a lot about aflibercept. And that is something that you can discuss with the patient and find out. And at least 1 year of treatment, what it entails and how much visual acuity can improve is something that I discuss.
Affordability economics has been exploited unnecessarily. Because if you give vision to the patient, patient becomes your slave, in fact.
Yeah.
If you give something to the patient, if patient gains something out of treatment, he will stick to you. Like you have shown your patients following up with you for 9-10 years because they improved under your treatment. If patient improves, believe me, he will be your patient from Delhi to Cochin also.
Yeah.
So that is the issue.
Yes. One question, Gopal. We see a lot of medical retina people treating after 1 or 2 injections. They will get fed up. Patient will get fed up. They will not be motivated. So can you tell the few conditions where you will not give injection initially? Because we see a lot of people giving in PDRs and unnecessarily. Can you tell few conditions where you should not get injection? You should not give injection initially.
Okay, so if the vision is very good, patient is completely asymptomatic, then I may not consider treatment initially. Like vision is 6/6, patient is completely asymptomatic. There are 1 or 2 hard exudate spots near the macula. There is mild edema, maybe about 300, 310. I may not consider an injection. Number 2, if the patient has come recently after an injection and edema is completely normal, vision is 6/12, but edema is not there, OCT, no edema, no treatment. Number 3, if there is a hard exudate plaque clump in the center, and vision is like 2/60. The clump is significant and there is no significant sensory neural detachment again on either side, then may not consider treatment. Number 4, if there is visible traction with reasonably good vision with a little bit of edema, this is a patient who is a time bomb. If you inject, that traction is going to progress, and we are going to have a problem in our hands. Sir, I think we have Dr. Dinesh Talwar coming to us with an entire session on discussion and dialogue with the patient. So
definitely we can hold on.
Yeah.
So I think let's move on. Compared to ARMD, DME is not such a bad disease. The load of VEGF inside the eye is not so bad. Even if you defer for a couple of weeks or months, you see same question which Mahesh had asked to Giri, that if patient has CVA, here we have option of steroids also, even if we wait for some time, is
nothing will happen. Correct.
excusable kind of disease compared to ARMD. So I think if Thomas and Mahesh agree, we can move on to
the next topic.
Diabetic topic. We can take question later on also, because in PDR also everybody is pushing. You see, till a couple of years back, we thought that laser is PD in PDR, but now anti-VEGFs also are penetrating inside PDR. So let's hear from Rajesh. So when and why does he use anti-VEGF in PDR? Over to you, Rajesh.
Thank you, sir. So I'll be talking about the role of anti-VEGF in PDR. I would like to tell at the beginning that I don't have any clinical photographs, just like Dr. Gopal and Dr. Giridhar showed, because I hardly do anti-VEGF as the primary treatment in my patients with PDR. What we know is that VEGF is what that drives PDR. If you look at the level of VEGF in the vitreous of these patients with PDR, what you see is that the level of this VEGF is many times more than what we see in a normal patient. So the current gold standard of treatment for PDR is PRP. It's a destructive treatment, so it leads to loss of peripheral field of vision. It can also cause decrease in contrast sensitivity, and since the rods are damaged, the patient can have impaired night vision. But one of the most important side effects of PRP is that it leads to development of macular edema in an eye where there is no macular edema at the beginning, and it can also lead to a worsening of macular edema in a patient who is already having a diabetic macular edema. So there have been various trials which have looked at the role of anti-VEGF in PDR. The first was the Protocol S from drca.net, which is a 5-year-long trial. And then the second was the Clarity trial. The Protocol S, it came out with a report at the end of 2 years. The Protocol S actually compared ranibizumab with pan-retinal photocoagulation as the treatment for proliferative diabetic retinopathy. So the questions that Protocol S tried to answer were: is visual acuity achieved using ranibizumab for PDR? Is it worse than that achieved with PRP at the end of 2 years? It also looked at other questions like whether ranibizumab offered any advantage over PRP as far as the peripheral vision, macular edema, and the incidence of or need for vitrectomy is concerned. So the primary visual outcome they looked at was the mean change in visual acuity, and it was observed that the patients who received ranibizumab, they had a 2.8 letters improvement in vision compared to 0.2 letters. And this proved that ranibizumab was non-inferior to PRP as far as the mean change in visual acuity was concerned. They also looked at the proportion of the eyes which developed center involving diabetic macular edema. 28% of the patients in the PRP group who had no macular edema at the beginning, they went on to develop macular edema at the end of 2 years. Whereas this incidence of macular edema at the end of 2 years in patients who were receiving ranibizumab was only 9%. The peripheral visual fields were assessed with the help of Humphrey Visual Field 30-2 and 60-4 program. And as expected, PRP patients had much drop in the peripheral retinal sensitivity, leading to loss of peripheral visual field compared to the ranibizumab group. The complications of PDR, like development of retinal detachment, neovascular glaucoma, iris neovascularization, and vitreous hemorrhage, it was almost equal in both the groups. But what was more important was that the need for vitrectomy was significantly low in patients who received ranibizumab injection. So to conclude from Protocol S, we could understand that among eyes with PDR, treatment with resulted in visual acuity that was not inferior to PRP at the end of 2 years. It also showed that there is less visual field loss in patients who receive ranibizumab, and fewer eyes of the patients who received ranibizumab had diabetic macular edema at the end of 2 years, and only few eyes required vitrectomy at the end of the 2 years when they were on ranibizumab. The Clarity study was the other trial. It was again a non-inferiority trial which compared aflibercept with the pan-retinal photocoagulation. It is a 1-year-long trial, and it had an extensive exclusion criteria. One of the important exclusion criteria was the presence of fibrovascular proliferation or tractional retinal. Important from the clinical perspective that if the patient is having such findings in the posterior pole, you should not be treating the patient with anti-VEGF injections, because that patient may progress to develop a macular detachment involving the tractional detachment involving the macula. So just like in protocol, yes, the primary outcome was a change in best corrected visual acuity. And here it was at 52 weeks. And they noticed that aflibercept showed a significant improvement in visual acuity compared to the PRP, and it was superior, in fact, compared to PRP. Then there were other secondary outcomes that were looked at, like a gain or a loss of more than 10 liters. This was also in favor of aflibercept compared to PRP. The disease regression patterns, looking at that, the proportion of patients who had a complete regression of neovascularization was around 64% in the patients who received aflibercept injection compared to 34% in the PRP. Another interesting finding that you can see is that the patients who were treated with PRP, 44% had a partial regression and only 34% had a total regression. And looking at the presence of macular edema, treated with aflibercept had less chance of edema at the end of the trial. The incidence of vitreous hemorrhage and the requirement of vitrectomy was also low in the aflibercept arm. Now coming to the protocol is 5-year outcomes. So what is important is that only 60% of the participants who completed the first 2 years completed the 5-year visit. So this could be having some implication on the final results that we see at the end of the 5 years. So mean change in visual acuity, what is interesting is that the benefit that we observed at the end of 2 years in favor of ranibizumab was not there at the end of 5 years. So there was hardly much difference between the mean change in visual acuity between the two groups at the end of 5 years. And another interesting finding was that even those patients who received ranibizumab, they had a peripheral visual field loss, although not to the extent as seen in pan-retinal photocoagulation. So this could be due to the natural progression of the disease leading to damage of the retinal cells in the periphery that is leading to the loss of peripheral visual field. So even if you treat the patients with ranibizumab over a long period of time, the benefit of preserving the peripheral visual field is not there, but it may not be to such a bad extent as in pan-retinal photocoagulation. Then the probability of developing diabetic macular edema at the years was more in PRP compared to the ranibizumab injection at the end of 5 years. Diabetic retinopathy related adverse events, all the complications like detachment in both the groups. And another we see is that at the end of 2 years, the patients who received ranibizumab had less need for vitrectomy, but at the end of 5 years, there was hardly much difference between the two groups as far as the requirement for vitrectomy was concerned. So to conclude, severe visual loss or serious PDR complications were uncommon in either groups. Ranibizumab group had a lower rate of developing vision impairing diabetic macular edema and less visual field loss. So we can use either ranibizumab or PRP in patients with PDR. But the only point that should be ensured is that the patient will be compliant and the patient will be able to afford the cost of the treatment. And another debate that is going on is whether anti-VEGF injections have any role in the management of vitreous hemorrhage related to diabetic retinopathy. There are very many short-term studies as well as long-term studies which have said that if you inject the patients with intravitreal anti-VEGF agents, it leads to resolution of hemorrhage, sometimes as early as 3 months after the first injection. Sometimes this can be seen even in 1 to 2 weeks after the injection. And these studies say that it in fact reduces the incidence of vitrectomy in these patients. So DRCR.net actually conducted a RCT comparing the role of intravitreal ranibizumab with intravitreal saline for vitreous hemorrhage. The reason why they use intravitreal saline was that some of the studies where they used just intravitreal saline, it was observed that there was a resolution of hemorrhage following saline injection. So it could be that the process of injection itself has a role in resolving the resolution of vitreous hemorrhage. So they had compared intravitreal ranibizumab with the saline, and at the end of 16 weeks, what they observed was that the rate of vitrectomy was equal in both the groups. So it did not reduce the chance of the need for vitrectomy when you give the patients intravitreal ranibizumab injection. But another interesting finding was that those patients who received ranibizumab had better visual acuity compared to those who received a saline injection. Then the patients who received ranibizumab, they had better resolution of hemorrhage, which helped in completing the PRP, and all these patients also had reduced recurrent vitreous hemorrhage rate. So it could be that it is working to a small extent. So the take-home message from the various trials is that PRP is a good treatment option in PDR in the long term. Anti-VEGF injections require strict patient compliance and more frequent visits. In patients with diabetic macular edema and PDR, treatment with anti-VEGF is a preferred option. A patient who has a requirement for good peripheral vision, you may consider anti-VEGF monotherapy, provided the patient is going to be compliant and the patient is going to afford the treatment. So anti-VEGF may or may not reduce the need for vitrectomy in patients with diabetic vitreous hemorrhage and may be used with caution after ruling out rational events. Anti-VEGF injection may help in resolution in hemorrhage in diabetic vitreous hemorrhage, and it might help in completing the PRP. So there are also other indications for anti-VEGF injections. It is used as an adjuvant before surgery to reduce intraoperative hemorrhage. It's usually given 2 to 3 days prior to the surgery. And it can also be used in patients with NVI and hence may be used for the treatment of NVG. Thank you.
Thank you, Rajesh, for sticking to your time again. You see, this topic is very sore actually to me. You see, like you said, 2 years versus 5 years in your protocol S. You see, believe me, very few diabetics live for 2 years. Most of them live for 5 years or more. So in any case, the protocol S goes for a 6. It does not, stands the test of time. Because if you have lasered a patient very well, you see, I will have follow-up of more than 20 years who is doing very, very well with PRP. And this statement, I also take with pinch of salt that anti-VEGF monotherapy in PDR could be considered, provided patient can follow up. Again, this does not, at least for me, this is a second line kind of treatment rather than first. The only place where I do consider anti-VEGFs in PDR is either as a form of combo treatment along with laser, when patient has multiple bleeds despite lasering, or if there are a couple of patients where there have been very angry looking fronts on the posterior pole involving the arcade and patient has good visual acuity. So these are the two situations where I do consider. So I'll have inputs from, say, Meena or Malika also, or maybe Mahesh can pitch in about this PDR patient being subjected to repeated injections without laser.
Okay.
I fully agree with you, sir. I also use only as an adjuvant, where we don't need surgery, but we have given already good laser or something like that, interim treatment. That is the only condition where I use.
There's a couple of patients where I have 2-3 photographs where fronts are very close on the arcade or very close to the macula, where laser will be detrimental. I have done one eye laser also, but laser will induce scarring. So those patients do maintain good visual acuity but there also I will start doing laser from the periphery. Yes. Yeah. Malika.
And even the saline probably is inducing PVD, resulting in improvement.
Yeah. I agree there is no comparison between laser and anti-VEGFs for proliferative retinopathy, because that's a disease which is going to get worse and cause blindness. So the seriousness is much more than AMD or DME. And so we have to see that even if the patient is not coming back, they are safe. And as you said, once the PRP is complete, they are safe for life. Very rarely after 20 years, they may develop a couple of more new vessels which require additional laser. But without, with just anti-VEGF, they are sitting on a time bomb.
Veena?
I too never give anti-VEGF as a standalone therapy for PDR. Usually given in combination with laser. And laser is still the gold standard for PDR treatment. And if I give an injection of anti-VEGF, I see to it that I can follow up the patient, especially if he has some amount of vascular proliferation, so that the patient do not develop a traction detachment. Some of these patients may not come back for follow-up and may end up in a tractional retinal detachment.
Yeah. Ravi, what do you do? US में क्या होता है?
Thank you, sir. I think, let me, can you guys hear me? So I agree with your point. I personally, especially with posterior pole neovascularization, I do use anti-VEGF. Sometimes you initiate PRP and the patient bleeds, and then they are frustrated. Oh, and everything was fine. They were seeing 20/20, and then you initiate PRP, and then they're a little bit frustrated, though their vision is down. So I kind of initiate the anti-VEGF treatment. I counsel them that, this is, sometimes what happens, you treat them and then they disappear, So I tell them, this is not the treatment. This is not the treatment. This is just to temporarily kind of stabilize your eye so that you don't bleed. And I kind of keep emphasizing that bleeding is bad for your eyes. So, for posterior pole, yes, I definitely do, anti-VEGF, and then I bring them back within a week to 10 days to initiate the PRP. And then I do a block, and I kind of complete good PRP within one setting, especially in patients whom I suspect that follow-up is going to be an issue. I do kind of use that approach.
Or sometimes,
and of course,
sometimes I hope vision should fall down first. Then only patient, if the vision falls down, then it's better for us.
That's true.
Chirian, any comment? We move on.
As Professor Lalit said, and as Dr. Mallika had said, we have been observing cases of PDR who has undergone PRP for 15, 20 years follow-up, no further aggravation of PDR, no fresh traction, no fresh neovascularization. Not only that, there is not even a DME developing in these patients because the VEGF load has been significantly taken care of with the PRP. So the issue is when you are in the process of completing your PRP, maybe you'll complete your PRP in a few sittings. In that process, maybe you'll get a DME developing in between. For that, your anti-VEGF might help. Not after the PRP has completed and the patient has settled down. So PRP is the treatment for PDR, and anti-VEGF and adjuvant in the process during the time of completion of PRP. That's all.
So this dialogue is very important, that in the process, you may give 1 or 2 injections for development of DME. That's okay. Yes, Gopal.
Sir, I want to bring it to your perspective that we are all seeing 15 years, 20 years post PRP. Yeah. These are the patients who are really doing well. The other patients underwent vitrectomy. So based on one group of patients who are doing well, we cannot basically say that PRP is a panacea. So it depends upon when we start PRP in a patient. If we start doing panretinal photocoagulation early in the course of proliferative diabetic retinopathy, yes, the results are really good. But if the proliferative diabetic retinopathy is a little more advanced and you start laser treatment, like Dr. Ravi said, we have a lot of possibility that a 6x6 patient may develop a bleed and become frustrated and basically create a lot of issues. So that is a point of time when there is a moderate proliferative diabetic retinopathy without a lot of visible traction in the macular region. Like if there is a visible traction, then we are pushing him for a surgery. So when there is moderate proliferative diabetic retinopathy without visible traction, I may consider starting the patient with an anti-VEGF injection, following with a laser. Monotherapy is out of the box.
Correct.
Not
so
done.
Here also in situation number 2, what you said is agreeable. You can start with anti-VEGF, but you can't continue. Ultimately,
absolutely not.
Ultimately, you have to depend on laser only.
Yeah.
So I think we'll move on. If
Chaitra wanted to say. Meena madam also wanted to say something.
Yes, Chaitra.
I just wanted to add one point, sir. Of late, a lot of physicians and medical, professionals are asking for the option of anti-VEGF rather than PRP, because I think it's not only doctors. I think a couple of professionals like pilots also are a little worried about the compromise of the visual field. So I think, like you mentioned, for a time period till probably when the visual field is important, anti-VEGF should work, then subsequently PRP. So this is, I think, one major issue with physicians asking.
Pilot, you should not risk. Pilot को नौकरी से निकाल देना चाहिए, because you see, you may develop a blink. No, I will not. You see, if he has high risk PDR, if he has a mild PDR, it's okay. But if it's a high risk PDR, all pilots, you should talk to boss of the pilot, that ask him that he is sitting on a bomb, as Malika said. So usko to, I don't think so we should risk that. He should be given only anti-VEGF and we can consider. So this is not a practical advice from my point of view. You see, Chidin said very nicely, in process you can do it.
Yes.
But
as a temporary,
as a mainstay of treatment, because pilot job is not temporary, na, because he may be flying from Delhi to New York, and kuch ho gaya to all 700 people are at stake. Yes, Ellen.
Yeah, just referring to the situation which Gopal was saying, moderate PDRs.
Yeah.
What is the view of the panel of doing early vitrectomy in such cases, particularly as Malika or Chaitra said, in professionals who have moderate to severe PDRs which have not been treated. So I think there is
bled also
about early vitrectomy.
Depends on the frequency of hemorrhage and the visual acuity. Two things are important. Yes, Deepu, Dipender.
In our practice, the patients who bleed, they do better than patients who do not bleed.
Yeah.
So I'll tend to operate a patient with traction, which is threatening macula and has never bled. These are the patients who go into fibrotic diabetic TRDs. Bleeding patients, normally they have some partial PVD, and most of them, they do better. This is my observation, but limited experience, I think. This is what I wanted to add.
Not bled. Deepu, if it is not bled, agar bleeding nahi hua hai.
Yeah. And you have a treatment naive PDR and traction, which is now encroaching to fovea, and you can scan OCT, and he may be just 6/9, but there are neovascular complexes which are right at the posterior pole. These are the patients, younger patients, they do better with primary surgery. And then you use anti-VEGF as a adjuvant, not the monotherapy.
Even when you do a vitrectomy, you would like to do a good PRP before you do a vitrectomy.
Endo-PRP. We do it intraoperatively.
PRP, or even a day or two before the surgery, because sometimes they start bleeding during surgery. You may not get the chance to do endo-PRP, and you may end up with NVG. So
that's the reason we give pre-operative anti-VEGF. And PRP will take 6 weeks. It will do it same job in 48 hours.
Yes.
Okay, I think with this very good discussion we have had on diabetic retinopathy, we move on to another complex disorder, which is RVOs. And we have with us Dr. Meena to tell us about the treatment paradigms for various classes of RVOs, BRVO, CRVO, small vessel block, and everything. I think, Meena, over to you.
Is my screen visible now?
Yeah, you're visible.
Screen is still not visible.
It is not visible, Dr.
Yeah, it
Meena
is visible now. Yeah. It is visible, ma'am.
It did come for some time.
Your presentation open on the desktop, Meena?
Yeah.
Is it open or is it closed?
Madam, can you once again, share screen?
Let's start with the next presentation. Actually, it has gone back to the main keynote thing. So let Ali present. I'll come up with my presentation after that.
Okay, I think we can now have LA.
Sure.
LA, are you there?
Yes, sir. Yes, sir.
Yeah. So you can start sharing, and LA will tell us about paradigms in ROP, because this is again another controversial issue. And LA will, I think, rub in on us that why does he prefer anti-VEGF?
Thank you, sir, and thank you, Gopal and KSOS, for this opportunity to speak on one of the topics which is very close to my heart, anti-VEGFs in ROP. So the flow of my presentation would be the indications, then the safety issues, which we are all very concerned about, the follow-up issues, again, major issues, the complications or recurrences, and then I would just sum it up with the current guidelines or recommendations of how you would use the anti-VEGFs. So my journey in using anti-VEGF started way back in November 2006, and this is actually the first case where the anti-VEGF in ROP was used in India, a 27-week-old baby of IVF pregnancy, 44-year-old parents. And when I went for the screening, you can see these are the pictures taken from just the indirect. It was persistent tunica vasculosa lentis with a rush disease. You can see the red margin and pupil not dilating. And we discussed these issues because just 1 month prior to this baby, I think it was the first time presented at the retina subspecialty meet. So we opted to give injection to this baby. And to our surprise, just third day post Avastin, the tunica vasculosa actually disappeared. You can see a few strands remaining, but the pupil started dilating well. And then we were able to do very good laser. And this is how the baby is today, doing very well with the scar encroaching on the macula in the left eye and has 618, while the right eye has 6/6 vision. So slowly we started using this more and more, and this gave us confidence in using this as a primary therapy, even as a monotherapy. And just to show you a representative case again, this was a case of stage 3+ disease. Again, not very good dilating pupil because of the tunica vasculosa lentis. You can see the flat retinal neovascularization. And again, the dramatic response that we usually see with Avastin, with complete dissolvement of these retinal vascularization and progression of the vasculature into the peripheral zones. Most important indication which is now emerging, particularly in our countries, is the APROP. And I think now it is almost established that the anti-VEGF is the choice of primary therapy for these eyes. And you can see this child where the vasculature is hardly up to the macula. And you can imagine giving laser, which would destroy almost 90% of the retina. And again, here you can see how good the response usually is. And within 2 weeks, you can see the plus disease resolved and the vasculature is going. But you can see still it's just 2 weeks down the line and there is a lot of peripheral vascularity. So you need to follow up these patients, particularly of APROP. Another variety which has been described by Dr. Dogra's group is the hybrid ROP, which is a combination of kind of a plus disease. And you can see this flat, dirty, white fibrous tissue. And these cases also respond extremely well to anti-VEGFs, and you can see how good the response is. And this tissue actually dissolves in front of your eyes. Another very, very important type of ROP which is emerging, what I think Anand likes to call is the half zone ROP, where you can see the vasculature is not even reaching the macula, it's just half zone. And there are looping of the vessels in the superior and the inferior aspects. And it is established that the choice of treatment, primary choice of treatment, again in these cases, is the anti-VEGFs. And you can see how good the response was in this baby post-injection. However, it's too early to stop the treatment because there is a large area of persistent avascularity. These children are usually very small babies and very born too soon babies, like 23 weekers or 24 weekers. And it's a very delicate balance of when to use the anti-VEGF injections because the vasculogenesis is still taking place. Again, a classical example of what we are calling half zone, and we are seeing more and more these cases of what we used to call as the oxygen-induced retinopathy. Now, this is becoming very common in the peripheral centers because the NICUs are increasing, but unfortunately, the oxygen is not being monitored, and most babies receive 100% pure oxygen. And this is what the oxygen-induced retinopathy looks like. There is only a peripapillary vasculature, nothing else. And it's impossible that you can treat this by laser. So you can see these babies, they respond very nicely, but majority of these babies, they need repeat treatments, either in the form of repeat injection, and most of these babies eventually will need a little top of laser in the extreme peripheral zone 3. But this was one of our cases where we treated with one injection, then actually the vascularity stopped at the anterior zone 2. And when we gave the second injection, and you can see here, the vascularity progressed almost up till one disc area up to the aura. So they responded very well only with primary monotherapy. And we all know that this became very established and controversial as well when the BEAT ROP study was first published in the New England Journal of Medicine. And actually after this publication, what it showed that the recurrence rate, particularly in the posterior zone 2 as well as the zone 1 disease, was significantly less as compared to those treated with laser. We all know there were fallacies with these studies, so I'm not going into the details. But what I defend is that even though they were fallacies, they actually represented the real life scenarios. Now, you see day in and day out babies being referred from the peripheral centers who have been treated by laser. And if you see the laser, it's actually a mockery. You have to be very, very strict in doing lasers for ROP without any escape areas. And we see a lot of babies whom have been treated by laser saying, laser has been done, now you forget about it. You know, you're okay with the rest of your life. And they come back to us with recurrences. And when we see there's hardly 40% of the area which has been lasered. And so probably this is the reason why these babies responded very well in the BEAT ROP study as compared to laser, because it was a multi-center trial and there was not a standardized laser therapy. This actually led to the American Academy of Pediatrics to come out with a recommendation saying that consideration may be given to the treatment of ROP with infants with zone 1 stage 3 plus ROP with intravitreal injection of bevacizumab. So even the AAP came out with a very strong statement in favor of primary therapy. And most recently, we all know the Rainbow trial, which is again one of the only multi-centered randomized trial which actually compares ranibizumab with laser. And here they compared two doses, that is the 0.1 and the 0.2 milligram of ranibizumab versus laser. And just showing the conclusions, what they mentioned that the treatment success rate of 80% was achieved with the 0.2 milligram versus 66% with laser. Though a statistical significant p-value was not achieved, they concluded that infants treated with the 0.2 milligram dose were twice likely to achieve success versus the laser group. Both the doses were tolerated well and the safety profile was very good. They also reported the pharmacokinetics and the systemic VEGF data, which did not show any alarming results. And most importantly, a 5-year extension study to show any long-term effects is still undergoing. The other advantage and situations where you have to use anti-VEGFs is particularly in very sick babies who are on ventilators or who cannot tolerate your laser, because laser is a long procedure lasting for anywhere between half an hour to 45 minutes. Then this is a very, very effective treatment. You can give the intravitreal injection right there in the NICU, even if the baby is ventilated. simply under topical anesthesia. So coming to what kind of drug, and as we have been discussing so far, there are various anti-VEGF drugs, of which bevacizumab, ranibizumab, aflibercept, these three are the commonest use. There are also published reports of the use of the cumbercept, which is the Chinese anti-VEGF, in the use of ROP. And most recently, we also have the biosimilars, which have also been used in ROP. However, I think the most important point when it comes to the topic of anti-VEGF ROP debated till today is the safety profile. And majority of the critics are just concerned about this issue. So let's look at the safety profile. And I think we should all read this paper, which is just recently published this month. It's a fantastic review article on an update on antivascular endothelial growth factor safety for ROP. And it beautifully refers to all the cases and the adverse events which have been published so far in the literature. Basically, majority of the users and the pediatricians as well, they are mainly concerned about the long-term systemic effects because of the systemic absorption of these drugs in an already unusual circumstance, which are the premature babies. And they include the neurodevelopmental delays, the thromboembolic events, the respiratory failure or infections, the hepatic dysfunctions, as well as the nephropathy. And isolated reports have been presented and published with each of these things. Also, there are some local ocular adverse events, which probably is related to the technique of intravitreal injection. But when it comes to ROP, many a times we see post-injection vascular sheathing, retinal pigment epithelium, as well as choroidal rupture. We see optic atrophy, choroidal ischemia, and most importantly, when it is not given in the right indication or when it is given late, then many cases we see what we call as the crunch phenomenon, where there is a sudden dragging and a development of the tractional retinal detachment, which was also seen when anti-VEGF was used in PDR cases in the wrong time. Also, recently with the use of the wild-field fluorescein angiography, abnormal vascular branching as well as shunt vessels have been reported with the use of anti-VEGFs. And refractive errors also have been mentioned with anti-VEGFs. It's a myth that only laser causes refractive error. We've seen cases having myopia as well as astigmatism, even with primary anti-VEGF therapy. I think the most important issue is the recurrence. Now, what is the definition of recurrence? I think that is very, very important. And most people believe that if there is an evidence of progression of the disease that requires the application of additional treatment, and that would include progression of the disease despite previous treatment, or the reappearance of the neovascularization, which could be a flat retinal neovascularization, or it could be a fibrovascular proliferation, and a reappearance of the plus disease. Recently, as I told you, with the use of the wide-field angiography, they have shown that leakage at the peripheral vascular avascular junction and persistent peripheral avascularity is also considered to be a recurrence. Basically, there are two types of recurrence, one which occurs at the initial ridge, and secondly, which occurs at the advancing edge of the retinal vascularization. And what has been documented in the literature, that the commonest reasons and the cases which would have recurrences are those associated with lower birth weight, extended duration of hospitalization, and of course, APROP, which is a very, very devastating disease. So just to show you an example, this is the case that I showed earlier of an APROP, and you can see how nicely it resolved the threshold disease. But this patient went on to have recurrence, and you can see what kind of, this is almost 4 weeks after the first injection. This is the junction of the initial ridge, and there is appearance of the flat retinal neovascularization. And you can see the vascularity which has progressed a little further anterior, and you can see small buds appearing at the advancing edge of these vascularity. We opted to give a second injection to this patient, and the patient has responded very well. If not, we could also add laser to the peripheral avascular retina at this stage. Now, these are the features that you see in angiography. This is the initial edge, and these are the advancing edge, and you can see the leakage at both the edges. You can see the arrest of the retinal vascularization with pruning of the vessels in the periphery. And lastly, you can see small budding flat retinal neovascularization at the advancing edge of the vessels. We are trying to study and develop an algorithm which of these patients are likely to develop more recurrence, and we are working with Harvard University and trying to do some artificial intelligence study, pre as well as post Avastin injections, and hopefully the initial pilot study have given us very good results. So we are now doing a larger study, and hopefully we can come to an algorithm which would predict which cases are likely to be developing recurrences and need close follow-ups. We are also interested in studying the long-term effects, and now we are into our 12 years of follow-up. So we routinely do structural measurements of OCT in all our treated eyes, and these are all OCTs of primary anti-VEGF babies. You can see hardly any abnormalities. Another interesting observation that we've seen is particularly in type 1 ROP eyes, many of these babies develop a localized PVD kind of a picture at the edge of the initial ridge. And these are the babies who do very well without the addition of laser. And once a localized PVD is seen, almost always the vascularity progresses beyond the ridge and goes right up to the aura. So this is a very good indicator of which of these cases will do very well and which of the cases would need extra treatments. We are also trying to study the effect of these drugs on the choroid, and we are doing detailed EDI studies, comparing them with the age-matched eyes. Another debatable area is the effect of refractive error with the use of anti-VEGFs. And most studies show that patients with zone 1 or zone 2 posterior ROP who have been treated with anti-VEGFs lower refractive error as compared to those treated with laser, which induces high myopia. And it is one of these reasons why majority of the experts recommend not doing individual treatments to two eyes, that is doing laser in one eye and doing only anti-VEGF in the other eye. They usually advocate doing similar treatments in both eyes, not to develop anisometropia. A very nice paper, again, recently published this month, where they've studied the foveal microvasculature, the refractive errors, the optical biometry, and their correlations in the school-age children which had undergone anti-VEGF or laser photocoagulation. And what they concluded is that the laser-treated eyes had significantly smaller FAZ. They had a higher fovea VD as well as the lower parafoveal VD in the superficial capillary as well as the deep capillary plexus. And the laser-treated eyes had significantly higher degree of myopia as compared to the anti-VEGF eyes. As regards to the optical biometry, the laser-treated eyes had significant steeper corneal curvature, a shallower anti-chamber depth, and a thicker lens, which would probably explain why they have higher myopias than the anti-VEGF eyes. Just yesterday, we presented for the first time in the world at the ASRS live meeting. We are now trying to study the effect of peripheral visual field loss in these eyes, and we've compared that in eyes who have received only anti-VEGF versus eyes who have received laser. And most of these eyes are with type 1 ROP, that is the AP-ROP or posterior zone 2 disease. And just to show you a representative case, this was the first case which I showed you. You can see the laser marks 12 years into follow-up. And when you see the visual field, it's shocking. The 30-2 field is almost totally wiped off. And even worse is the 60-4 fields. So this is what doing laser does to their peripheral visual fields. Now, as compared to that, this is the second patient that I showed you who did not receive laser, but had only primary anti-VEGF. And we are trying to do the wide field angiography also. And you can see this, there's no leakage, but it shows a very small area, temporal wedge kind of area, which is still avascular in the periphery in the right eye, but the left eye shows very good vascularization even up to the aura. And if you see the visual fields of this baby, 30-2 is very good, showing very, very minimal or absolutely no changes in the visual fields. So we are further going into the details of that, and hopefully this will give us a better understanding of what laser does to their peripheral visual fields. Now, as regards the dose, we are still confused. There are a lot of papers published. Most recently, again this month, there has been paper published saying that the dose as low as 0.004 of Avastin is equally effective as half the adult dose, particularly in a certain subset of patients. But again, another group have also recorded that probably these cases might end up having more recurrences. As far as ranibizumab is concerned, the Rainbow study showed us that 0.2 milligram is better than 0.1 milligram. We do not have many papers regarding aflibercept. However, most experts use half the adult dose. And again, biosimilars and combacept, they are still under consideration. So just to summarize, again, this is a very nice meta-analysis which has been recently published in the literature comparing anti-VEGF and lasers. I'm not going into the details, but there are advantages and disadvantages of both. I think the main issue here is to use anti-VEGF as primary therapy, particularly where it is indicated, and then back it up with laser. So today, my strategy is I use anti-VEGF as primary therapy in all cases of AP-ROP, posterior zone 1, half zone, or even type 1 ROP into zone 2 or zone 3, which has still flat neovascularization without a development of a ridge. And of course, sometimes we use it preoperatively when we are doing surgeries. What I do is I usually follow up these patients until the growth is beyond zone 2 anterior. And at that point, I decide whether to add laser or to still follow up. And that depends on various conditions, where the baby is from, how motivated the parents are to come for repeated follow-ups. I think the most important fact is this, that we have to emphasize that any treatment you do, whether laser or anti-VEGF, I think we need to have a communication with the pediatrician and neonatologist to correct the systemic factors and the nutrition of the baby, because these factors are very important in preventing the recurrences of the ROP disease. Again, follow-up is very, very essential, because with primary anti-VEGF, only 30 to 45% of the cases reach the aura. But I argue with people who are doing laser, because I tell all my patients, whether you receive laser or not, you have to come for a lifelong follow-up. It's a myth that when you give laser, you tell the patients that you are free. No, I think that's not true. We need to tell all our patients that all ROP, as a matter of fact, all premature babies need long-term eye follow-ups. As I told you, if a ridge is developing, straight away I add laser. And if there is a recurrence, I usually add one more injection. Again, just this was one of the cases that we saw during our lockdown. And you can see this case, you don't see any circulation at all. You can see hardly any vessels surrounding the disc. This was in the right eye, even the left eye, very, very narrowed, attenuated vasculature just in the peripapillary area. And difficult situation for us in the lockdown, and we gave an injection. You can see how nicely this has responded. The vasculature has now reached here, and a faint shallow ridge has started developing in anterior zone 2. This is the right eye, and again a similar very faint shallow ridge developing in the left eye. And this is just last week that we have followed up the baby, so we are going to continue to follow up and see how it progresses. We all know that documentation is very, very important in decision making, because you can go back, see your previous photos, and think over it. Expensive contact cameras, they are not in the reach of everybody. So we are working with a startup, and we've developed a very nice device. It's a handheld device where you can use your indirect lens and your phone, and you can capture these nice images. And there is a nice software, and it just costs about 10 to 11,000. It can be carried anywhere. And what we are trying to do is teach the nurses in the NICUs themselves to take these photographs. So again, this could be used for telemedicine as well. So just to summarize, I think anti-VEGFs have a very important role as a primary therapy, particularly in APROP and posterior zone diseases. You have to follow up these babies closely. It's your decision, and most likely you need to add it up with laser in a majority of the cases. Thank you very much for your patient hearing.
Thank you, LA, for throwing this clarity on this subject, because you know, we were always taught laser, laser, and laser in ROP, and injections that you have said have actually come. Obviously, you see, if the disease is posterior, you cannot do laser. You have to depend on anti-VEGFs. But you know, I have seen myself a turnaround by all the speakers of ROPs also. Initially, they were tilted always. LA is showing a smile because I have been in conversation with him for a very long time. You see, initially, we always used to have laser, laser, and laser. And all these people, you know, everybody used to talk, no, 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 injections, no, for these babies. But I remember LA, one of the first few Indians who started doing work on, and he has collaborated with not only abroad, but also Government of India, and his center is recognized as one of the. LA, can you tell something about that?
Yeah, we run a big ROP screening project along with the NRHM government of Gujarat, and we are doing this project entirely on charity basis. So we have trained our optometrists, so they visit NICUs, all the public NICUs in the entire central as well as northern district of Gujarat. So we are currently covering about 35 medical colleges and about 54 private NICUs. And we screen almost 200 eyes in a week. And we've started this project since 2012. So we've completed 8 years and we've treated 840 eyes so far. So essentially, you know, prevented blindness in 800.
I think this must be one of the largest projects in the country.
Well, I think Narayan Netrala is probably the largest now. Even Arvind has started in a very big way. Even Pune project is also very large. So, but it's still very large, and we are very happy that we are being supported by philanthropists. So the entire project runs on donations, and right from screening to treatment of all government colleges is done absolutely free of cost.
Shall I think this deserves a clap because you're doing so much of philanthropy at this age also. You see, I think you have rubbed it very clearly that APROP, hybrid ROP, when so it is posterior. And one thing which you said very clearly, but slightly hesitant, that anti-VEGF is about to become the choice. I think this is already a choice now. One or two questions on this before I ask any other member of the panel is it only anti-VEGF, or you sometimes add laser to these patients also? About these patients of tunica vasculolentis, APROP, hybrid ROP, and half-zone ROP, what you said. So in a two questions were there. One is how many injections, if at all? And second is, if you add laser, is it the usual laser or it's only the top-up kind of laser?
Okay, regarding the first question, I usually do not give more than 2 injections. So if there is a recurrence or persistent avascularity without the development of a ridge, I usually try to re-inject once. And if I don't find convincing results after my second injection, then I would straight away go into the laser. But in all other cases, even till today, except without when that develops a ridge, if you develop a ridge, then straight away I go into laser, because if you inject in a patient who is developing a ridge, they are likely to develop a tractional detachment. But if the retina is still very flat and if there is no vascularity, I still follow up them closely to see how far they develop the vascularity. And then, I mean, the whole point is try and reduce the amount of laser given into the periphery. So essentially in most of my babies, even if I need to add up laser, it's the standard ROP laser, but that is mostly only in zone 3. So you're essentially, lasering only a very small peripheral patch, and this probably will not affect the peripheral field.
I think any other panelist wants to make any comment? Malika, go. Yes, Natasha.
Yeah, I think just the take home from use of anti-VEGF in ROP should be that it is not the panacea that we thought it was in the beginning. Even anti-VEGF in ROP has its specific indications and should be used in those indications alone. And I find practically following up these babies once they are older and bigger is much more difficult. So my tendency is that once it reaches zone 2 anterior or close to zone 3, if there's any sign of recurrence, or sometimes if the follow-up is difficult, I give laser in that area so that it's easier to follow up these babies later. And second injections, I'm not comfortable repeating the injection. So if they don't respond to the first injection, I usually just supplement with laser.
Okay, I think Ali also rubbed this point very elegantly in his talk that when to add laser and number of injection. I think both of you have clarified. I think we still move on because we are running slightly late. Meena, are you ready for the RVO talk? Dr. Meena?
You should welcome Dr. Dinesh Talwar and Dr. Shobha Shivaprasad. They have also joined.
Can't see them. Ask them. Dinesh, Shobha, can you show your faces? Because, yeah, welcome, Shobha. Now we can see smiling face of Dr. Shobha.
Dinesh?
Yes, you are visible. I think we have to hear Meena first and then we go on for. Meena, are you ready with your RVO talk?
Is my screen visible, sir?
Oh, you are seen.
No, you are visible. The screen. No.
You need to share the screen.
PPT is not there. Meena, you have to start sharing your. Yeah.
Now, yeah.
Just click on this. Click on the PPTX.
Apologize for that hiccup. I have basically divided my talk into 2 parts. Am I audible?
You're audible, but screen, I think PPT, it has to go full screen.
You're still on the finder, you're on the finder of the...
Maybe there is a little lag from her madam's computer. I think with time, just it will come to full screen.
No, she has to unshare and share the PPT again.
Yeah.
Yes, madam.
Yes.
Sorry, I apologize for that hiccup. I have basically divided my talk into 2. I had asked Gopal permission so that I can speak on the glaucoma-inducing effect of anti-VEGF also, especially in patients with retinal vein occlusion who are either glaucoma suspects, ocular hypertension, or primary open-angle glaucoma. Unlike diabetic retinopathy or age-related macular degeneration, retinal vein occlusion is still an enigmatic black box. We really do not know the very specific mechanisms that are responsible for macular edema or neovascularization in retinal vein occlusion, and hence there is no one and done therapy. There is no patient management blueprint that is foreseeable and applicable to all your patients. So we treat based, like in other diseases, based on our own clinical judgment and also by studying the studies, and you identify a protocol that will suit your patient on an individual case-to-case basis. We have moved from the era when we did observation for macular edema and central retinal vein occlusion and sectoral or panretinal photocoagulation for the treatment of neovascularization and grid laser photocoagulation to perfused macular edema in branched retinal vein occlusion. So when should we initiate treatment in our patients? After doing the baseline investigation and identifying whether there is any associated systemic factor which could be responsible for the vascular event in your patient, and asking the patient to control all the systemic vascular factors. There are various studies which actually looked at the natural course history of central retinal vein occlusion for a period of time varying from 6 months to 3 years. And the results of these studies shows that we can basically divide our patients into two: eyes with a baseline vision of better than 6/12 and eyes with a vision which is less than 6/12. In patients with eyes with a baseline vision of better than 20/40, they do well with observation and have 65% chance of retaining that vision at 3-year period, although they require regular follow-up down the line. Patients who start with a poorer baseline vision have only a 7 to 17% chance of gaining 3 lines at the end of 6 months, and 50% of these patients lose more than 3 lines at 6 months. So in the beginning, when you see your treatment naive patient with a vascular occlusion, you know definitely whether he has to be started on treatment or not. There's a very elegant study which showed as early as in 2007 that intravitreal VEGF levels were maximum in patients with retinal vascular occlusion when compared to other retinopathies. The clinical severity of the vein occlusion correlated with the levels of VEGF, and administration of an anti-VEGF reverses this effect in central retinal vein occlusion. If you look at the history of the treatment trials in retinal vascular occlusion, the first trial was for the cruise, the Horizon Cruise, Retain, Shore, Crystal. We now have the Marvel study, as well as the LEVO 2 and the LEVO and the SCORE 2 studies, which are non-inferiority trials, head-to-head comparison between the commonly available anti-VEGF agents. Part of the results of these studies are out, so we know what drug to use and when and how to use these medications. This is the treatment line for branch retinal vein occlusion trial. Again, we have the Bravo, the Horizon Bravo, Retain, Shore, and the Marvel study. And whatever is the randomized control trial that you're looking at, and whatever is the treatment protocol, whether it is a fixed monthly dosing regimen or a 6-month dosing regimen followed by a stabilization criteria, control PRN criteria, or whether rescue laser is added or not, the mean number of injections that is required varies between 8 to 10. And when you look at the number of patients who gain more than 15 lines, 60% of your patients will be gaining more than 15 letters. That is a 3-line gain in visual acuity in the course of a 12-month period. The same is the results with the central retinal vein occlusion treatment trials. Here again, you require about 9 to 11 injections, and irrespective of the drug that we use, whether it is ranibizumab, bevacizumab, or aflibercept, 15-letter gainers are again very a little less, about 40 to 50% of your patients. So what do you learn from these studies? We learned that patients who start with a good baseline visual acuity can either stabilize the vision, but some of these patients do lose their vision. This is because of a ceiling effect. It is not that your treatment is not working. And since you have started with a good vision initially, there is a ceiling effect of how much the patient's visual improvement can occur. In contrast, a patient who starts with a moderately severe vision loss at presentation with a baseline vision varying between 20/70 to 20/200, his vision definitely improves down the line, and he's a 3-letter gainer or a 15-letter gainer in branch retinal vein occlusion, and a 2-line gainer in a central retinal vein occlusion. So what it teaches us is that the more intense is your treatment with the available anti-VEGF agent, it gives you meaningful results in your own clinical practice. So in simple, basic terms, each additional anti-VEGF injection that you give your patient gives your patient chance to gain 1 letter. So is it the same thing applicable in a real world scenario? If you look at the real world outcomes, they differ from what we see in clinical trials, and these patients, the anti-VEGF is not used alone, and each retinal surgeon on his own personal decision may add steroids, focal laser, or pan-retinal photocoagulation. And the studies on the real world scenario are more diverse in presentation. The cases that are enrolled into these studies may have advanced form of the disease. The patients may have ischemic retinal vein occlusion. The retrospective nature of the data adds a bias to the outcome, and there is a non-standardized visual acuity assessment. However, whatever is the drug that is used in comparison to the standard randomized controlled trials, fewer injections are given in the real world scenario, and the visual gain is also much less. When you gain about 15 to 16 letters In the randomized controlled trial, the visual gain is only about 7 to 8 in the real world scenario. Irrespective of whether you're treating central retinal vein occlusion or branch retinal vein occlusion, whether you're using ranibizumab, bevacizumab, or aflibercept, the mean number of injections is about 7.6 compared to the 8.5 or 9 injections that is given in the randomized trials. And the number of patients who gain more than 15 letters or 3 lines is also much less in practice. This is the same scenario whether we look at the retinal vein occlusion, AMD or DME trials. The number of letter gainers is much less than what you see in the randomized trials. So this is a gap which you have to look in, and it calls for more frequent follow-up of your patients and more frequent injections. Next, we come to the big question of which drug to use. Can we compare the outcomes that we obtain in the various studies which have different enrollment criteria? Patients with different baseline attributes are enrolled into the study and have different treatment protocol and different primary endpoints. However, we can look at a single aspect that is common to all these studies, which is the 15 letter gainers. And there are very, very elegant studies which are head-to-head comparative studies, the SCORE2 on the central retinal vein occlusion and hemiretinal vein occlusion. The results are out. So also the LEVO study, which is conducted in UK, as well as a Marvel trial from our own country, which are head-to-head comparison between bevacizumab, aflibercept, and ranibizumab, and shows that none of these drugs these are non-inferiority trials, are inferior to the other, and the same number of injection of each of these drugs will give the same result. So whatever your patient is comfortable, your patient is insured, you can go for a more costlier drug. If not, you can choose something that will fit his pocket. Let us look at a few case examples. I took out these examples to emphasize the need for a systemic workup of the patient and also to emphasize the fact that a high serum homocysteine level may be responsible for the thromboembolic episode in your patient. We have a very high number of patients, especially in southern Kerala, with very high serum homocysteine level who do very well with good dietary advice and supplementation of the B-complex, vitamin B6, B12, and folic acid, in addition to your anti-VEGF and laser therapy. This is one such patient with a branch retinal vein occlusion, bilateral. One is treated and the other one has macular edema. After 5 injections of bevacizumab, medical treatment of his homocystinuria, the medicine is available as a single tablet of homocyst, capsule homocyst, which can be given twice daily. Follow up your patient, and once the homocysteine level comes down, you can stop the treatment. There's another such patient with a branch retinal, inferior temporal branch retinal vein occlusion who had an old superior temporal occlusion with macular edema, who was treated again with 5 injections of Avastin and medical treatment with good recovery. Let us look at this patient with central retinal vein occlusion with a serum homocysteine level of 23 millimoles per liter. We started treating him in 2015. He received several injections of Lucentis. He was a partial responder. We shifted to Ozudrex with the resolution of macular edema, along with treatment of his high serum homocysteine level. Is another such patient. So we go to the third aspect of my talk: how frequently and how long do you inject? Do you follow the fixed monthly injection regimen? Do you treat on a stabilization criteria derived PRN dosing, or you give the treat and extend protocol? We look at it. And how long do you treat? You treat till your macula is completely dry and the patient regains a vision of 6:6, which is like looking for the fountain of youth. And the main goal is to keep your macula dry, to stabilize the patient's vision. And the additional goal is to reach that point with a protocol that is least burdensome to the patient and at minimal cost as possible. So if you look at the fundamental principles of anti-VEGF therapy, the main principle in all the talks that you've heard so far is to maximize and maintain the visual acuity benefits, for which early initiation of treatment is absolutely necessary. It is also important to tell your patient that the vision once lost is very difficult to regain. These are trials which have showed that with treatment, there has been significant improvement, the Galileo and the Copernicus study in non-ischemic vein occlusion. And in each patient, and with each drug, it is necessary to understand that there is a specific disease recurrence-free period or a period of VEGF suppression. And we have to know the period of VEGF suppression when you treat a patient. If you're treating with ranibizumab, the period of VEGF suppression, according to studies, is about 26 to 69 days, and it is longest with aflibercept. So let us look at the treat and extend therapy, in which It's a proactive and a customized approach which aims to prevent recurrences with lesser number of follow-up visits, and there is no need for interim monitoring. In this, the patient's maximum disease recurrence-free interval has to be identified. So you initiate the patient a treatment with a loading dose of 3 injections and gradually extend the treatment time between treatments until the patient has just recurrence of fluid or the vision comes down. And that is the period where there is a maximum fluid-free interval. The interval between your loading dose and this period is that particular patient's maximum fluid-free interval. Then you start treating the patient a little more frequently than the maximum fluid-free interval to keep his retina dry proactively and maintain vision. This reduces the number of follow-up visits the patient has to make to your clinic. On the other hand, if you're looking at the PRN dosing, which is a reactive type of treatment, you individualize your patient and identify his VEGF suppression time, and along with the VEGF suppression time of the drug that you're going to use. Suppose this particular patient has a VEGF suppression time of about 6 weeks, and you're following him up monthly. When he comes for review in the first month after injection, he is absolutely fine. His macula is dry. He is going to come back to you for checkup only after another 4 weeks. His VEGF suppression time is 6 weeks. So there is a 2-week period when there can be a disease recurrence in this patient. So this disease recurrence period should be identified, and you have to treat a little early. So you, in actual clinical practice, you have to combine both treat and extend as well as the PRN dosing regimen to suit your individual patient. So this is a comparison between the PRN dosing and treat and extend. In actual clinical practice, it is different on an individual case-to-case basis, and it has to be taken according to your own clinical scenario. There are a group of patients, about 40% of patients who may be suboptimal responder, whom can never dry up the macula, even after 3 or 4 injections of anti-VEGF, or the macular edema recurs after 2 weeks. These patients may have an epiretinal membrane with preomacular traction or peripheral ischemia. And there are various treatment options you can consider. You can consider a laser to the peripheral retina, switch to another anti-VEGF agent, add steroids, give a combination therapy, etc., which can be worked out. So what about ischemic central retinal vein occlusion? So far we have been talking about the well-perfused central retinal vein occlusion. In ischemic central retinal vein occlusion, if you look at the various studies, there are about 15 to 20% of patients enrolled in these studies who had poorly perfused retina. In this, a combination of anti-VEGF with peripheral pan-retinal photocoagulation would do wonders in stabilizing the patient's neovascular process. So also in patients with neovascular glaucoma, a combination of anti-VEGF, laser, and if the medical control of intraocular pressure, and should a medical control not be achieved, you have to think of a shunt procedure in these patients. I'll go to the second half of my talk, which is the IOP elevation of anti-VEGF therapy. If you basically look at the intraocular pressure elevation of the anti-VEGF, which can be classified into 2 sections. One is the prompt elevation of intraocular pressure, which is transient, occurs immediately after the injection with the IOP returning back to normal in 30 to 60 minutes without any IOP lowering agent. And there is the second variety, which is a sustained elevation of intraocular pressure, which is of several causes, has been postulated to be responsible for this. And let us look at what are these factors and which of the anti-VEGF agent is more prone for intraocular pressure elevation. If you look at the prompt elevation of intraocular pressure, the pressure rises very high immediately after injection. Suppose you are starting with a baseline pressure of 8 to 23 millimeters. The pressure may go up to 36 to 40 millimeter of mercury, and in 15 minutes time, it comes down to normal. Let us look at all the factors which could be responsible for this high elevation of intraocular pressure from the baseline IOP, and the positive correlation was noted between the short-term IOP elevation and baseline IOP. This is something very simple to understand. So if you are starting with a high baseline IOP, the pressure is going to spike after the injection. A positive correlation was also noted between the elevation of intraocular pressure with transient elevation of post-injection intraocular pressure and the number of injections that is given. Studies have looked at whether injection into an eye with a smaller hypermetropic eye with a smaller axial length would cause a prompt elevation of intraocular pressure, and very elegant studies have shown that it does not. So also the shorter the interval between injections, you're going to have a more high transient elevation of intraocular pressure. But what is very, very important is the way you inject the drug into the eye and the gauge of the needle that you use. There is a very definite entity called the post-injection reflex, or the PIR, which depends upon the way in which you inject. If you have a tunnel entry into the eye, the PIR is much less than when you have a direct puncture into the eye. PIR is not something bad, which you should try to prevent the liquid vitreous as well as some part of the drug from egressing to the subconjunctival space. You should not press on it. PIR actually reduces the transient increase in intraocular pressure, and this minimal amount of fluid vitreous which comes out is not going to cause any peripheral traction. So let us look at this small video clipping. This is for the comprehensive ophthalmologist to understand that they should not panic when the PIR occurs. This is the injection goes into the eye. The PIR depends upon the needle gauge, the angle of insertion of the needle, the depth of insertion, the lesser reflex with deeper insertion if you're injecting to the midvitreous cavity, and the speed of injection. If you're injecting slowly, you get more PIR than when you inject slowly. So this is the PIR. There's a small bleb that comes up which actually prevents the transient elevation in intraocular pressure. And if you're dealing with a patient who has a primary open-angle glaucoma, even this transient elevation in the intraocular pressure can cause damage to his optic nerve. Does prior application of a pinky ball, which we use in our country, prevent the transient elevation of intraocular pressure? No. No. There are very elegant studies which show that it does not. Does prior treatment with anti-glaucoma medication, either topical or systemic medication, reduce this post-injection reflex and prevent the transient increase in intraocular pressure? Studies have not shown that it is useful. But however, there is one single method by which we can prevent a transient increase of intraocular pressure, which is to do a paracentesis in patients who have ocular hypertension, who have primary open-angle glaucoma suspects, or who are actually on treatment for primary open-angle glaucoma. If you are injecting into their eye, performing a paracentesis would reduce this transient elevation of IOP. However, there is an additional risk of iatrogenic injury in about a very small amount of patients, about 0.7% of patients. And when you're injecting under the microscope, this risk of injury to the iris or the lens is minuscule. So now let us look at this patient who had a central retinal vein occlusion. He had a baseline IOP of 20 millimeter of mercury, received 3 injections. His IOP increased from 20 to 24, and his fields and RNFL were normal. And here comes the take-home message that you should record your intraocular pressure in the patient before IOP, before injection, and at each subsequent visit that he comes to your clinic. And you should also compare the intraocular pressure difference between the treated and the untreated eye. And this same patient went on to receive his 4th injection. His pressure is still at 24 millimeter of mercury. We start him on treatment and keep him on regular follow-up. So let us look at another patient in whom there was an IOP elevation from baseline by about 10 millimeter of mercury, and a difference in IOP between both the eyes of 5 millimeter of mercury at a central corneal thickness of 575 micron. He did not have any peripheral field changes or RNFL thinning, and he was put on brinzolamide eye drops. So this is a patient with a sustained elevation of intraocular pressure, which is defined as an IOP of more than 25 millimeter of mercury, or a difference in IOP of more than 5 millimeter of mercury between both eyes, lasting for a period of at least 30 days after your injection. If you look at the post ad hoc analysis of some of the major randomized controlled trials, the sustained elevation of IOP is seen in about 3.6 to about 12% of patients. And it is very difficult to actually identify the percentage of patients who have an sustained elevation of IOP from these post ad hoc studies, because the criteria is different. Some people look only at a point-to-point pressure measurement. Comparison between both the eyes, or elevation from the baseline is not taken into account. So let us look at the factors which could be responsible for the sustained elevation of intraocular pressure. The most important factor that is responsible is a mycopart particle obstruction of the trabecular meshwork. There could be actual trabeculitis, which has been demonstrated in this very elegant study by Palmer et al. The monomer antibodies and aggregated proteins could clog the trabecular meshwork, causing difficulty in aqueous outflow. And this kind of microparticle obstruction is maximally seen with pre-filled ranibizumab and repackaged bevacizumab injection. And this elegant study on microflow imaging and showed that the more is the hold time for your drug, there are more microparticle which leaches into the solution. And the leaching can occur either from the syringe in which you store the drug, or when you're transporting your drug from one clinic to another. People who operate in various different centers and transport the drug during the movement that occurs during transit can actually cause silicon bleaching and also the monomer particles to aggregate. And these particles as well as anti-VEGF may have a toxic effect on the survival of the trabecular meshwork cell by disrupting the nitric oxide pathway. And this nitric oxide pathway is basically responsible for the contractility of the trabecular meshwork. And when there is nitric oxide in the aqueous, in the arterial chamber, the trabecular spaces are wide open and the facility of aqueous outflow increases. If you're looking at the molecule per se, bevacizumab being a larger molecule with a daisy chain or paper doll kind of VEGF binding, may actually clog the trabecular network theoretically. In addition to that, the FC segment, which is available only for the bevacizumab, the other two drugs that are commonly used as only the FAB segment. This FC segment, trabecular meshwork cells actually have receptors to the FC segment. So in all, bevacizumab should cause a higher increase in intraocular pressure. But however, studies have not shown that there has been a significant difference in intraocular pressure between ranibizumab or bevacizumab, except for a single study which enrolled 101 eyes. VEGF is actually produced by the trabecular meshwork. It is a useful agent, and this VEGF is responsible for increasing a facility of outflow during the ocular pulse amplitude. When the eye pulsates, there is stretching of the trabecular meshwork, and the trabecular meshwork cells will release VEGF. And this VEGF is responsible for increasing the facility of aqueous outflow. So when you are going to administer anti-VEGF over prolonged periods of time, the effect of this VEGF in improving the facility of aqueous outflow is hampered. So if you follow up your patients, you will find that the facility of aqueous outflow is reduced. And in addition to that, these patients also will have progression of the RNFL thinning. So what about the frequency of intravitreal injection and sustained elevation of intraocular pressure? The more number of times you inject, the higher is the risk of increasing. And the reduction in the RNFL thickness is more in patients with diabetes in association with diabetic retinopathy or retinal vein occlusion. So let us go back to your original patients who had an IOP elevation of 10 from baseline. He requires one more injection. So what would you do? Would you be afraid of giving the injection? No, you should not be afraid of repeating the injection. You should make a note of the sustained elevation of IOP in his case sheet. Consider an anterior chamber tap or paracentesis before injecting, and post-injection follow up your patient closely and consider stepping up his anti-glaucoma medication should there be a worsening of his condition. Repeat his field and RNFL analysis every 3 monthly. So in conclusion, for management of retinal vein occlusion, you have to derive a protocol that fits the patient's pulse as well as his clinical condition, and it should be customized. I thank you very much for your patient hearing.
Thank you, Meena, for this talk on RVO. I did not know that most of the talk will be concentrating on IOP issues after anti-VEGF. In fact, that has been an eye-opener because a lot of people, I think, including me, ignore the IOP fluctuations. And I'm very happy that you have brought out this IOP issues after of injection. And it is very important, seen from your slides, last, I think, 14, 15 slides, about the relevance of studies of IOP, which may be responsible. Even though the figure, like you said, may vary from 3.6 to 11%, I think this is a significant number. All of you, Mayer IOP, pre-op, post-operatively follow these patients, or Malika, Gopal, or Chaitra?
For IOP, yeah, I take special care in patients who have glaucoma, obvious glaucomatic defects, or are on treatment. And in those patients, especially if they're advanced glaucomatous disc, I do a paracentesis before giving the injection. In some of them, I just advise them to take a tablet Diamox in the morning of the injection when they come. So the chronic patients already do that. But as Dr. Meena said, I don't know how much it helps. She said it has been shown to not help much. There are some patients with advanced glaucoma who do complain of vision loss after an injection specifically. So yes, we have to be careful, but not in non-glaucomatous eyes. I have not had any patient who has developed glaucoma after these injections.
So there are two categories. One is people who are prone. Like we know, you see around 20-30% of vascular blocks and DM patients are prone for ocular hypertension or glaucoma. This category, I think all of us, it makes sense to either do paracentesis or follow up this patient closely. You see, these, I'm talking routine intravitreal injections. You see, routine means where patients are not suspect or patient does not have any history of glaucoma, no previous rise. So those category of patient, do you do something?
So there was I have seen a patient where somebody has given non-predisposed to glaucoma, given an injection, developed a BRAO, detected next day. So any patient can develop a problem, especially if the volume injected is high. So that we should have a standard understanding that the risk of IOP elevation from any injection in any patient exists, with CRAO and BRAO possible. But apart from that, generally speaking, we have not ever had a problem in non-predisposed patients.
I am very happy, Meena, you brought up this topic. I would like Dinesh to comment on this about IOP issues in patients who are not prone for glaucoma.
Yeah, so as a principle in all our patients, I have been doing IOP measurement after the patient has received the intravitreal injection before he leaves the center. And we do not like to leave the pressure at more than 30. If the patient's pressure is more than 30, we prefer to start him on anti-glaucoma medication, bring the pressure down before sending him down. The reason is for this only. There could also be patients who are not diagnosed as glaucoma. You may be just taking care of the AR, MD, not realizing he'll lose the central field also and the peripheral also.
So next time if this patient, same patient who is not prone, and we are only category we are talking is non-prone.
Yeah,
if
so
this
now,
next time.
Yes. So now, if in two repeated injections, I note a tendency of the pressure to go beyond 30 in each of the injections, then the third time around, I will put it that the patient has to have a paracentesis also. And I have a few patients who have, now we are talking of the non-glaucoma patients. Yeah. I have one patient, in fact, whom I remember because he's coming he has to come every month or two. Both the eyes get injection. Both the eyes develop. After the first 10, 12 injections, he developed a tendency for the pressure to go up to 40, 45. So now in every injection, he gets a paracentesis. This is a routine now.
So in fact, now, because dilatation also sometimes can cause crowding and.
No, but his pressure doesn't go up before the injection. It only goes up after the injection.
Okay.
So there are patients in whom the pressure can go beyond 40 also. So I will, and especially if the patient has glaucoma, there is no question I will, and if the patient is on more than 2 drugs. If he's on 1 drug, I may not give him a paracentesis. If he's on 2 or more drugs, I prefer to do a paracentesis.
Yeah, that's okay. Meena, what is your comment on?
You're starting with a baseline pressure of 16 millimeter of mercury in both the eyes of a patient, and you're injecting. If he has a rise of about 4 or 5 millimeter of mercury, you may not consider it as significant. What is most important is to compare the pressure with the fellow eye. And if there is more than 5 millimeter rise from the fellow eye, it means that increase in pressure is significant, and you have to keep your patient on follow-up with fields and RNFL analysis wherever possible. And you will reach a stage when you can actually demonstrate progression, since these patients will require multiple injection, and at that stage, you have to start the patient on treatment. So you're looking at 2 different things. You're looking at patients who have ocular hypertension, or who are primary open-angle glaucoma suspects are already on treatment of glaucoma. They form one category. And second is a routine patient. In the routine patient also, you have to look for a difference in pressure from the fellow eye. And that is very, very significant.
So this is an eye opener. In fact, measuring pressure in both the eyes after the injection, which in any case, I mostly don't do it, frankly speaking. So in prone eyes, we do it, but in, like you said, you have to compare between 2 eyes, and if the difference is more, this is a good, I think, take home. Mahesh?
Yeah, sir, regarding this homocysteine, I had talked to some of the hematologists. They tell that the increase in the value more than 3 times the normal limit is significant. So is it that the 22, 23, is it significant to start? Usually the treatment is with warfarin, not with clopilate and aspirin. Yeah. So, Meena madam?
No, the treatment is with very simple. It's just a complicated combination of vitamin B6, B12, and folic acid, and dietary control. If the patient is a strict vegetarian, it is likely that the B12 is deficient, B12 absorption is deficient, and he is going to be a vegetarian all his life. You cannot ask him to start on anti-VEGF, non-vegetarian food. Sorry. So in such a patient, you can just give a combination of vitamin B6, B12, and folic acid. Warfarin is not the treatment. The treatment is just simple.
But real homocystinemia, the treatment is.
This is just dietary deficiency of vitamin B12, and this is treated with a single tablet of homocyst. This vitamin combination is available as homocyst. The slides, the images that I showed was from my presentation at the American Academy. This was 5 years back, with vein occlusion with associated homocystinuria. The normal value in an Indian subject is 10 to 13 millimoles per liter.
Yeah.
And
yeah.
significant.
Yeah, I think warfarin is not the drug of choice. What you need is basically starting the patient on B12. That's all. I mean, it's the other things are not. And if you feel that there is a tendency, I may give EcoSprint for some time and stop it later on.
Okay.
The high dose of B12 we normally give. Yeah. I think we'll move on and keep discussing in between these points. You can jot down. Now it's my privilege to ask Dr. Mallika Goyal to tell us about myopic CNVM, which compared to modality which you have discussed is a relatively happy situation. Mallika will tell us whether it's happy or sad. Yes, Mallika.
Yes. Good morning, everyone, and I'd like to thank the KSOS, COC, Dr. Pillai and Dr. Lalit Verma for this opportunity. So yes, this is a happier situation than AMD and PCV, but not completely so, as we will see. So this is seen in about 5 to 11% of the patients who have pathological myopia, who generally already have poor vision, but they present with sudden decline in central vision, or with metamorphopsia or a black spot in their vision. Now, pathological myopia is that which is associated with myopic macular degeneration and is usually associated with over 6 diopters of myopia. And this is because of the globe elongation and the abnormal choroidal vasculature resulting from this elongation. So what are the risk factors for CNVM in a myopic eye? Is the presence of lacquer cracks, which are breaks in the RPE-Brooks choriocapillaris complex. This lacquer cracks is important not only for CNVM, but also for simple hemorrhage, which happens in myopia. Then the other risk is the presence of RPE or patchy atrophy at the posterior pole, thinning of the choriocapillaries. And very important risk factor is if the other eye has CNVM, then the patient should be cautioned about risk in the fellow eye. There is a genetic predisposition for this, and importantly, it can occur in eyes that have no degenerative changes at all. So myopic CNVM can be classified in 3 stages. One, which is the active stage, it is a small, flat, grayish membrane, as you see on the left side slides. Now, these are very subtle and may be missed completely unless OCT is done. And bleeding, if it is present, then of course it becomes obvious. Untreated, this leads to the second stage, which is a scar. And this scar is a grayish scar, which is called the Fuchs spot or the Foster-Fuchs spot. And the third stage is the atrophic stage, where it leads to an area of degeneration and RP atrophy. A characteristic feature of this is over 1/3 of the patients will develop bilateral CNVM. And in fact, about a fourth of the patients, 25% of the patients, will present with CNV in both eyes. One may be scarred and the other may be active. Most of the CNVMs in myopia are of the type 2, which is subsensory neuroretinal. As we see here, very bright leak on fluorescent angiogram. A very small proportion could be occult or type 1 CNVM under the RPE. And now OCTA can be used for imaging to diagnose the presence of CNVM and also monitor treatment. A very important clinical condition in the myope to differentiate from CNVM is simple hemorrhage, because the treatment is very different, the outcome is different. This also is associated with lacquer cracks, but it has no relation to the development of CNVM. It does not increase the risk of development of CNVM. It resolves spontaneously, though there may be a recurrence of these hemorrhages in 1/3 of the patients. So how to distinguish it from CNVM related bleeding is by doing any one of the angiographies. And as you see in the slides below, the CNVM is shown as a hyperfluorescent lesion in the center of the bleeding, or it may be at the edge of the bleeding. The visual outcome for simple hemorrhage is usually very good. However, sometimes if the hemorrhage has been very thick and damages the outer retinal layers, the ellipsoid zone, then the visual outcome may be poor. So these slides are showing that there is no leakage seen on the angiograms, but in the upper row, you see that the ellipsoid zone is intact, so visual outcome is good. Whereas in the lower slide, the ellipsoid zone is damaged with a poor outcome. So even simple hemorrhage may have a slightly poor visual outcome if damage to external layers exists. Now, very specific to the management of myopic CNVM is that they need a very careful peripheral retinal exam for any lattice and holes which need to be treated with laser before we start any intervention. Also important is to examine the optic nerve carefully because the myopic disc is very difficult to distinguish from a glaucomatous disc. And I've had at least one patient where the young lady developed advanced glaucomatous field defects, but the disc looked just a myopic disc. So that can happen. If there is any doubt, better to consult a glaucoma specialist. And when there is glaucoma, it's already discussed, we should do a paracentesis on the same time as injection. Also in these patients, important to look for coexisting macular pathologies, which will affect the prognosis. The first treatment for this was photodynamic therapy, but it was found that it gives no benefit to visual outcome as compared to placebo. Then the first trial with ranibizumab was the repair trial, and it found that there was an improvement by almost 14 letters at 1 year compared to 3 letters, compared to no treatment in the sham group, and with a median of only 3 injections in 1 year. Now, this is different from ARMD, PCV, or even diabetic macular edema and RVO. Just 2 or 3 injections and you get a good visual improvement. The Radiance trial, it compared ranibizumab with PDT. There were 2 different PRN schedules. One was the visual acuity stabilization criteria, and the other was the OCT related disease activity criteria. And again, the ranibizumab group at 3 months had a 10 letter increase, whereas the PDT group had only a 2.2 letter increase. So at 3 months, PDT group was switched to ranibizumab, and then you see that at 1 year, even the PDT group had a 9 letter increase on switching to ranibizumab. Also important to see is that there was a continuing visual improvement from 10 letters at 3 months to 13 letters or 14 letters at 1 year without any further injections. So the vision continues to improve in a myopic eye following initial treatment. The number of injections was, mean number was 3.5, and more than 60% of the patients did not require any injections after the first 6 months. Also significantly, there was no retinal detachments following injections, and extrafoveal CNV should also be treated immediately in myopic eyes because this CNV is followed by atrophy, which will involve the foveal center as well. And hence the Radiance trial included patients with extrafoveal CNV as well. This was followed by the Mirror study where aflibercept was compared with sham, and only 2 injections were required in the first 3 months, and then no injections after the first 3 months. And the visual acuity increase again, as you see, is 12 letters versus -2 in the sham group. Again, the same findings were seen that at 6 months, 40% of the patients in the aflibercept group had significant visual increase of 15 letters or more, whereas only 10% in the sham group. Now at this point, at 6 months, the sham group was switched to aflibercept. So you see at 1 year, 30% of the sham group also had significant visual improvement. But it did not catch up with the group that had received aflibercept right from the beginning. So early treatment is also very important. Delaying the treatment can reduce the visual outcomes. Now the question that can arise is that would combination therapy be a good option to reduce injection numbers or frequencies in a given case? So it has been found from various studies that anti-VEGF monotherapy is the only treatment which can give a visual outcome, improve visual outcome, whereas PDT monotherapy or PDT with anti-VEGF does not lead to increased visual acuity, though the disease may become inactive and anatomically the disease may dry out. So PDT has no role in myopic CNVM as a monotherapy or as combination with anti-VEGF. Now, so important points which emerged from these studies is that a single injection followed by PRN treatment is good enough for myopic CNVM. This is followed by monthly visits for the first three months, and after that the patient can come every 3 months for a year. But patient is educated to be vigilant and report any visual drop while they are waiting for their appointment. These were all very good results because these studies had a follow-up of only 1 year. But over the long term, it is found that more than 90% of the patients will have less than 20/200 at 5 to 10 years because of the progressive macular degeneration or the coexisting problems of macular hole or macular schisis, etc. that come in myopic eyes. And this has been our experience as well. So now I will talk about what has been our experience. Most of these patients are very young, and they are usually already one-eyed when they come because the other eye has been affected by degeneration or scar, or they have an old retinal detachment, or it's an amblyopic eye from high myopia, or there is a macular hole, and very commonly glaucoma coexists with myopia. So they're usually already severely visually compromised when they present for treatment. And very common to this group is very severe distress and desperation. Because they are young, they are often the only breadwinner in the family, and they have a lot of aspirations and a life ahead of them. Also, because they are young, affordability of treatment is often a problem, unlike AMD patients who come with their middle-aged or elder children who are settled in life. So these are usually young people who have a lot of limitations. And I have found that injections may be required for months or years in these patients. And even if you can stop injections initially, recurrences can happen after several months or years. So a lot of vigilance is required on the patient's part. And recurrences can happen in different areas of the posterior pole. Also found that it is not easy to identify or locate these membranes on the slit lamp biomicroscopy or on OCT because the myopic posterior pole is so large and these eyes don't fixate very well. So indirect ophthalmoscopy is often good to identify where is the new CNVM because it gives you a larger view of the fundus. And then you can take the patient on OCT and look at that particular area for CNVM. So I'll just show a few examples. This is one of the happier cases where you can give 2 injections and the patient is good for life. This is a young lady who required 6 injections in 1 year, 7 injections, but had a good outcome. And till now there is no recurrence. Okay. This is a young man who initially responded, but then subsequently became non-responsive. Despite 7 injections in 9 months, the vision has continued to deteriorate and you can see the fluid has not dried despite the use of aflibercept. And I do suspect that it has non-response was triggered by a gap in therapy when he left for outstation. A 3-month gap in therapy was followed by complete non-response, and he has lost his vision with continuing activity. So not all cases will respond to anti-VEGF therapy. This is a patient who had a recurrence 10 years after the initial treatment, and following that she has been treated with ranibizumab. Anatomically, the disease has responded, but you can see that there is on the left side, the infrared images showing you the progression of atrophy, and hence the visual improvement was modest. So this is a common finding that atrophy takes over when the CNVM has dried out. This is a relatively young person, marfanoid habitat, high myopia, both eyes, macular degeneration, advanced glaucoma, status post trabeculectomy, and in the right eye he has a dislocated cataract, but it is not being operated because of the multiple comorbidities, and the left eye has aphakia. Now this eye had multiple lattice, so that was first treated. That is very important. And then he required 11 injections in 1 year for this CNVM, which was repeatedly non-responsive or recurrent. But finally, at the end of 1 year, he has had a reasonably good outcome. And this was his better seeing eye. Now, this is a myopic CNVM. which was actually scheduled elsewhere for ERM removal. But when they came to me, I felt that it was the CNVM which had caused the sudden vision loss. And you can see 6 injections in 1 year, in 6 months actually, 6 injections, and he was okay. But there was a recurrence at 4 years. So the patient has been educated to report recurrence immediately. And with 2 injections, that settled down, and he's continuing to do well now, 6/6 vision. Recurrences can also happen in a new location. You see this patient. There is a hyperpigmented spot on the infrared image, which is the CNVM. This was treated, but there was a recurrence after 2 years, temporal to the macula. The previous was nasal to macula. And after another 3 years, the recurrence was actually subfoveal. And she has been treated, but visual outcome has been reduced because of the associated degeneration. This is another lady. Started treatment in the right eye. They could not afford, so developed a scar. But now when she developed in the left eye, they were very desperate for treatment. So you see that she has improved, but there was a recurrence after 2 years. Again treated, recurrence after another year. Again recurrence after a few months, 10 months. But finally she has 6/6 with 3 recurrences and 9 injections in 3 years. Vision is good. This is a lady who came with one eye scar from CNVM and the other eye had an active CNVM. I treated the left eye, the active eye, with several injections of bevacizumab over 2 years. And surprisingly, the other eye started improving, which had a prior CNVM. And ultimately, both eyes became equal because I also treated that eye then. And both eyes have reasonably good vision, and she's able to work as a teacher even now. So, an important point to remember is that when there is a hemorrhage from these CNVMs and we do a gas injection with anti-VEGF to displace this blood, the risk of retinal detachment is very high in the large globe, and the inferior tears and inferior RD can happen, which happened in this young man. The submacular hemorrhage resolved, as you can see, but he came with detachment after 2 weeks. Did a detachment surgery and he was doing well, but then the CNVM came back after a few months and that required injections. But finally he's doing well and has his job after 10 years. I think this is one of the last patients. So this is an elderly gentleman, very high myope, other eye is lost to scar from CNVM and was treated with PDT many years back. This eye, when he came to me with retinal detachment, which was operated, doing very well, then came with a lamellar macular hole, inner lamellar, which progressed to full thickness. Now he was one-eyed and relatively elderly. So I was hesitant to operate the macular hole. And then he comes with sudden complete vision loss with a CNVM. Treated the CNVM, but surprisingly, there has been no improvement in his vision, though anatomically the CNVM has regressed, but I cannot explain that vision has not improved. So I'm glad that I did not operate his macular hole, because then I would have felt guilty and I would have thought that the CNVM was probably triggered by surgery. Thank you.
Thank you, Malika. I thought myopic CNVM, there will be very few slides, but I think you have covered a huge gambit and shown a lot of examples. We will move on, Malika, because the time is running out and Gopal is issuing me, private messages that we have to move on. So in any case, with due regards to what Malika has spoken, we will take 1 or 2 questions in any case. You see, myopia, I agree. Whatsoever you may do, like one patient you had RD, detachment, everything done, still patient had 6/12. So as if all of us can, tolerate and treat PCV, what Giri had shown in the beginning, AMD, so myopia for all of us is a reasonably happy situation, provided we take care of the peripheral tears also and detachments also and other associated, problems. So I think we will move on from these issues to now practical issues, which I think Gopal has a lot of, time he wants to spend on this, and we will spend time, Gopal. And before we go to Dinesh Talwar, we have 2 very important keynote addresses, which one is from USA and one is from UK. So UK comes first if we travel to US. So UK is first, Dr. Shobha, and that is clinical trial versus real world results with aflibercept. This is very, very relevant for us in developing countries, that whatever the trials, keep speaking, what is real world. So Shobha, you have to highlight that. Thank you. Thank you,
Thank you very much. And good morning, everybody from the UK. So I will present today on clinical trials and our real world experience in the UK. So these are my disclosures. So as Meena said, our goal of any retinal disease management with anti-VEGF therapy is to maximize the visual acuity of our patients while reducing burden. It is a conundrum. It just does not work. If you try to increase the maximize the visual acuity, the burden will definitely be significantly more. There is an entity here, do balance your treatment between under treatment and over treatment. As far as AMD is concerned, there is no over treatment as far as I can see. Everybody needs quite a lot of injections. So when we consider clinical trials, we have enough evidence from several fixed monthly regimens in Anchor and Marina that shows us that if you inject them monthly, they do extremely well. And then the VIEW study came around telling us that if you give them aflibercept every 8 weekly after the loading dose, they do extremely well too. But all the PRN individualized or quarterly dosing clinical trials have all shown that the visual acuity declines with these sort of regimen. However, these are the type of regimen we can deliver in clinics. So that is where we fail when we compare ourselves with randomized clinical trials. So you can see from the CAT study that the bevacizumab and ranibizumab PRN regimen did quite well. But what we should always remember is that both the CAT and the IVAN study required monthly monitoring of patients on anti-VEGF therapy. And that's an impossible task, even in the NHS where treatment is free, transport is provided for patients who need it, etc. Even in the best of systems, this is impossible to see every patient every month. So the CAT and IVAN study, although not pharma studies, also prove to us that it is impossible to deliver a PRN regimen in real life. So let's get on with ranibizumab in real world. That's how we started our studies in the UK. So this is the Medisoft or the EMR data on about 100,000 injections on ranibizumab in the NHS. And you can see drug is free. The clinicians can inject as and when required. You can see that we did not deliver well. By the end of 2 years, we've reached 0 letter gain. And by the end of 3 years, we literally patients started to lose vision. So this provided us with an significant evidence that what we are doing in the NHS at that time on PRN dosing did not work. So we also needed to do a larger study. So this was led by me and Frank Holz from Germany. This is called the AURA study, where we looked at the real life evidence in 7 countries, including 7 from Europe and Canada. And what we found that even in all other countries, it is not the UK, whatever be the health system, if we are giving PRN regimen with ranibizumab, which was the only drug available at that time, we failed to deliver the gain in vision noticed in the clinical trials. Even the clinical trials where PRN was given, we were not able to match that. We were very good at the loading phase, as you can see. By 60 days, we are good at delivering 3 injections, but after that, the slope is downwards. And we also have the Luminous study, the WAVE study, and other real-world study, all telling us PRN does not work. So from that, we learned a few lessons. One, we can go on to treat and extend, because by that time, treat and extend regimens came around. And also, aflibercept came on board, and aflibercept VIEW study, as I said earlier, taught us that we can do fixed regimen in the first year. So this Meena has showed the slide already. Aflibercept has an edge over the other existing anti-VEGF therapies in that it also blocks other angiogenic agents, as well as it has a very good binding affinity to VEGF compared to bevacizumab and ranibizumab. So this is the view design where it compared to 8-weekly aflibercept to monthly ranibizumab, and the others were not really relevant, but it was in the trial. But it was a very well-run trial. What it showed us in the first year, you can see the yellow points at which injections were given in the first year. It shows that after the loading phase, we could go on to 8-weekly aflibercept. But what it didn't tell us properly is what to do in the second year, because the patients were monitored and given dosing at quarterly rate. And we just did not know how to apply this in real world. So in the view studies, as you can see, at 52 weeks, clearly ranibizumab, aflibercept was non-inferior to ranibizumab, and it carried on at 104 weeks too. So what is the real world evidence of aflibercept in neovascular AMD? Haven't failed to deliver the PRN regimen in the way patients would have liked. We then went on to look at our evidence of giving fixed dosing in the first year. So this is our UK aflibercept user group, which we did across 16 UK NHS sites, had nearly 2,000 patients. And what we found is when we give fixed regimen in the first year, we are able now to cause a gain of 5 letters, a mean gain of 5 letters for our patients. So this is the first lesson we learned. If we see a patient with AMD, there is no over treatment. For most patients, they need the full dose in the first year of 3 loading followed by 8 weekly fixed. And we can achieve 5 letters. That is a line more than when they came in. But what we also noticed in this is we had 16 centers and we found a significant variability between centers. So you can see here the proportion of patients who had more than 70 letters at baseline and then at 52 weeks. So that taught us that we're still not doing it right. And when we looked at the variation at presentation of visual acuity at less than 35 letters and more than 70 letters, you can clearly see that in some centers, they're having a high proportion of patients who are turning up when their visual acuity is less than 35 letters. And a proportion of patients, sites are doing very well when their patients present at 70 letters. So this made us rethink again about how we do our guidelines. So we found out that we need to increase public awareness of wet macular degeneration and the need to treat urgently. We needed to improve our access to ophthalmology services. We had to have fast track service. And the NICE guidelines came around telling us that if somebody sees a wet AMD in any optometry, they should refer to a retinal service within 1 day. And the patient, once in the retinal service, should be treated within 2 weeks. So that gave us a bit of an impetus to change our guidelines to ensure that all patients are treated promptly. We also noted from our previous studies on fixed regimen that second eye eyes do very well because they are in the hospital and therefore are being monitored. So NICE guidelines also told us that we have to monitor second eye and treat as soon as disease activation starts. So with these in mind, we made sure that there are quality standards now that we have to follow in the UK. So which means that we want to test whether our referral system is working. So we have to do an audit on what is our baseline visual acuity. Proportion of patients who turned up with 35 letters, proportion who turned up with 70 letters. That will tell us how we are delivering our service. The next thing is the number of injections we are giving. And we will know that by looking at the outcome of our patients. We also needed to see that patients do not drop out. So we are also monitored on the retention rate of our patients. So when the strict quality standards came in, we believe our services have improved from the PRN times. But this is all about process and all about how we improve our service to provide adequate benefit to our patients, but it is still difficult. We must always remember natural history takes over after 2 or 3 years of anti-VEGF therapy. So this is the National Aflibercept User Group by 2-year outcome. So as I told you, with fixed regimen, we were very good at giving a 5-letter gain. That same cohort in the second year only gained 2.8 letters. And you can see that our number of injections reduced to 3.7 in year 2. Again, telling us we are not good when injections, when the clinician makes a decision, we are not good, and it has to be protocol driven. So many of us then went on to treat and extend in the second year or continue on fixed regimen in the second year. So this is the summary. Some patients had dropped out from the original study cohort. So we had 1,180 patients. Showed us a few things. And we explained it by saying we have capacity issues seeing all these patients. And we thought patients preferred the ability to attend less often, but we were scrutinized for that, and we were told it is not patients and it is not capacity, we need to get on. So almost every one of us have now shifted to having fixed regimen in the second year, or as much as possible, and then also treat and extend. So this work was done by Shruti Chandra. She's an ex-fellow of Giridhar, very proud to have her on board in Morpheus Eye Hospital, and she's doing extremely well. So she has shown us what a 5-year aflibercept data looks like in Morpheus Eye Hospital. So we had 512 patients on 5-year follow-up with aflibercept therapy. Here you can see at 1 year, we managed 5.6 letter gain on an average, reduced to 3 in the second year, and then to 0 by the third year. And in the 4th and 5th year, we have started to decrease the visual acuity by about -2 letters. So that tells us, despite our treat and extend, or despite our fixed regimen in the following years, we do have a drop in vision after year 3. What we also noted, which is good news, is that a high proportion of patients still gained 70 letters or more. So nearly 40% of our patients still had 70 letters or more by the end of 5 years, which is very good because that's the driving vision standard for the UK. So it tells us that, you know, driving is extremely important in the UK. And when you're in the older age group, if you can't drive, it is difficult to get around. And we have managed at least 40% of patients to reach that score. She also showed us that injection frequency mattered even in the 5-year outcome. So she come up with this bullet points. If you are to maintain visual acuity in our patients, we need to give at least 5 injections every year until year 5. In that way, that group of patients did really well, and they continued to have a gain of vision. I mean, they stayed above the 0 x-axis. She also then went on to do a 10-year data on anti-VEGF. So 10 years means it's a combination of Lucentis and then shifting on to aflibercept. As most of you know, we do not use bevacizumab in the NHS. So here you can see, although we have injected about 17,000 patients in Morpheus alone, only 611 patients were initiated in 2008 to 2009. Of that 611 patients, 218 had deceased by the end of 10 years. That means a third of patients die by 10 years after they start anti-VEGF therapy. So we had and then 244 lost to follow-up. Again, the most common reason for loss to follow-up was comorbidities. And the total remaining were 149 patients on a 10-year monitoring. So at 10-year monitoring, you can see that again, we had a mean change of -2.1, which is pretty good for this group of patients who were under the system being monitored regularly and injected when necessary. But you can also see the two extremes. So there are 20% of patients who still maintained a 15-letter increase, and there's 11% who still had a 30-letter decrease. And you can go forwards to see the individual level data. Now, this clearly tells us that equal proportion of patients lose vision as well as gain vision by the end of 10 years. And an average of about a third of patients do have about, will just go around the x-axis throughout the 10 years. So this is the longest follow-up data that we have on anti-VEGF therapy for wet AMD. So in summary, there are a few points that I would like to stress. First thing is we have to give fixed regimen in the first year. And we chose Eylea because that is the drug that gives us the best evidence of reduced number of injections compared to ranibizumab. And we can still get a good visual acuity gain. Second year, we should either do fixed regimen or treat and extend, but we should try to give a minimum of 5 injections in the second year onwards. Up to 5 years at least, we have that evidence. We also learned baseline best corrected visual acuity is a predictor of final visual acuity. So we have to ensure that these patients turn up in time and we start treatment in time. And aflibercept treated eyes do maintain visual acuity up to 5 years at least. That's the data we have got. And as I stress again, we need to ensure that these patients are given 5 injections per year. The big question is, do we consider all patients as one? Is there over treatment? Is there under treatment? From what we have learned so far, only 15% of patients who come into Moorfields to date have managed to get off treatment in the first year. So it just tells us that almost every patient initiated on anti-VEGF therapy needs long-term therapy. In that case, then for us in the NHS, because cost is not an issue, we prefer aflibercept. We also have equal proportions of patients by 10 years who lose or gain vision because the natural history of geographic atrophy does cause trouble for us because there's no drug for that. We're just treating the CNV. There will be atrophy and there will be fibrosis, and these are sequelae that we can't get rid of. Even in the NHS, where drug is free, treatment is free, patients travel is okay, also free, the dropout rate is still significant. And for us, comorbidity is the commonest cause, but for other health systems, such as India, cost is a major issue. So we do need new drugs, despite all what we say about current drugs. Thank you.
Thank you, Shobha, for this very lucid talk. Specifically impressed about your long-term data, and done by Giri's fellow brings further happiness into this. You see, I just wish that there was a way to find out that at 10 years, equal proportion had gain, equal proportion had loss also. I know a lot of genetic studies are going on to identify which patients require more aggressive treatment, which require less. Practically, there's very little to offer as of today.
Correct. So we have done, I mean, we and many other groups have done the genetic analysis trying to correlate treatment response. To date, there is no evidence that genetics has got anything to do in response. So we are still at a loss with that. And we have done several imaging biomarkers at baseline to find out whether that's a predictor. Short-term predictor, yes, but not in the long term. Long-term natural history will take care.
This was pure ARMD, no PCV in this.
No, this is not PCV group, no.
Okay, any comments from Thomas or any other panelist?
Yeah, that was an eye-opener, in fact, Dr. Shobha. Thank you very much. In fact, that statement of you can manage an AMD with 5 injections per year for 5 years makes it very much cost-effective, even in a country like India, where we have been injecting so much without good results. Patients have been going bad, but 5 injections of aflibercept a year for 5 years, that makes it very much cost-effective and practical. Thank you very much.
After the first year you need to go fix it.
Yeah.
Does that mean monthly? Are you talking fixed monthly, or are you talking of fixed meaning?
Exactly like the VIEW study. We give the loading and go straight on to 8 weekly. So yeah, so it will be about 8 injections in the first year.
Dr. Shobha, I'd like to ask you one thing. This is my whatever analysis from my own cases. The patients who require only 3 injections are usually classic CNVM. They are not
Yes.
CNVMs.
Yeah.
So why do we still not, why do we not want to make that differentiation when we do the studies? Because we should not be including the data.
So we had only 15% of classic CNVs in our cohort. Our cohort, there were very few patients in classic CNV that did not need treatment. Because as I said to you, I mean, when we talk about overburden, we over-treatment, even classic CNV, we still treat them for 1 year. So maybe there is a way to improve that group by monthly monitoring, but we don't do that. We go by protocol because we did so badly in the first few years of anti-VEGF. It's a government instruction now that we have to do fixed for everybody. And if we don't, we do need to explain why that particular patient did not need it. It's hard to substantiate that. Some people after 3 or 4 injections remain stable and then they kick up again by about 8 or 9 months. And then the question will come, why didn't we inject?
But a subgroup analysis could have been done in the sense that, you see, although government pressure is there to follow that protocol, but it's, Dinesh's question could have answers in that if you do a subgroup, that classic CNV, at least for us, should not require so much of this, and whereas the other variety could require more aggressive kind of treatment.
And Shruti has been doing some work on this, and it shows that even in classic CNV, size matters. So if you have a small classic CNV, that needs less treatment. If they are big, they still go into the other category.
In fact, I would suggest that we missed out about PDT in this, because we also know from the Mont Blanc study that small lesions, combination therapy does very well, regardless of the lesion type. But we've just sort of thrown that into the waste paper basket. The second thing is, I think you undertreated many of your patients with occult CNVM, because when you give them, because what I have seen is that there is a group of patients for whom 2 monthly aflibercept is grossly inadequate. They require injections around 6 weeks or so. So if they don't get that for the next 2 years after the first year, then they will deteriorate. So we don't want that either. So I think part of the reason why the figures fell down for the second year was under treatment of those who needed more than sort of injections at less than 8 weekly. And that is a substantial group.
It is a very difficult, if we individualize patients, that's the ideal thing we should do. But when you start individualizing patients, our treatment protocol changes because there's a mass influx of patients. But I totally agree. There are loads of patients who after 3 loading injections, when you see them in 8 weeks, they are still wet. That 4 to 8 is, there is a group like that.
Okay, I think we'll move on. We go to US now, and we have our own colleague, Dr. Ravi, who is practicing VR in North California, to tell us about the same thing, that is clinical versus real world in DME. You just heard Shobha about ARMD, so Ravi will tell us about DME. Over to you, Ravi, and welcome home.
Thank you, Dr. Lalit. A wonderful webinar. Thank you, Dr. Gopal and the Cochin Ophthalmic Club for organizing this. I think this was Dr. Shobha's talk is a nice segue to my talk, because I think we are going to talk about the same thing. Overburden in treatment, under treatment, economic costs, and so on and so forth. So just a little bit trivia. We just want to get you away from the field of ophthalmology. This was the Comet Neowise. This was a picture I got. It was the first time I'd ever seen a comet. So this won't be back for 6,000 years. So one more box checked off in my life. So why do we need real world data? Why can't we just follow clinical trial guidelines? But real world patients are quite different, sometimes quite different from clinical trial patients. This is the baseline characteristics of patients with DRCR-V protocol, and look at their median A1C. I would like to follow these kind of patients. But we know in real world, we don't have the luxury of treating patients who have very good metabolic control. And real world patients miss appointments because they live in real world with real world problems, like, they need to, especially diabetic patients, they're in the working age, so they need to go to work, they need to feed their families, so they miss appointments. So again, looking at the DRCR-I protocol, 1 year visit completion was 94%. That's pretty stellar. So looking at my own data, sometimes I wonder how many of my patients, even treatment naive patients, come into this kind of follow-up regime. And in real world, cost does matter. Dr. Shobha talked about NHS, where government sponsors your cost of medications. But here in the US, different models are there. Private practice models do have the luxury of using aflibercept or ranibizumab. But there is still a cost factor. So I sent out a survey in my group. We are about 37 retina specialists, we're covering over 4.5 million patients in Northern California. So my question to the group was, does cost factor your choice of anti-VEGF medication? And majority said yes, sometimes it does. So what are the real world scenarios in diabetic macular edema? So you can have patients with central involving DME. I think Dr. Gopal went over some other scenarios. You could have good presenting visual acuity, and then you could have patients with moderate to severe visual loss. So let's look at patients with central involving DME with very good visual acuity. So which study should we fall back on? So we look at DRCR-V protocol. So in the DRCR-V protocol, patients with vision better than 20/25 were followed up for 2 years. There were three different treatment regimens. They were not three different treatments, but 3 different treatment regimens. One, the group with aflibercept only injections, and the other 2 were laser and observation with use of aflibercept if there was worsening vision acuity. And the thing to notice, so they all did okay. I mean, it's less than 10% of patients had lost more than 10 letters at 2 years. So I think if we translate that to the real world, yes, I think in our this is true of the PAT survey too. Like majority of patients can be followed up if they have central involving DME and they have good visual acuity. Observation is a good choice. So some real world examples. Here is a 62-year-old diabetic. She's very educated. She knows what's happening. She always is looking at her A1C. And nowadays we have this. They can monitor their blood sugar in an app on their phone. So patients are more aware. So. So 2 years later, she's still doing fine. No treatment. Vision is 20/25. She continues to do well. Here is a 42-year-old type 1 diabetic. So he came with an A1C of 10.2. So I sat with him. I told him, if you go down this path, you'll be blind. You'll be in a wheelchair. You'll be needing dialysis. Something struck in his mind, and then he took it to heart. He underwent a gastric bypass surgery. He brought it down, his A1C. He said, "Oh, doc, I'm not a diabetic anymore." Yeah, and his A1C was 4.6. And he said, "Oh, my vision is blurred." So what happened there? So there was some worsening of his central foveal thickness. But before all these trials about anti-VEGF treatments, we had the DCCT trial, so which showed that yes, in patients who are randomized to intensive blood sugar control, yes, there could be some early worsening, but that plateaus off and then they do well. So had to hold his hands, explain to him that this is temporary phase, keep working on your blood sugar, we'll see you back in 3 months. But there is a caveat with the DRCR-V protocol. So there in the protocol, the visual acuity was used rather than the central foveal thickness as retreatment criteria. And the visual acuity, as in any clinical trial, is very stringently measured. So this is used using the electronic version of the ETDRS. I have done some of those EVA measurements. They are very stringent. So obviously that cannot be replicated in practice where you're dealing with patients and your tech is measuring the vision. So, but I think overall, and then the V protocol did not mention anything about severity of retinopathy. So overall, I think it's still applicable in real world. If you have a patient with center-involved DME, I think, with Dr. Gopal talked about, we still have to counsel these patients. We can't just let them go, kind of arrange a suitable follow-up. So what about moving on to the next scenario? This is a classical patient with central involving DME, with vision worse than 20/30. So what is the preferred anti-VEGF treatment? How many treatments should we do? Should we use focal macular laser? Should we use steroids? These are all the relevant questions. So I threw this question out to the group anyway again, and this, in US, I think bevacizumab is still used. We use it a lot. I know in NHS and in India, I was talking to my sister, and then it seems like Avastin is a big taboo there. So, but even in the past survey, 50% of US physicians still use bevacizumab as the initial treatment option. And Dr. Gopal talked about the protocol T. What about patients who had initial vision which was worse than 20/50, or so where aflibercept and ranibizumab had proven to be superior? But even there, again, I add a caveat that this is not, this is from the data from our own group and doesn't apply to US practice in general. Academic practices differ, private practices differ. But bevacizumab was still that initial drug of choice. So looking at the DRCRT protocol, so as Dr. Gopal alluded to, so if the baseline visual acuity was good, the three treatment arms didn't matter. The ranibizumab, bevacizumab, and the aflibercept didn't matter. But if you look at 20/50 or worse, that cohort did better with aflibercept and ranibizumab compared to bevacizumab. So, just looking at clinical trial data, so we should not be using bevacizumab as the first treatment with patients who have visual acuity of 20/50 or worse. So how does it translate to the real world? So fortunately, the T protocol patients were followed up from year 2 up to year 5. And that kind of gave us some real eye-opening statistics about these patients. So these patients were followed up as part of their clinical care, and not part of a study between the years 2 and 5. And their data was reviewed, their visual acuity, OCT images were reviewed. So certain pertinent questions were: did the participants continue to care with the retina specialist? How many treatments did they receive? How often did they get it? How did their vision and their oral OCT profile change between year 2 and 5? So basically at year 2, they exited the clinical trial. So how did they fare after this? And how many eyes still had DME at 5 years? So out of the 558 patients in the original T protocol, about 70% of patients, data was still available. And the baseline characteristics between the group who still were followed up and who were lost to follow up, the baseline characteristics were similar. So majority of patients were still under the care of a retina specialist. That's a good thing. So a lot of these patients, they come to clinical trials and they think, they received some treatment and then they're done. So fortunately, most of these patients were still kind of followed up, as regular standard of care. The mean number of visits was about 14. So that's roughly about 3 to 4 visits per patient per year. about 70% of patients still needed treatment. So only 30% of patients did not need any treatment after they exited the trial, and 70% of patients needed some form of treatment. And the good news is, I think it validates some of the things we have been doing. Almost 1/3 of patients in each treatment arm did not need any treatment. So that's a good thing. And about half of them kind of continue to remain in the same group as they were originally assigned to. So if you are in the bevacizumab group, so there's a 50% chance, 51% chance that they continue to remain in that group between the years 2 to 5, so that they continue to get bevacizumab after they exited the trial. So that includes also the 32% which did not need treatment. So uniformly, that I think that's a very key point, that 1/3 of these patients did not need any treatment. So what happened to the visual acuity? So Dr. Sharma mentioned about the AMD patients losing vision in NHS, and I think we have seen this recurrent theme since morning. So again, an average patient who had gained about 12.2 letters at the end of 2 years lost almost 4.7 letters at year 5. So definitely the initial gains was lost, not completely, but some gains were lost. And what about across the treatment arms? So across the treatment arms, uniformly, again, all the patients lost vision. So even if they were in aflibercept group or bevacizumab or ranibizumab, they all lost vision. So again, in the subgroup analysis, if they had good vision, they lost some, and then the 3 treatment arms were similar. But if they had poorer vision or 20/50 or worse vision, again, all the treatment arms patients lost vision, but again, the bevacizumab group fared worse than the aflibercept and the ranibizumab group. So again, it kind of drive home that point that if you are dealing with a patient with vision worse than 20/50, we need to relook at the choice of our anti-VEGF treatment. I think it drives home the point that bevacizumab is not as good compared to aflibercept and ranibizumab when the vision is 20/50 or less. So what happened to their OCT profile? Surprisingly, they continue to do well. So they had lost about, the subfield thickness had reduced by 150 microns when they stopped the trial, which continued to be maintained even at year 5. And then this was uniformly true across all the 3 groups. So which begs a question, what has happened at the biological level? So I don't think we have answered to that question yet. So how many treatments did they receive? We talked about it. So 1/3 of patients did not need any treatment, but an average, the median number of injections was about 4. So that's 4 in 3 years. So an average patient got about an average 1 to 2 injections a year. So in summary, the protocol T extension data shows that yes, even after exiting the trial, these patients are still receiving retinal care. That's a good thing. And majority of patients are still receiving some treatment, but most patients have lost the visual gains they gained during the clinical trial, and then the visual acuity worsened at year 5. But the subfield thickness on the OCT profile was similar. So of course, it's a limitations. It's because it was a retrospective analysis, and then they can't compare the treatment arms because the treatment was at investigator discretion. So, but there are some limitations. But I think some of those points were kind of very eye-opener. So we looked at, this is from a satellite office, we looked at our own data. I mean, it's still unpublished, still kind of analyzed 100 consecutive patients with DME who had received treatment, had finished 2 years, completed 2 years of follow-up. Baseline characteristics, about 50% were moderate in PDR. So like I said, our group prefers bevacizumab as an initial treatment. I did not subanalyze like how with anybody with worse vision acuity received aflibercept or not. I don't believe so. All patients received 4 monthly injections. Patients were switched to ranibizumab or aflibercept if the edema persisted beyond the treatment. So B number of injections at 1 year was 7.2. At 2 years is 11.7. Again, like I said, bevacizumab was the go-to medication. Focal laser, about 15% of patients, only 1 patient had the Ozurdex implant. This was, not too bad. This is again at 2 years. The baseline visual acuity improved from 20/80 to mean 20/40. The central subfield thickness decreased by about 100 microns, but only 10% of patients had resolved edema, again, which was defined as absent edema in 3 consecutive visits. So this is some of the patients from our own data. So this is a patient who had presented with 20/60 vision, received 12 intravitreal bevacizumab over a 2-year period. She's doing well, but still needs follow-up. She's doing 20/20 vision. Another gentleman had initial bevacizumab, not responsive, switched to aflibercept. At the end of 2 years, good recovery, 20/30 vision, some disruption of the ellipsoid zone, but reasonably happy with the outcome. Another patient who had resistant to bevacizumab, and then switched to ranibizumab, no effect. Didn't try aflibercept, but did the Ozurdex implant. He did well, of course, with steroids, as we know, that he developed a cataract, his pressure went up, and then, he had recurrence of, so that it's an ongoing thing with him. He receives, I think we had to switch him back to aflibercept because of his steroid response. So just answering some of the other questions from our own group. So macular laser, still sometimes majority of our providers do use it as an adjuvant treatment. Steroids, none of our physicians use it as a primary treatment, but yes, in treatment-resistant patients, steroids are used. I think there was the data also showed that majority used transrenone as the first choice of a steroid. So what about big volume data? This is published in Ophthalmology Retina in 2018. This was a retrospective review of large database of patients who underwent DME treatment in a private practices in United States. Patients, eligible patients underwent at least 3 anti-VEGF injections within 4 months or a 6-year period. Overall, they had 15,000 patients, out of which I think 1/3, about 5,000 patients had finished 2-year, they had data for 2 years. So the distribution of treatment was slightly skewed because they didn't have the results of the VISTA and the VIVID trial set. So the aflibercept group was less compared to the ranibizumab and the bevacizumab group. So the mean number of injections was about 12.8. It's kind of similar, or it's for 2 years. What we are finding, I mean, again, in the US practice, it's the less number of steroid use and focal laser, not so much. So what did the data show? Again, the data showed that after the initial gain, after the intensive treatment, patient did lose some vision at year 2. So it was not sustained. So the number of injections across the 3, this is not a treatment arm, it's a retrospective study. It's just, comparison of the 3 treatments showed that the number of injections were similar. The mean vision acuity, this was very underwhelming. So the aflibercept group, the mean improvement at 2 years was only 4.7 letters. So contrast this with the VISTA and the VIVID trials, where an average patient gained about 11.5 letters. And it was even underwhelming in the ranibizumab group, where the average patient gained only 2.3 letters. And compare and contrast with the RISE and RIDE trials, where an average patient gained 12.5 letters, here is less than, it's about 2.3 letters. So very striking data. So so again, it's not in US. This is a study from Japan. It's a retrospective study, treatment naive DME for patients followed for 2 years. The final improvement in visual acuity was only 2 letters. Both in they had anti-VEGF monotherapy as one group and combination therapies where they had used steroids. So again, very underwhelming results. So so in summary, real world DME experience. I think we've been seeing this whether in India, it's true here too. So experience worse visual outcomes compared to patients in clinical trials. Under treatment, I think that's the theme. Whether it's AMD or DME or retinal vein occlusions is one of the reasons for this worse outcome. I think a lot of patients do employ PRN regimen or treat and extend in diabetic patients, which really doesn't work because you're dealing with an ongoing disease. Real world patients, in contrast with the clinical trial patients, also have poor metabolic control, and then there are other coexisting conditions, hypertension, chronic renal insufficiency, which may influence the outcome. And clinical trial patients obviously fare better because their visits are paid, and then they have travel vouchers, and then the clinic. Whereas our real world patients, like I discussed before, they deal with real world problems and they miss appointments. And of course, in clinical trials, patients who have ERM and VMT, these patients are excluded. And we know, like, patients who had PRP have some form of ERM. So proliferative diabetic retinopathy patients tend to have this ERM patients with macular edema, which won't respond very well for anti-VEGF treatment. So in summary, data suggests that in real world, patients with DME are undertreated and have less than expected outcomes compared to data from clinical trials. Patient compliance, variance in metabolic control, financial costs, and treatment burden are some of the factors implicated in worse outcome. And strategies to improve, we need these strategies to improve long-term visual outcome in these patients because these are still in the working age group. So they need to maintain their vision. So I think future studies targeting alternate molecular pathways and of course innovations like the sustained release devices would provide some of the answers for this. Thanks a lot for your patience hearing.
Thank you, Ravi, for summarizing the real world data. You see, all of us agree that the real world, the gain is less than clinical trials. But I think optimization has to be done. So do you think that we treat more aggressively? What do you tell our patients? You see, this is not tolerable that 2 to 3 letters vis-a-vis 14 letters, what you showed in that graph.
Yes, I think it's quite an eye opener, which I've realized too, that these patients, we need to be aggressive when we counsel them. I think Dr. Gopal talked about how do we lay out the treatment management plan. We have to talk about in terms of 5-year plan, not just say, oh, you come for 3 injections and we'll see what happens. So we have to lay it out and say them, this is what is, over the next 5 years, there'll be multiple visits involved, and we have to counsel them about blood glucose control and what to expect in terms of the improvement. So I think counseling is an important factor in a busy clinical practice. I think we miss out on that. But
diabetes is multifactorial disease. You see, compared to ARMD, where you can't. Diabetes, at least all of us, I think, scare the patient so much. And what generally happens is that once you scare the patient with the need of injections, metabolic control, not only for the patient, for the entire family, tends to improve if you scare the patient very well, because if you scare him very well. and ask him to reduce weight, like you said, one of the barbaric surgery your patient had, and his HbA1c dropped down. I think diabetes should be, if we should, all of us should be able to better manage compared to ARMD, because the VEGF is not as high as ARMD, and the number of injections required are not as great as ARMD, and the regimen followed also is not as strict as ARMD. So therefore, I was slightly, this thing, data, what you showed, 14 letters versus 2 letters, which is not acceptable.
Yes, yeah, I do agree. I think we need to do a better job with diabetic patients.
The reason
we want to talk directly, because how do you counsel your patients so that they come nearly close to what Ravi is saying?
Okay, I'll come to that, but one thing I wanted to point out, that diabetic patients are less faithful, they are less compliant as compared to ARMD patients. So that's the reason why they don't do well, because they think they...
That's the age gap.
Yes, so let's come to... Yes, so if you want...
Now we come to Dinesh's talk, because I believe that this talk was inserted by me actually, because how do you talk to a patient? You see, patient has come for the first time to you, whether it is DME, AMD, or vascular block, or who requires anti-VEGF injections. And we have the real world data on one hand, and we know that these patients are less compliant and they need a relative to bring, and cost is involved, number of injections, not like NHS where funding is by, even for travel funding is by the government. But here it's a totally different scenario. So I wanted Dinesh to tell, how does he counsel? How does he counsel? Does the patient have to sell his house or his village or whatever? Yes, Dinesh.
Can you see the screen?
Yes, carry on.
Thank you, Lalit. I think you built the right base for this talk. And the fact is that, and in fact, it started with Ravi talking about the need for counseling. The fact is that ultimately, I think that is the weapon which we are not using adequately enough. You made intravitreal injections ubiquitous. They're there for everything: DME, choroidal neovascularization, vascular blocks. But the question is that any effective treatment for any procedure requires good patient-physician communication. And what does that do? That creates the trust. And that trust is what will lay the next thing, the foundation of this trust. How will this come? You need to have complete transparency. Whatever we are discussing here, that has to actually go in simple words into the patient's ears also. Then it works. And this transparency is achieved by counseling, provided you convert that information, which was in medical terms, into routine terms. So what is this counseling about? This counseling is about the disease process. It's also about the options available for treatment, their costs, the risks and the benefits. And when you talk about cost, you don't talk of one injection cost. You talk of cost per year. And also the nature of the treatment, the duration of the treatment, the number of treatments required, so that he knows what are the total costs involved. Is the counseling the same for all types of injections? Does one shoe fit all? No. An injection, and it's not an injection, is not an injection. There is a huge difference in the counseling done for ARMD versus the counseling that we would do for DME. Is it okay to say, well, let's give one and see, and then we'll see what to do? Well, not for most disorders. I believe that is a waste of the patient's resources, which if he thinks it's only one injection, he scrounges all his resources for that one, thinks that's it, not realizing this is only the beginning. And for many diseases, this could be a waste of his resources. The other important thing, a tendency to trivialize. This is not a trivial thing. It's, don't worry, it's only a 5-minute job. Not really. Don't trivialize this procedure. It's an intraocular procedure, has major risks. So there is what I call the general counseling, which is applicable to all intraocular procedures. So I will tell them about the risks of endophthalmitis, hemorrhage, retinal detachment, risk of worsening despite treatment. But the first three, I will tell them that, look, these three are the main risks. But the risks together are less than 1%, but it's important for you to know so that you don't think that this is an innocuous procedure. This is not an innocuous procedure. However, we are going ahead and doing the treatment because the benefits are much more than the risks involved. Now, as far as specific counseling for each disease, for exudative age-related macular degeneration, the patient, I would try to tell him how many injections, how much benefit, which injection, cost of injection. So how do we go about that? Now, the first thing is we know that 20% of the patients do not need any retreatment following the first 3 injections. Also, the rest of the patients could need any number of injections varying from 1 more to 5 more. So there's a huge individualization required in the treatment. It's difficult to predict, but you can tell the patient that, look, 40% of the patients have a chance that once in a quarter injection will be enough. But the rest may require injections as frequently as every month. So this is important to tell to the patient. When the patient asks, what injection will you use? Now, you see, when you talk to the patient, you have to, of course, tell him about the costs. And then you have to tell him that, look, preferentially, if you had PCV or occult CNV, I prefer to give aflibercept. If you already had injections, not responded to ranibizumab, that's another category where aflibercept becomes an important treatment. Also in patients who need ranibizumab more than 8 weekly, that means every 6 weeks, every 4 weeks, these are patients where aflibercept is a preferential drug. But I would consider ranibizumab in patients who've got predominantly classic CNVM or who've got an inflammatory or idiopathic CNVM, or patients who are requiring aflibercept very frequently, every 6 weeks. Now, this last group is because I don't want to give too many aflibercept injections. I believe that the incidence of geographic atrophy is more in these patients. Just give me a minute. Yeah, so I'm sorry, that's my dog.
Also requires some counseling.
Yeah, he needed some counseling. Yeah, so the other important thing is before you say which treatment, you must explain the alternatives to the patient. So there's aflibercept, there's ranibizumab as the innovator drug, the biosimilars of ranibizumab as well as bevacizumab, and you must explain the patient that economic issues are important. If he says I can afford bevacizumab every month, but I can't afford aflibercept, so be it. Don't shift him to aflibercept and find that he's become bankrupt. The standard of care is given if the patient says I have no economic issues. But if there are economic issues, go to the biosimilar, that is ranibizumab. And if he says even that is too much for him, you can go to bevacizumab or even the biosimilars of bevacizumab. And we don't give bevacizumab. In our case, we refer them to RP center where the drug is available very cheap. How long will the treatment continue? You have to tell the patient. So some statements have to be a little dramatic. So I tell my patient, as long as you live, or as long as I live, but if I die, find a new doctor. The fact is that only 20% of patients are lucky enough to get away with 3 injections. Most will require quarterly with ranibizumab, and 60% also is the maximum who can get away with aflibercept on a quarterly basis. The rest will need more frequently injections. But the important is whatever the frequency of your injections, for the first year or 2 year, monitoring is going to be monthly. And that is what results in the best results. Nothing else works as effective as monitoring and treating the moment you find the first recurrence. The good news, when you give a stick, you must give some carrot also. If you follow adequately, if you treat adequately, you can expect to maintain your vision for many, many years, maybe hopefully as long as you live. The other important thing, you have to give him some hope. You're never going to go blind. Your ability to read will get tremendously affected if you don't get treatment, but you will be able to walk around in most cases. you will be ambulatory in most cases. This is very important to build hope for the patient. It's very important to use both the carrot and the stick, tell both the aspects, the good as well as the bad. Now, when it comes to diabetic macular edema, the counseling is completely different. I tell them, look, this is a finite disease for most of you. With proper monitoring and with proper treatment, you can expect to get away with something like 8 injections in your first year. If that you take properly, you will end up with 4 or so in your second year, and maybe 2 or 3 in the third year. And then it'll go down to 1 or 2 injections, but you should be able to maintain yourself. Now, this is important because if you don't do this, then we will not get these results. The other thing he asks is, well, what about me? Will I improve? Will I tell him, look, 25% of the patients who got this injection for DME did not need injections in month 3 and 4. And if you're one of those who after 3 injections doesn't need injections, the response to you is going to be great. You're likely to be, so the response to your first 3 injections is also a prognosticator for you. On the other hand, if you do not respond well to the first 3 injections, if you end up requiring, and there are going to be 20% of patients who require injections month after month. Well, today we are not going to let you go month after month for 24 months with injections. We will give you an alternative, and we have alternatives in the form of steroids as well as aflibercept, which can both help to decrease the number of injections and can improve your management. The take-home message being, this is a systemic disease. If you improve your environment, that means your blood sugar, your lipid profile, your nephropathy status, the hypertension status, you will improve. So if you do all those things, your eye will also improve. If you don't improve them, then the eye will also not improve as much. Our treatment alone will not be good enough. With regular treatment, we should be able to give improvement to 50% of patients. And the rest of the 45% will be close to stability if you don't miss your treatment. Otherwise, each time you come, you will get another injection and you'll say, well, nothing seems to be happening. Yes, nothing much will happen because you've not taken adequate treatment. Also, don't worry if you don't respond to your first treatment, your treatments with ranibizumab or with bevacizumab. We have steroids for you. Ozurdex can help you as a second-line treatment. I don't give that as a first line. I will explain that to him because that has more risks. So we go for safety first, and then we are accepting a little less efficacy. As far as those who can't afford Ozurdex, we tell them the triamcinolone is available for you. The third group of patients is proliferative diabetic retinopathy, and say, hey, can I be managed without lasers? So we said, yes, you can. You will need something like, even if you don't have macular edema, you need something like 10 injections in 2 years. And if you have diabetic macular edema, it could go up to 14 injections in 2 years. Now, the other important thing. So if you take monotherapy, be prepared for 14 or more injections. With possibility of more, this disease may not go away. Your fields may be better. But remember, the laser, at least in studies, has not been shown to affect driving ability. The fields don't get affected. Though they get affected, the driving ability has not been affected in most of the studies. There will be a need for follow-up continuously then if you want to take injections for proliferative diabetic retinopathy. Because if you don't take them, you may end up getting a worse form of the disease. And patients with maculopathy, they need something like more than 8 injections for 72% of the patients. Patients who don't have maculopathy, more than 8 injections are needed in 1/3 of the patients. The third important group is the vascular occlusions, and I'm going to differentiate between branch retinal vein occlusion with macular edema and CRVO, because BRVO is a more innocuous disease. Spontaneous recovery is going to occur in 2/3 of the patients. So don't worry. I mean, it's not as severe a disease. Final visual acuity is usually good up to 6/12 or more. And persistent macular edema is usually seen in 5 to 15% of patients during a 12-month period. But of course, there's also a risk of neovascularization. Now, the important thing is if the vision is very good, duration is less than 4 weeks when the patient presents to me, he doesn't need treatment, which is what was also discussed by Meena. I would follow this patient up to weekly. I would tell him, we'll keep you only on follow-up, no injections. And there's a possibility that you may recover. There's a 50% chance you may recover without anything. If you deteriorate, we will treat you. And this is just to corroborate the same. This is patients whose duration was less than 60 days, and actually there was no difference in the outcome. So even if you wait up to 60 days, yes, if you wait more than 60 days, the outcome was affected. So I say, watch them for a month. If they deteriorate, treat. If they don't treat, if they don't deteriorate, you can just do observation. On the other hand, patients who've got chronic disease, I also want them that we will, if you're not responding to the injections alone, we will give you laser treatment, and that will help to improve your vision. And this is what you see over here. Ranibizumab with laser had better results than only ranibizumab monotherapy. So, and these are all evidence-based studies now. Now, if the patient's vision is less, I tell him you have a choice of bevacizumab or ranibizumab. The injections are needed till the vein recanalizes in its natural course. The moment it recanalizes, you will need no more injections, but we don't know how much time it will take to recanalize. And if it doesn't, the recurrences are going to be there and you're going to need multiple injections. And if that is happening, we will give you adjunctive laser therapy, which will also decrease the number of injections required. The important thing is your outlook is optimistic. This is usually a self-limiting disease. Vision maintenance and improvement is usually possible and sustained. So don't worry. And if you're not responding to anything else, we still have steroids as a second-line treatment for you. So this is what the counseling for BRVO is. In CRVO, on the other hand, we know this is a bad disease. Chances of losing vision without treatment are high. The patients respond well to treatment, both with ranibizumab and with aflibercept, probably better with aflibercept than with ranibizumab. Recurrences are common after each injection, and therefore, and again, the spontaneous, this is what I will tell him, that recurrence will, the spontaneous regulation, recanalization can occur, but may take months to years, and you're going to need injections till then with regular follow-ups. With anti-VEGF treatment, we can maintain this vision for a long time, but your follow-up every month till you stabilize and become okay is for a long time is needed. So it's not a short time treatment. You have alternatives of ranibizumab and bevacizumab, and you have steroids as a second-line treatment. The most important thing for all injections, not only CRVO, regular follow-up is imperative. You go from 4 weekly to more longer follow-ups only when your patient has become completely all right for a long time. And the risk in CRVO, of course, is of ischemic CRVO and NVG. So we may be doing laser for you also if you have peripherals, if you develop peripheral ischemia, which is severe. But with treatment, we can help you. And we can help you in all these diseases. This proper counseling, ladies and gentlemen, is mandatory. It helps to improve patient confidence. It minimizes litigation since the patient is a partner in this management process. It prevents disappointments due to undue expectations. It keeps the patients, the relatives, and the doctor happy. Thank you very much.
Thank you, Dinesh. What I would say is a difficult topic made relatively easy. In fact, all of us should copy all these slides and remember and revise and talk to the patients if you don't want to lose your patients and if you don't want your patients to lose vision also. I think he has categorized in various categories, and that is very, very relevant. We will have some discussion on this, but I would request Dipender to, upload his talk on another very important topic, that is cataract and anti-VEGF agents, which a lot of anterior segment people and cataract, they keep asking about this. Dipender, are you ready?
Dipender,
Yes,
please
ready,
unmute.
sir.
Yeah. Yes, Dipender.
Shall I start? Or?
Yes, please.
for sir, DT sir?
Yeah, please start.
Okay, yes. Thank you, sir, and thank you, Gopal and Cochin Ophthalmology Club for inviting me for this topic, intravitreal injections and cataract surgery. I'll try to stick to my topic because all the speakers have very comprehensively covered a lot of things about intravitreal anti-VEGF injection. And let's see that is this a important topic for all of us. Now we have all of have witnessed this in our career, that slowly intravitreal injections have now become the most common operative ophthalmic procedure, and they have overpassed cataract surgery, which is still the second most common. And if you go through all these trials, try to see their patient profile, almost 65 to 70% of these diabetic patients were phakic patients. And if you are treating them for good 5 years, so it is quite obvious that you will, I think, intravitreal injections and cataract surgery will frequently cross roads. So this discussion on this becomes even more important. Now, if I see this topic, I think I see two situations. One is a patient was on regular intravitreal injections and he has now developed cataract. Second situation is a patient comes seeking opinion for cataract and he gets diagnosed with a medical retina condition which needs injections. Now here I'll just quickly call for, I think for our comprehensive ophthalmologist, it calls for a very careful preoperative assessment for macular disorders in all patients who are seeking opinion for cataract. And if possible, try to do OCT for almost all these patients. I'll rather recommend to consider OCT as a method of examination rather than an investigative modality. Now, indications for anti-VEGF have been very nicely covered by all my co-speakers. So I'll not read all these, but if you see in our real life, there are two major indications for anti-VEGF. One is macular edema, either from diabetic retinopathy or retinal vein occlusions. And second big group is a neovascular AMD. So we'll try to see situation-wise and etiology-wise. So if you have a situation one, patients with neovascular AMD on regular injections, he develops cataract. So now first question which comes to our mind, especially our comprehensive colleagues, is should I postpone the cataract surgery because visual potential is poor? And we see a lot of these patients being denied cataract surgery for a very long time, until somebody finds them and explains and counsels and do a cataract surgery. And there are a lot of studies which have now found that cataract surgery will not influence their disease activity. Rather, there is an advantage of doing cataract surgery in these patients. You get better imaging, especially if you have to do an ICG or OCT angiography. Then your type 1 CNVMs with good vision, I think they also, they are doing a lot of self-monitoring when they are you are trying to extend their follow-up intervals. So if you remove the cataract, which is a confounding factor, your accuracy becomes better. And third, these patients, they have compromised central vision. So if we improve visual field, we are going to rehabilitate them better. There are lots and lots of studies. I'm not going to go into the detail. This one is a good read, 2015 ACTA, and they've reviewed almost all the studies available at that time. And their final conclusion is that cataract surgery should be encouraged. And of course, all of us have been trained to judge whether there is a significant cataract or not. But if it is significant, we should offer cataract surgery. Now, second question, which comes to our mind is, should I combine cataract surgery and injection in same sitting? Because these patients are coming frequently, so you want to reduce their visits. In our practice, we have hardly done this because there was never a demand coming from patient for this. And of course, technically, when you are combining cataract surgery with vitreous surgery, you can combine injection also. But there are few arguments in support that there is no urgency to combine cataract and intravitreal injection in AMD patients. And theoretically, at least, I'm not aware of any study which has evaluated, but theoretically, there is increased risk of infection and probably raised IOP also if you are combining it. And if you are not going to put a suture because of high vitreous pressure, either there can be a wound leak and more chances of infection, or it can also lead to forward pushing of lens, and maybe it can affect post-operative anterior chamber depth and effective lens position. And it is a big financial burden if some patient is on aflibercept or eccentrics, and you combine cataract also. So for these patients who have a regular expense on their injections, the cataract surgery is another added expense. So combining may not be a good idea. Now, third question is, okay, we are not combining, so when to do cataract surgery? So in general, what we follow in our practice is that we try to schedule cataract surgery at least 1 week after the injection. And the main reason is that we want eye to settle down, be comfortable for another topical intervention. But another reason is you don't want to do a cataract surgery in an eye post injection, which is under incubation for any infection. It can be disastrous, like if patient is developing a very slow post-operative end-off and you are doing cataract surgery over that. So similarly, if you have to give an injection after cataract surgery, 2 weeks is a safe interval. You get nice wound stability after 2 weeks of phaco surgeries. So now, but if you see the second category of patients, patients having macular edema either from diabetes or retinal vein occlusion, and they are on regular injections. Now, these are different patients, because here all of us know very clearly that cataract surgery can not only worsen macular edema, it can also worsen and accelerate the progression of proliferative disease. So we have to stabilize both of them, macular edema as well as proliferative disease, before planning a cataract surgery. Now, in general, if we get a patient who has macular edema involving center and cataract, and if he or she is not a steroid responder, our preferred choice these days is dexamethasone implant, but I'll not go into the details because today we are focusing on anti-VEGF. So the question then we would ask from ourselves is, when should I use anti-VEGF before cataract surgeries in these patients? So first indication is, as I already told, that patient who is a steroid responder. Now, second category is a patient who has active PDR and center involving macular edema. So I think anti-VEGF is a better option for these patients because it will act on both. Third category is if media is so hazy that it will not allow you any good laser. So those are the patients where you can give anti-VEGF injection with laser. Now, another category of patients where you have a proliferative disease, either coming from vasculitis or RVO or PDR, and they develop NVI and cataract. These should be given injection before cataract surgery. It will not only regress the new vessels in the posterior segment, it will also reduces the chances of hyphema and other things. But I am not saying that if media is clear enough to do laser, just jump for injection and go for cataract. Still try to do as much as laser possible for these patients before planning a cataract surgery, even if you have to do with LIO. Now, the second question which comes to our mind is that, should I, when there is a DME patient on injection, should I try to make macula dry before cataract surgery, or when should I plan cataract? So if possible, if it is a treatment naive eye, fresh DME, try to make macula dry before going for cataract surgery, especially if you are planning anti-VEGF, because anti-VEGF have a shorter duration of action, unlike steroids, where you can still operate with OCT at 300, and that DEXA will take care of post-operative resolution of DME. But on the other hand, if you have a refractory or recurrent DME patient who are never going to be dry, you try to operate them at their best anatomical condition. Again, you have to do serial OCTs. Now, third question again in this category of patient is, when should I schedule our cataract surgery after giving injection? So again, for the reasons I given earlier, 1 week is a good interval, especially for anti-VEGF injections, because yes, they have a longer half-life, but most of them will have their peak effect by 7 to 10 days. And we sometimes do serial OCTs. Very few patients keep on getting better beyond 2 weeks. So if or you can also use OCT to plan your cataract surgery. If you get a dry macula and if your treatment goal was dry macula, you have achieved that, you plan cataract surgery. Otherwise, you postpone, give another injection after 4 weeks of first injection, and then reconfirm with OCT. Now coming back to the situation second, that there is a patient who has come for cataract, but now we have diagnosed a retinal condition which needs injections. So again, I think I'll highlight that and even myopic patients, like previous speakers have highlighted, the type 1 CNVM and myopic CNVMs, they can easily get missed. So it's very important to do OCTs for all these cataract patients. And if you are doing very OCTs selectively, at least do in those patients where you are not able to see the foveal reflex. That is again a good guide for colleagues who can't afford to do OCT for all cataracts. And once you have diagnosed the patient with AMD or other CNVMs, they have to be counseled, like Dr. DT sir has already highlighted. Important thing is to teach them about home monitoring and also inform them that there is a fellow eye risk coming from CAT trials, and a lot of OCT angiography trials are now saying that 1 year risk of fellow eye CNVM is almost 12 to 14%. So this has to be informed to patient. And it may not be a bad idea to connect them at least, or have an opinion from a retinologist who can evaluate it and then decide the treatment regime. Now, for DME and RVO, they probably needs much thorough evaluation before planning a cataract surgery, where you have to do angiography and you have to look at the morphology of macular edema to prognosticate and chart out the whole plan for the patient. If there is traction, you can always discuss a combined surgery. Again, they all need to be counseled for a long-term follow-up, like DT sir has highlighted. So, but do consider a combined surgery if you see traction in these patients. Now, I'll now quickly run through a few slides to how do we plan and do cataract surgery in these patients or who are on injections for neovascular AMD or DME. Now, one thing is very important to set the realistic expectations. And for AMD patients, what works well is you make them feel their scotoma, make them aware of this thing that they have a central field loss, and that is not going to change much after cataract surgery. So that is something they should realize. And once you counsel them, I think they are the happiest patient after cataract surgeries because their peripheral field gets better. And second, like our previous speakers have also highlighted, and even Pronto, the first study which used OCT, highlighted that we have nothing available for geographical atrophy. It keeps on progressing. So that again has to be highlighted because that can lead to late disappointments. Another thing, what we do in our practice and why I want to share with all my non-retina colleagues is that do not try to overuse quinolones in your practice, especially for injections. We don't give any pre-injection antibiotics, and we, for more than a decade, are using chloramphenicol for post-injection. And prime reason is this, that someday they will need a cataract surgery and we don't want quinolone resistance in them. A third, and probably the last thing is cataract surgery in these patients same like for other cataracts? No, I think it's little higher risk of posterior capsule rupture, inflammation, and even infection when you plan surgery for these patients. And intraocular pressure has been very nicely and lucidly discussed. So, and if you see the ocular adverse effects in all these trials, 1, 2, or may sometimes 3 eyes have developed traumatic cataract from needle injury. All of us have seen it. So be prepared. These cataract surgeries can behave like a posterior polar cataract. So plan it in a place where you have a VR backup. This is a very good paper. I think in Ophthalmology 2016, they have, it's a big data study coming from these Medicare beneficiaries, more than 2 lakh eyes. And they found almost 126% higher risk of PCR, which required any intervention. I'm sure actual rate of PCR must be higher than this. So this is something we need to be aware of when we are planning cataract surgery for these patients. And I'll not go into surgery. So to sum up a few take-home points, one is that For neovascular AMD patients, cataract surgery can be scheduled at 1 week after injection. And if you have to give an injection, you can schedule it 2 weeks after cataract surgery. For patients having macular edema and proliferative diseases, it's better to stabilize the retinal disease before going for cataract surgeries. Use imaging modalities. One common thing which we see in our practice is angiography is now very less done. I think when any such of patient is approaching cataract, that is the right time to plan an angiography. Look for ischemias and new vessels. Restrict your use of quinolones. And of course, you need a cautious approach for doing a cataract surgery in these patients. Thank you.
Thanks, Deepu, for your excellent talk and segregating AMD and other vascular disorders, because that was to be brought out, because AMD generally has known. There are occasional case reports where there has been negative, but by and large, not at all. AMD does not influence, or cataract does not lead to progression of AMD. I think there are very good take-home messages like DME stabilize as far as possible. And one excellent point you made was that message for NTA segment surgeons that OCT is a must. To prevent visual surprises, you see, they should not be, feeling bad that patient has not gained in surgery. It helps them in so many ways. But, expecting that, you operate with retinologist and opinion from retinologist, this will never happen. This does not happen. You see, they refer. If you tell them that do OCT, they may still do it. But I think this is a very good message. You have told that OCT is a must before virtually any cataract surgery. As I said, to prevent visual surprises, or especially if they are doing high-end surgeries with 6/9, 6/6 vision with say Californian type of cataract, and they may land up in trouble, because you see a lot of studies from West, also from India. There have been 3-4 studies where around 15 to 20% patients who undergoing cataract surgery, routine cataract, have been found to have some alteration in the macula. ERM is the commonest thing, or VMTs, and sometimes lamellar macular holes or Scheisses or macular, they have been found. So I think these are very, very important. Anybody else, Thomas or Sai, or anybody wants to have any other opinion?
Yeah, Dr. Deependra, very often we come across patients who have a lot of systemic issues, cardiac issues, nephropathy, patients on dialysis. In these patients, when you decide that you have to go for an anti-VEGF injection and a cataract surgery, do you combine or do you give it separate?
Yeah, I almost always separate these treatments, because see, these medical retinal disorders, they are not one-time treatments. So they have to be on regular follow-ups. And what we do is we club their follow-up visits. Like he's coming for a follow-up after injection, and then you schedule a cataract surgery on that visit. He'll show the eye and then just go ahead with the cataract surgery. Dialysis patients, we are very rarely injecting, because many of them, they don't have a macular edema which classifies to receive an anti-VEGF injection. So, but yes, there are sick patients where we will go for a retinal surgery, combined surgery for them if they have a non-clearing vitreous hemorrhage or some tractional issues. So to make their visits less in long term. But just one visit, I think you just think about it, you are just reducing one visit, and he might need 30 visits in next 3 years or 4 years. So that's the reason it never occurred to us that we should try to club injection in cataract.
Deepu, any experience with the telescopic kind of IUL? What type of IUL in AMD? Because you made a very good point that central scotoma will be there, but they can have good peripheral field. There is one FDA approved IUL also.
Yeah.
Where, any experience or any literature on that?
No, I think no personal experience, but I think tolerance of that IUL in NTA segment was not good on long term. One of our ex-alumni was part of that original paper, Dr. Amol.
Yeah.
That was like IMT, implantable miniature telescope. Somehow the endothelial loss was too much. But what we do is we tend to overcorrect them, like our old concept of reverse Galileo method. We tend to undercorrect them and give them a plus glass. So that is a small tip for anterior segment colleagues, that don't make them myopic at least.
Good suggestion. Yeah. So I think we will move on because Gopal is nodding constantly. So I think before we go to Natasha, I thought we will finish off with all the injection dosage plans, and then we'll learn about what is the technique and litigations and all these things. Gopal, is that okay? We'll ask Unni to tell us about, if Unni is ready, about dosage plans in all these conditions, because all of us have been loaded with so much of information from all the diseases. But you see, PRN, treat and extend. I think let Unni finish, then we come to Natasha. Yes, Unni. You have to unmute yourself, Unni.
Natasha is not very excited.
No. Unni, unmute. Unni, you have to unmute. Can you? Hello? Dr. Unni? Unmute. Gopal, can you tell him?
Just realized it. Yeah, now you are unmuted. Yeah.
Yes, Unni. Unni is a very prolific speaker. I think I always enjoy his talks because his method of presentation is unique, and he has every slide will have some take-home messages.
Thank you, sir. Thank you, and it's a pleasure presenting at this forum. So we kind of thought that we've heard a lot about treat and extend and PRN. So I just thought to take it down in a very lucid way. So we'll just go through a few good points over here. That is, why are we looking at alternative plans? And I'll be talking about treat and extend for AMD and a little bit of PRN for DMA. So we'll understand these two plans in two different conditions, basically. And there's a reason for that also. And we'll talk about the inferences and relevances of what I've been talking about. So this is the way we came. So all through the morning, we've been going through all of these talks. All of these studies have been mentioned in passing or in detail. And eventually we have understood that a monthly regime gives the best results. However, 92% of physicians or ophthalmologists do not follow a monthly regime. It's highly individualized. Why? Because most of the other regimes are more convenient and more cost-effective for the patient than a monthly regime. And compared to the monthly regime, the other regimes have fewer risks. They minimize systemic side effects and they have less atrophy. But a summary of the real life situation is that 30% or less people actually complete the loading dose. In real life for DME specifically, a person gets only 3.2 injections in the first year as compared to 8 to 10 injections they require. A thing we all know is that it's much easier to start than to stop injections. And it is more individualized, not by science, but by the patient convenience and finances. Now, the difficulties of a real life situation also, you're encountered with non-responders. You have people who are chronically unresponsive, and eventually you see structural damage happening in the retina. So why do we look for alternative plans? The two plans that eventually we've come to settle down is, one is a treat and extend, and the other is a PRN, which is also treat, observe, and treat again based on the amount of exudation and activity. And why are we looking at these plans? As we said, we're looking at a cost-effective solution, we're looking at convenience, and basically we're looking at high compliance. And all of these, we're looking at these to reduce the number of the optimal injection count. Okay, so while I discuss the two plans, there are a couple of things. It's basically the drug, the disease, and the dosage plan. The drug, which is better than the other, it has been studied left, right, and center. There's so many studies and there's still not many conclusions, essentially. The diseases are different. So I would like to essentially categorize the AMD and the DME in two different scenarios. AMD is a volcano disease. It erupts causes a lot of problems, then is it's not exactly quiescent, but it's in a rumbling stage for some time. It may be quiescent for some time, and then it erupts again. And it happens again and again for a long period of time. DME is like pollution. For all those of you who unfortunately live in Delhi, you can know slightly man-made, depends on the condition outside. You can deal with it at a little time. If you don't deal with it today, you'll deal with it tomorrow. It's always there in a minimal amount. You can take care of it by some measures. It's always there, DME. It goes away, but it's something that you have a little bit more leeway than a catastrophic event like a volcanic eruption. So to differentiate the disease, AMD has an aggressive initiation. It's a local pathology, a slow-growing angiogenesis with precipitous bleeds, recurrences, but the eventual visual loss is either due to scarring or atrophy, or scarring with atrophy. DME is more like a long-standing vascular anomaly which produces ischemia. So I don't have to say all of these things. It's a global pathology, and persistence more than recurrence, we could say, is a thing, and you have late structural changes. So whatever dosage plan, we have a lot of issues. You have to initiate treatment. You have to have a clear
Only your sound is cut off.
points. Finding an optimal and realistic treatment, and eventually the dosage plan has to be cost effective, convenient, and compliant. So through the years, this is just a very strange slide. Through the years, we started with 2006 monthly. People felt it was too much. They went with PRN. They're finding all sorts of ways, and they find it was not enough. And many studies, many people, they went into, and we are still struggling with these concepts now, 15 years after initiation of anti-VEGF. So essentially, everything boils down to two things. You have a PRN regime and treat and extend. We heard from Dr. Shova that there is also a fixed regime because of an availability of a drug that gives you the option of a longer treatment period. The PRN regime is, we'll talk about that. It's a loading dose of 3 months followed by evaluating the patient monthly and treating if there are signs of activity. The treat and extend regime is a modified fixed regime where you keep on increasing the treatment interval and individualize the patient's treatment dosage plan for that patient, that disease, that eye. So this is what we have to understand. I mean, for those who are not too sure about what a treat and extend means, that is, the interval between treatment is extended by every 2 weeks if the OCT is dry and the vision is stable. On recurrent edema or activity, the treatment interval is shortened. What I would really like to say about this is that we're not talking about a visit. You're talking about an injection. The patient receives an injection, whatever the status of the eye on that particular day, the decision was taken at the last visit. So this is something that treat and extend people have to understand. So again, I would like to say is that to do a proper treat and extend, a couple of things are essential. There has to be a uniform evaluation system to tell you what do you mean by activity, what do you mean by stability, and all of that has been decided. That is the presence of SRF. I'll put a small asterisk over there. The presence of intraretinal fluid or new hemorrhage, yes. The decision making is not whether to take an injection or whether to inject. The decision making is only when the next injection is. So that is something, the name treat and extend, if it was inject and extend, probably people would have understood and got the concept a bit more clearer than treat and extend. So this is an important slide. Treat and extend is a proactive step. I'll tell you why we're talking about proactive when we talk about reactive later, but it's a very proactive step. You look at disease activity by certain markers, and you stop only when there is, you call it stability only when there is no more morphological improvement in the patient. This is something that I'd like to say is very important if you want to implement a treat and extend protocol. That is, you have to decide whether your clinic is a one-stop or a two-stop center. That is, can you see the patient, evaluate the patient, and inject on the same day? Or can you see the patient and evaluate the patient on one day and inject only on a different day? This is very critical to both of the regimes. Treat and extend, it has to be bang on at your period of 2 weeks or 4 weeks or 6 weeks. Or if it's PRN, you evaluate one day, see activity, and do not do an injection for a week or 2 weeks, then you have actually lost time between you detecting activity and you treating the patient. So basically, this is an algorithm of the treat and extend. To put very simply, when you see once you have attained some sort of stability, and if the macula is dry, instead of a 4-week interval, the injection is received at 6 weeks, and that is increased every 2 weeks till the patient. If by any chance you detect fluid or activity at the injection visit, the next injection visit is decreased by 2 weeks. So this is called algorithm challenge. You have challenged the algorithm. And the importance of a challenge, I will talk about sometime later. So let's talk about treat and extend for naive patients. It always has three parts. First, it always goes monthly, so that why you make the macula as dry as possible, the vision acuity is improved as much as possible. So the monthly arm is to provide improved visual gain. Then you go to the treat and extend arm. The treat and extend arm is increasing increasing the interval while retaining the gain you have got. And then eventually you may have to go to the constant dosing arm. That is, you reach a point of time, let's say 8 weeks for a particular eye, and you continue constant dosing till you maintain the visual benefits. And then there is a concept of cessation. The concept of cessation is when you decide that it is enough, this is enough to maintain, and the patient will not regress after your point of treatment. So there are 4 steps or 3 plus 1 steps in when you decide a treat and extend protocol. Now, this is quite interesting. When you have a patient on a PRN regime, why do you want to switch to a treat and extend? If you have poor compliance, or if you want longer intervals between the hospital visits, you go to a treat and extend. There are 2 small caveats which are interesting. A patient who is on PRN and who has been stable for 3 months, you do not shift to a treat and extend. Now, the ideal person who is on PRN who requires re-injection less than 3 months, you might shift to a treat and extend, and there are some very, very nice clues to treat. Suppose you have a patient over a period of 2 to 4 years who has decreasing visual acuity and frequent recurrences. That's an ideal patient to shift to treat and extend. Suppose you have a patient who's on recurrences, and each recurrence does not respond to only one injection. They have to receive multiple injections to settle down that recurrence. That's point number 2. Suppose you have a patient with stable visual acuity, but he gets recurrences and never actually has a dry period in between these recurrences. It's a wonderful patient to shift to this kind of a flexible, fixed regime. A patient with pressure side, a single-eyed patient who you cannot give to risk to form a massive hemorrhage in AMD. Yes, obviously patients who you cannot bring in monthly, and these are the patients who there is an advantage of shifting to a treat and extend regime. Now, the next point: why is this 12-week period or 3-week period assessed or taken as a maximum extension? There's a wonderful real-life study of 2,000 eyes in which it says that after at 20 weeks, each visit there's a nearly 40% chance of the patient having a reactivation. And at 12 weeks, this is a maximum extension that is allowed in the treat and extend regime. Now, when you're on a treat and extend, when would you stop and how would you stop? So let's say a patient has gone very well and the patient is has attained maximum morphological improvement, and you've reached the 12-week injection limit. You can continue it for 12 weeks, that is about 9 months. And then you can either transition to a monitoring and extend. You just don't let the patient go, you monitor and extend. But if it's monitor and extend, you start another 3 weeks, that is a year after the last injection, and you start monitoring every 4 to 6 weeks, and you extend it till you're monitoring every 3 months. So that's a reasonably okay guideline to how to stop a treat and extend regime. There are two subsets. I think Dr. Dinesh just mentioned it in his talk, two subsets. Those who require less number of injections and those who require a lot of injections. Now let's talk about those who require a less number of injections. This is really, really important. You cannot blindly put everybody on a treat and extend. So this is the most important subset to be recognized. After the third injection, by the fourth injection, if you really find that the patient has really settled down, the CNV muscle, there's no activity, you have the option, you give the opportunity to the patient to go on a monitor and extend regime. Not a PR and extend, a monitor and extend regime. That is, you monitor, increase the monitoring durations, and be ready to inject the patient at the time when you see activity, and then you shift to a treat and extend regime. Now let's talk about the subset of patients who require a lot of injections. There are two important caveats in this. One, the treat and extend approach will allow you to identify these patients who require a lot of injections. The second caveat is that increase the interval by a week, not 2 weeks in these patients. Nothing is fixed. You can increase, you can make it 4 weeks to 5 weeks to 6 weeks instead of 4, 6, and 8. Do not challenge your extension period indefinitely. That is, if you've had 8 weeks activity, you bring it down to 6 weeks, patient is stable on 6 weeks, you challenge it again, you try to make it 8 weeks and 10 weeks again very fast. You preferably do not do that. You do that, and if you do that, do not attempt to challenge it more than 3 times, because you will have a drop in visual acuity if you challenge your treat and extend fixed deadline many times. So this is an interesting concept. It's not basically an Indian concept. It's a foreign concept of bilateral injections. When you have two-eye disease and you inject according to treat and extend, generally you'll under-treat one eye and you'll over-treat another eye. So there's a bit of mathematics happening here. If you can fix the injections so that like one eye goes 6 weekly, one eye goes 12 weekly, you've got it done. The other option is to base your treat and extend policy on the better visual acuity potential eye. Okay, that's one way to do it. And that's how you get it. But we don't usually do a lot of bilateral injections. So yeah. So I'd like to introduce 5 concepts when we talk about treat and extend. Concept number 1. The most important thing about attaining good visual acuity in any anti-VEGF patient is time to the first injection. And I think this is a concept, and it is something that has to go out to all the people treating anti-VEGF, that AMD, time to the first injection, is the most critical to maintain good visual acuity results. Concept number 2, when you are treating monthly, it was highly proactive and you are over-treating. When you're going to PRN, you are seeing activity and then you are treating. What does that mean? has been released from your anti-VEGF blockade probably. So you have been doing reactive. So it's an under-treatment. So eventually the treat and extend is a middle path. That is, you are slowly releasing your individualized treatment plan for that particular patient. Concept 3, this is what I told you. The most important thing is a monthly treatment to maximize the visual gain, and then slowly go into treat and extend, and then go into constant dosing with the findings that you have obtained, and then your cessation phase. Concept 4, what I mentioned, give the patient an opportunity to escape from your treatment if he's done well enough. That is, I am not a big fan of calling it PRN because we don't do PRN properly. PRN is not letting the patient escape. PRN is calling the patient every month to your clinic and saying that you don't need an injection if he's safe, which may be required, but we should have the confidence to extend the monitoring interval also. So, and the concept 5 is that you can switch forth and back from PRN to treat and extend back. But what I'd like to stress at this point is that the core of treat and extend is optimal injections. You give enough injections to prevent a subretinal hemorrhage or a precipitous bleed happening, but not too many injections to cause macular atrophy. So the core of a treat and extend is optimal treatment. So these were the treat and extend trials that happened. And I'm just going to do the Canadian trial, the CAN-TREAT. Over 2 years, 17 injections, which is not a low number. 73 patients, they could be extended to once in 2 month injections with ranibizumab, okay, not aflibercept. And 43% could attain 12 monthly, that is 3 monthly with the ranibizumab. If you look at the mean gain of visual acuity, the letters, it's 6. It is less than the monthly regimes, but the number of injections is also about 7 or 8 less in a 2-year period. This is an important slide. You could prevent severe loss of vision by a bleed or whatever in 6.5 patients when you did a treat and extend. So maybe that is equally important than the visual gain, that you did not have a massive hemorrhage that obliterated vision for these patients while optimizing visits, while optimizing number of injections. These are new 4 concepts in treat and extend which have thrown the whole thing, thrown a spanner into the whole thing. Fluid, the type of CNVM, Octa, and type of drug. Fluid. New concept, you can retain or accept a little bit of subretinal fluid. The patients who are really dry, there is an increased chance of macular atrophy. The studies all say that. So there is supposedly, like type 1 membranes, a particular type of membrane in which the growth of the membrane recapitulates or repostulates the cornea capillaries, gives them an amount of nutritional support, vascularity in an otherwise atrophic choroid, and it probably protects the photoreceptors. So leaving a little bit of fluid, tolerating fluid. What does this do? This changes your endpoint for treat and extend. The treat and extend endpoints we're talking about dryness. Now you're saying you can retain a little bit of fluid. We have to rethink this. The type of the lesion. As mentioned earlier, type 3 lesions, you have to treat early and you have to treat aggressively. You have to keep on watching monthly. And maybe for these patients, a strict PRN regime is better than a treat and extend regime. You know that these lesions are not going to continue for a very long time. You have to get rid of the retinal component fast and hit it hard. Type 1 lesions, you know they're going to persist for a very long time. So these are the lesions, the type 1 lesions underneath the retina. These are the lesions where you can effectively plan on doing a treat and extend. So based on the type of the lesion, you can take a decision earlier. Octa. Octa, diagnosing the presence of a non-exudative or a quiescent membrane is the other confounding factor now. So probably in the time to come, we would have to incorporate the presence of Octa, identifying neovascular membranes in all your treat and extend regimes. Why? You can see it much earlier than the presence of the membranes, the growth of the membranes, you would be able to see much earlier than they produce exudation. And the type of the drug. What we've talked about 3 monthly or 12-week was with ranibizumab, the presence of aflibercept, and like ma'am said, fixed dosal regimes with aflibercept, they are extendable to up to 16 to 20 weeks with aflibercept, the treat and extend regimes. Now, I'll just go into DME. Here, I'm going to talk only about PRN, not treat and extend for certain reasons. So these are the studies that always stress on this point. Pro renata means as and when required. Uncircumcised pro renata, we use it as and when convenient. So the patient comes in when convenient, we inject when convenient, and we call it PRN, which is not the thing. A PRN means it's a monthly intense monitoring schedule, not a relaxed Indian stretchable time schedule. So this is a basic thing. After the 3 monthly anti-VEGF loading dose, you monitor monthly. Again, I'm saying monitor monthly. The number of visits, the number of times you have to come to the hospital, the indecision of the patient, whether you're going to say he needs an injection or not. Now, why is this acceptable? See, all the guidelines in most of the places. So there's a big divide. This side of the world, that is a lot of places, Europe, India, they prefer PRNs. A lot of the US and the Americans, they prefer the treat and extend schedule. Yes. Now, there's a difference. There's a general consensus that DME does not need as many injections. It's being challenged now. A laser is an additional thing that you can use. A lot of the out-treatment schedules, you get it flat, the patient goes totally out of control, the edema comes back very badly. Yes, so that is why a PRN, a study regarding the PRN said the visual acuity was nearly maintained in a PRN based on the loosest characteristic, that is visual acuity, and an OCT guided treat and extend, the number of injections and the visual acuity gains were nearly the same. The retain study, you can see that what was worse is the PRN was worse compared to the TNE, but the number of letters the number of injections was also much less. If you can look at these, the number of injections, you could see that a person in treat and extend, they received 18 injections, while in 12 injections for comparable visual acuity results. Now, I'd like you to see this. This was 2019 BC, that is before Corona, people sitting together. It's unknown now. Anyway, what we follow now is a loose PRN. That is, a patient comes in not exactly at 1 month. We take our own time. When do you want an injection? Next week? Okay, that's fine. What about your insurance? It'll take 2 weeks to come. Okay, that's fine. Just get it done. So what we practice is not exactly a PRN, because there is a lag between our monitoring. There is a lag between what we tell the patient, you have your injection at this time. He has it a week or 2 weeks later. But that is still okay in DME as compared to AMD, where you should not have a let go. In DME, a week, 2 weeks, 3 weeks is probably not desirable, but it's probably acceptable. And that is why a loose PRN is more close to a real life strategy, is more close to what we practice in our clinics for DME. So the take home advice, AMD requires prolonged treatment and supervision. We should follow guidelines to switch and stop. It's a volcano disease. It will erupt, and you have to predict the eruption. And you're doing all of this to prevent a precipitous loss of vision. DME, it's more difficult to overcome, but more forgiving to treat. You can adopt a more people-friendly PRN approach without severe deterioration. It's like pollution. You live with it, you reduce it. Some days it's less, some days it's more. But the money in the bank message I'd like to emphasize. Time to the first injection, critical. Monthly phase till stability. Even if you're doing a PRN, you have to go monthly till you get the best visual acuity results and the morphology results. And you stick to your preference as much as possible. You do not give up. You don't say that the patient hasn't come in, so I'll consider it a PRN and not a TI. You have to stick to one particular form to know whether it's working or not. And this is what I like to say. The inferences and relevance in the current day scenario. It's a pandemic era. You have to reduce hospital visits. You have to reduce waiting time and decision-making time. Be prepared to receive the patient and treat the patient quickly and maximize outcome. And this is sounding tremendously like the treat and extend regime. So to conclude, I'd like to say science changes. Science changed a lot over the last years. We didn't like treat and extend. Now we like it more. We loved PRN because it was so physician and patient friendly. Now we don't like it so much. We have to strike a balance between studies and real life. And thank you for patient listening, and hope it was useful. Thank you.
May I say truly wonderful. You see, I have yet to hear a talk on treat and extend, which is so nicely explained. I also like the similarity between volcano and pollution, although Delhi was slightly.
I'm sorry, sir. It was too much of a dig for me not to take.
It's okay. I think we will move on because time is running out, because I have a lot of points to ask also. But before Chaitra puts up, I think Natasha has to tell us, sorry Chaitra, because I had asked Natasha to wait for some time, primarily because we wanted to hear all the regimens and then come back to injection technique. So Natasha is going to tell us whatever we have heard, whether it is real world or practical or real, whatever, how to give a good injection, what is a good technique. Because now that everybody is giving injection, even Ozurdex and DSM people are giving. So I think Natasha's talk becomes very, very relevant. And after that, we'll hear about the legal tangles. Yes, Natasha. Sorry for delaying you, but I think this sequence dictated that let's hear all the regimens and then go to technique. Sorry.
Good afternoon, everyone. Thank you, COC, for this opportunity. And that's all right, sir. The captain can always change the batting order. That's fine. So let us now see, after the what and the why of it, let us now see how the intravitreal injection should ideally be given.
Go just outside the screen and click, please. Outside the, yeah, or click next, page down.
It's not coming, just, yeah.
Yeah.
So, like we have said earlier, it has overtaken cataract surgery as the most common intraocular surgical procedure, and an informed consent regarding both the drug used, especially important when you're using the off-label bevacizumab, and the procedure is a must. Just general guidelines, of course, indication for the procedure should be very clear. Like we always tell our students, the what and the why is more important than actual how of it. So you should be very clear about why you're injecting the patient and when you're injecting. And initially, you should assess for any risk factors for infection, like ocular sac infections or any lid infections. And also, you should look at if the patient has any comorbidities like glaucoma, whether that is well controlled or not. Systemic, again, metabolic control if you're injecting for DME and other patients also, and whether there is any focus of infection elsewhere in the body. This is very important because if you are having a urinary infection and the patient has a bacteremia, you are likely to produce another nidus inside the vitreous with your intravitreal injection. Preparing the eye is prepared what I probably Dr. Shobha and all would differ because they would be injecting in a designated room. But in India, where bugs are so common, it's always better to inject in the OT. So a sterile operation theater is what we prefer for the injection. And preparation is done just like you would do for any other intraocular surgeries like cataract surgery. You clean the eye with povidone iodine and use the 5% povidone for conjunctival surface preparation and drape the eye. Perioperative antibiotics and pre-operative antibiotics, there is not much role in it. Topical proparacaine anesthesia would do, if you want, you can do subconjunctival or subtenons, but it is usually not required and everybody does it under proparacaine anesthesia. The needle diameter 27 to 32 gauge, but 30 gauge gives you the most atraumatic entry. The angulation of the entry is important to prevent vitreous wicking and reflux of medicine from inside the vitreous. The shallow angulation at the sclera and then inward into the vitreous is the best method. The site of the injection, however experienced a VR surgeon you are, it is to for each of your injections, distance from the limbus, either in phakics, you can use 4 millimeters, in pseudophakics 3.5, and in aphakics 3 millimeters from the limbus. The idea is to inject it through the pars plana. Anteriorly, you are likely to cause a lens touch, and posteriorly, you are likely to cause damage to the retina. And the drug is then gently injected into the mid-vitreous cavity. You can either ask the patient to look straight up or 180 degree away from the injection site. Hold the syringe in your dominant hand and a Q-tip in the non-dominant hand. Care taken not to touch the needle tip to the lid margin, which is perhaps the most important tip of all. That is the most important step. There should, once you have loaded and you have uncapped the syringe, then the needle tip should not touch anywhere except the point of insertion. Do not move the needle while inside the eye so as not to cause any traction in the vitreous and potentially cause a retinal tear. Inject at a steady speed and withdraw the needle also at a steady speed that reduces efflux of medicine from inside. Ensure optic nerve perfusion with an indirect ophthalmoscopy to just look at the disc perfusion post-injection. And reassure patients that they may see floaters, which may be an air bubble, or if you're giving triamcinolone, it may be the medication itself. Just like you do for cataract surgery, explain warning signs of end-off and ask to report in case of pain or defective vision post-injection. Complications I will not deal with in detail because Chaitra is ready with it in the next presentation. The most common one we see is the subconjunctival hemorrhage. Of course, you can have vision threatening ones like the endophthalmitis, touch cataract, etc. A small video on how the injection is actually done. So measuring with the calipers, 4 millimeters for a phakic patient. The injection is given straight into the midvitreous. Do not move the needle while it's inside the eye. Withdraw at a steady speed. You can use a forceps and then the Q-tip to gently interface the fibers. We will also see how an Ozurdex implant is done. This is the Ozurdex implant. It has a plunger and it has the safety tip. That safety thing has to be removed before you start the injection, and that is the plunger. So here again, you go straight inside till the steel part of the blade is inside, and then you press the plunger so that the medicine is released into the midvitreous. So in conclusion, like all procedures, there is a learning curve for intravitreal injections, and we must learn to do it right every time. So do the injection for the right indication, following the right procedure. And most importantly, never ever think that it is just an injection. All safety precautions for sterility, for your own protection as an informed consent should be done for all or every time you do the intravitreal injection. With that, I would like to start this presentation.
Thank you, Natasha, for this. What I would tell Natasha as well as Gopal, who is the chief convener of this webinar, that although everybody knows, I would still request Natasha's presentation to be made available to everybody, lest the overconfident people, become so confident that they create complications. So the other part you see was that in your slide, you said that you go at an angulation and then go vertical, but in the video you showed a direct vertical injection. Was that deliberate or?
Just at the side. Actually, that is more important when you're using the bigger gauge needles. With the 30 gauge needle, it is not that important when you are doing, because there is not enough space there for your manipulation.
The other thing was, do you really think that with 0.05 ml injection, it is required to check optimal perfusion? Well, I don't know it. That's the reason I'm asking. 0.05 ml of injection with the 2 injections, it's okay. But a single injection of 0.05 ml, do you see the optimal every time?
In our practice, we actually do a pre-procedure paracentesis before injection.
At the end of injection, I don't see the optic nerve. That's the reason I'm asking.
Sir, ideally, we should be seeing the optic nerve. If you do not see it, you should be seeing the optic nerve perfusion, because especially when the pre-operative IOP is a little high, you may push it to higher.
We see in glaucoma, predisposed eyes, those are okay. But in a single injection in routine eye, not predisposed, not glaucomatous, not operated or whatever, then normally 0.05 ml does not, I don't see, therefore I was asking. So in any case,
I have the opinion of the panel on that.
No, Dr. Dinesh Talwar wants to speak.
No, we will not differ on this because time is running
out. We don't differ on this. I think we do not look at the fundus in a 0.05 injection. And if the pre-existing pressure is high, or if the patient is on multiple anti-glaucoma treatments, I would actually do a paracentesis anyway. So the issue gets closed. But when the patient goes down, then I definitely out of the OT, before he goes out of the hospital, the disc pulsation is checked once.
So
on the table, we don't bother to do it.
Okay. I thank all the 13 speakers we had here, but you see, we can't leave this webinar till the time we understand the legal tangles. Because legal is one word which scares everybody. So I hope Chaitra will not scare us and, help us in this webinar or interval injections, that how we are safe. Over to you, Chaitra.
Thank you, sir, and thank you to Gopal for inviting me. And I think we're at the finishing line of this marathon session on anti-VEGF injections. So I'll be speaking a little bit about the complications and the legal tangles. And like Dr. Lalit said, it is extremely important, and especially in the Indian scenario, because we are all still using off-label drugs, we're using biosimilars. So there is a gray zone there. Have no financial disclosures. We've already, the need for the drugs have already been well elaborated in all the previous talks. But predominantly we spoke on anti-VEGF here, but we also give a lot of other injections. Even for infective conditions, we do give intravitreal. So it's beyond just anti-VEGF when we're looking at complications of intravitreal injections. Specifically, the importance of anti-VEGF is already well established. The clinical efficacy, despite the small dose and the intravitreal route, we do know that it can enter the circulation and cause alterations, and there are some risks associated. And ranibizumab, aflibercept, and razumab have been approved for use in the eye, whereas bevacizumab is still off-label. So first, let's look at the risk and the complications. A lot of them have been covered along with the respective talk, but I will just give a brief overview for completion. So the risk is quite low because we have come a long way. We've learned from our mistakes. Our technique has improved. The gauge is smaller much now, so it is definitely better now. The risk is much lesser. So the adherence to the good technique should reduce this risk even further, as Natasha has shown us the best way to do it. And an informed consent, we should tell the patient of all these risks, because we don't want the patient questioning us later as to, you didn't tell me that this can happen, you didn't tell me that. So the consent form should be comprehensive with all the risks. And despite necessary precautions, we do see complications, even though the incidence is very, very low. So complications can be systemic or ocular. The reason why systemic is important is because it is known to have complications in those with a known cardiac or cerebrovascular accident recently. So these are some of the studies, and the incidence of systemic side effects are mentioned here, particularly those patients in whom probably in the last 6 months or 3 months they have had a cardiovascular or cerebrovascular incident. It is best to avoid the drug. Now, coming to the ocular side effects, these are very comprehensive reviews that have been done for the risk of intravitreal injections. There are 2 studies, and both are extensive in the detail and the numbers that they have studied. So what are the main concerns for as far as the eye goes is endophthalmitis, inflammation, cataracts, retinal tears, vitreous hemorrhage, and so on. We'll just look at some of the important ones or the more common ones. Also, we need to keep in mind the iatrogenic injuries when we're injecting, especially we do a lot of training for fellows, so they also give injections. So we need to be very vigilant when at least they start off, especially with respect to phakic patients. We've seen even corneal abrasions when the patient comes for a follow-up on the first day post-injection. There is a small abrasion or an epithelial defect. Intraocular hemorrhage, retinal tears, hyphema. So these are some of the complications that we see caused by the injecting physician. Of course, post-injection endophthalmitis, this is again one large meta-analysis that did it between 2005 and 2012. Out of close to 3 lakh injections, they found the incidence to be just 0.05, and they found staph and strepto to be the most common. And another analysis, again, between 5 and 10 saw it to be around 0.04. So you see the risk is pretty low as long as we're taking all the precautions. Here again, staph and strepto was most common. So unless treated effectively and in a timely fashion, we can have severe vision loss and blindness. So we need to treat appropriate antibiotic, and when it's very severe, surgical management as well. Now, retinal detachment, basically, we see because of vitreous traction at the base, but the smaller gauge needles has pretty much reduced the risk. And retinal perforation itself, when you don't take a careful measurement using the caliper, Natasha has again explained where we need to give the injection, what measurement in which kind of eye. And this is an important thing is because we also give intravitreal injections for CMV, retinitis, and other infections. The incidence of RRD in this was 0.9 as against 0.05% in non-infectious conditions, because the retina is itself predisposing in these diseased eyes. Floaters, photopsia, and peripheral vision loss, early recognition of these symptoms and treatment if there are any tears or detachment is mandatory. Now, ocular hypertension, glaucoma, extensively covered by Dr. Meena, so I'm not going to go into the details, but a transient rise in IOP is expected, and normotensis usually returns to baseline without intervention. If there are IOP spikes in high-risk patients, then we do need to manage them. AC tap was mentioned already. Steroid responders or pre-existing glaucoma, especially when we're giving them steroid injections, we do need to carefully follow them. Underlying glaucoma or ocular hypertension is not a contraindication as long as we monitor them closely, because a lot of them do need treatment because the macular condition, the vision loss can become irreversible. So we do need to risk-benefit ratio these people. Paracentesis is not routinely recommended, but an option should be kept for patients with the known glaucoma to prevent an acute spike in IOP. So we do advise anterior chamber tap in these patients, but again, this itself carries a risk. It could be hyphema, cataract, or endophthalmitis. Should be done carefully. Coming to cataract itself, we know that the risk with anti-VEGF is very low, but what about steroids? It is an uncommon acute complications for complication unless it's an iatrogenic injury. But a study by Haller et al. Has shown that the adverse effects in the study eye is around 4.1, and that is comparable to 4.5 in patients in the sham group. So I don't think it's very significant. And considering that cataract surgery now, is a rather quick and successful surgery, I don't think it should be a major deterrent to using steroids. Now, how do we save ourselves from the legal tangles? This is the next segment. So I think that brings us to the question, is there really a right anti-VEGF to prevent or to protect us from these legal issues? What is the evidence we have as regards to the efficacy and the safety? What is the affordability, availability, insurance? So this is how I'll cover it. So evidence on efficacy is there. We have multiple studies that have shown us that, almost all of them are equally effective with given, the different options that we have. But when we come to these biosimilars, we don't really have RCTs, probably because it's not required for them for their approval, because that's how it works. The biosimilar, as long as it's similar to the innovator, they don't require an RCT. And we don't have very large, non-pharma sponsored trials and no meta-analysis as yet, because the reported literature is very low on these particulars. So that's the shortcoming. As far as evidence on safety goes, there is published data for ranibizumab, aflibercept, and bevacizumab. And right now, yesterday in one webinar, I had some insight into a comparative trial being done at Disha in Kolkata for a biosimilar with the innovator, and the results are available. They have quite a large number, so we should look forward to those results. Whereas coming to Avastin or bevacizumab, we cannot really extrapolate the trial data to the practice in India, because the Avastin used in the trials is not the same that we use in our clinical practice. So this is a pharmacology group that has done a study, and they clearly said that the off-label indication of bevacizumab does show an increased risk for our patients. Why are the concerns? Because of the compounding errors, the contamination, the counterfeit drug, and we've all had experience with this. And also the bevacizumab used in these trials, the central pharmacy was used for repackaging, and they were single-use vials, which we don't have access to. The testing was complete for each one of them for sterility, purity, and potency, and the standards may not be available in a clinical practice setting. So that is, I think, a major concern that we all have. Also, we don't have compounding pharmacies in India, and we get a lot of spurious drugs. So the key issues remain off-label use. Roche clearly writes Avastin is not for ocular use on the box itself for the India supply, whereas that's not the same in the US. Guidelines are not possible for us to follow in a clinical practice, no compounding pharmacies, so no legal safeguard there because of all these above reasons. And you have a lot of media scrutiny and headlines every time something goes wrong, just like we've had previously with bevacizumab. So these were some of the things, and we hope that we will get past this, but then still we do have endophthalmitis coming frequently. Clusters are seen when we split the vials, either because of the environment in which it's injected or because of the drug itself. Government of India has also previously banned the drug, and the leading eye centers, including government hospitals, do not use Avastin. So legally we are in trouble. So we may have a good intention to treat our patient because it's an affordable drug, but that is not necessarily a good defense in court. That we need to remember. And as far as biosimilars go, published data is sparse, and inflammation and variability is there from batch to batch. Right now, I think that's kind of stabilized now. And also there is always talk about immunogenicity with respect to biosimilars. So this is quickly to summarize the affordability, availability, and insurance, because that's a huge concern in India, because we have, keeping in mind, say, for example, 5 to 7 injections a year with visits and scans and travel and cost of the treatment. It's about less than 1 lakh for bevacizumab, ranibizumab just over 1 lakh. Ranibizumab, the biosimilar, and for the innovative, it's about 1.5 to 1.6, and for aflibercept, it's much higher. But of course, the number of injections required may be lesser with the aflibercept. So this is one other popular slide where it shows the comparison between each one of the drugs. So more important is the cost and the consequences if things go wrong. Of course, to the patient, it would mean more visits and investigations, the medical and the surgical interventions that are required, the reduced compliance. They don't want to come back for injections once they've had a bad experience. Partial or complete vision loss can occur. And as far as we go, the time and effort to treat these complications, we could be using it for treating probably 10 other patients, because obviously the time you need to counsel these angry and unhappy patients and relatives is much, much more. And you may need to waive off the fees for treatment of complications, which will again have a bearing. Loss of credibility. One patient, you have a complications, 10 patients will not come to you. And then the litigation, the legal fees as well. So the right anti-VEGF, while cost is most important for us in India, the evidence on efficacy and safety is very important. We need to evaluate the cost in the context of the actuals and the potential consequences, and we carry the responsibility for the drug we use. So we need to be extremely cautious about that. And this is one litigation that happened in 2017. Quickly, this was a 60-year-old woman suffering from edema due to RVO. With Avastin, first 3 injections were successful in restoring the functional vision, but the 4th injection, she had endophthalmitis, intraocular antibiotics were administered, no results, and for vitrectomy, but the eye was lost. Now, she had sought for compensation, moral compensation in a very, very huge sum. But though the claimant admitted that the defendant had fully disclosed to her that the Avastin had no regulatory approval for intraocular use at the beginning of her treatment and the risk involved, and the content of the same vial was used for 7 other patients and none of them had any adverse effects, the court still found the defendant liable with the loss of the claimant's eyesight and had to pay a moral compensation. So this is despite a consent with full information being given that it is off-label, still the doctor had to pay for the moral compensation, so to say. And this is closer home in India. Again, 51 lakhs was claimed, but a lump sum compensation of 5 lakhs was given. This is again for bevacizumab. So despite all these limitations and all the studies, we are still uncertain about sometimes which drug to go with first, which is the safer, which is more affordable for the patient, and how long can we use them safely. And the choice of the best pharmacological strategy after the first-line treatment failure is still some of the gaps in our current understanding. Thank you so much.
Thank you, Chaitra, for removing some of the tangles. I think tangles with anti-VEGF will continue, legal tangles, till the time judges understand or a doctor becomes a judge, because it's very, very difficult to make judges or politicians or bureaucrats understand all these things. I personally have had a bad experience of explaining, because judges, believe me, are not with you. They are always with the patient. Yes, Malika, you had a point.
Yeah, what I want to say is, from the patient's point of view also, we should not, the first principle is do no harm. First, do no harm.
Yeah.
If you are trying to use a cheaper drug and then give an endophthalmitis and a thyroid eye, actually, an untreated AMD would have had a better outcome. So we should not try to economize at the cost of patient's outcome. That's also morally wrong, even though we are doing it for the patient. And second is, first you have to take care of your own interest and your own defense before you try to be philanthropic and reduce their costs. So both ways, I think it's best to go with on-label treatment and not get into trouble.
Thomas Cherian, your take on this?
So,
Malika says, take care of yourself first.
Yeah, we used to say use a lot of Avastin earlier on, but with a lot of issues.
Can you remove your mask, because unless you are seeing a patient?
We have given up Avastin almost entirely and switched those patients to whatever happens to the biosimilar, we are legally protected because it's approved by the DCP.
How much biosimilar do you use?
So we have.
You use a lot of biosimilars?
Space who of space were on earlier. Now we have biosimilar. That's a safer drug consulting Indian scenario.
Mahesh?
Yeah, yes, sir. Same here. We try to avoid Avastin as much as possible, even though it is not possible to completely eliminate the use of Avastin because we give a lot of free occasionally and all these things, no? So trying to replace, we have to take care of ourselves first. That is correct only. Because if the patient can afford, let him go for the other two. That is.
Sir, when we are talking in terms of 1 injection, 2 injection, 3 injection, then you can go to any extent. But when I counsel the patient about 4 or 5 years of treatment, most of them would not want to move away from Avastin. That is one major problem. So if you are talking about, the 3 months treatment, you have, 3 plus 1 or 2 plus 3 is equal to 5. All these things will be very good and patients will go for it. But after that, initial 4 or 5 injections, when you are looking at the long term, then these the only thing is a cheaper biosimilar can probably replace Avastin. The other things, it's sometimes difficult unless insurance drives it.
Yeah, before I ask Dinesh, what is your take on this? Because you see, if somebody else is paying for the treatment, like insurance or, that's okay. But if patient is paying, I think you need to be legally safe.
Yeah, it depends upon what is your socioeconomic strata of the patient that is coming to your practice or my practice or anybody's practice. That determines the whole scenario.
Gopal, I disagree here because as Chaitra mentioned, cost in terms of time that is required to handle that patient, if there is a patient, you spend so many hours, weeks and months in handling the endophthalmitis, it won't be worth you having saved 5,000 or 20,000 for him. So you have to think of everything. The consequences can be very serious. You will end up in legal problems. Even if they are socioeconomically poor, it takes them very little money to file a case against you in the consumer forum.
With the new CPA coming up, even district forums can give a compensation and give 1 crore now.
Yes, yes.
New CPA has come now.
Yes.
Yes.
They can file online. They don't even have to go physically now. They can file sitting in their room, sitting in their home. They can file a 1 crore case on you.
So let me ask my friend Dinesh Pilwar to give a last word on this.
So 1 minute, I have one point, sir. If they are going to go to the court, how is it that the government agencies are the ones who are authorizing for Avastin? Now, we have a set of patients who come to us where they have approval only for Avastin from the government insurance body. So how do you fight in the court of law when the government has approved the drug?
But Chaitra,
Dr. Dinesh, you're on mute.
The judges are actually calling it a banned drug. The judges actually called it a banned drug,
Dinesh is muted.
Yeah, Dr. Talwar, you're muted.
Dinesh.
Muted. Sir, you're muted. Mute.
There is no government approval for Avastin. The fact is that the company has written on its product labeling not even to be prescribed by the ophthalmologist. Forget about being given by the ophthalmologist. Now, under those circumstances, Chaitra, you go to the Supreme Court and fight it out and win that case. You cannot prescribe the drug. First, you go and win that case. Only if you win the case, then you can talk about prescribing.
I know, sir. I know. That's why I put that case. But my point is, we have our state government who has approved Avastin and no other drug.
So what will happen is the state government will also be a party in your case, and probably the state government will also be asked to compensate for the person.
No, not even there, because the state government has said this is what is approved. You decide whether you want to give it or not. You don't give it, send him to a government hospital.
Government hospitals are not giving. Yeah, very clear.
Why are you giving?
So let us conclude this, and we'll not fight till the end, because my aim of question, raising this question was, believe me, you fight it out in court of law, you will have multiple visits, you will waste so much of time, energy, everything will be bankrupt. But I agree with Malika, be safe, be safe. Do not prescribe this thing, off-label drugs. Off-label you are free to use. All of us use off-label drugs. Vancomycin, Ringerlactin, everything is off-label. But if patient develops an infection, onus is on doctor to prove, and judge is not with you. Even if you produce AS document, VLSA document, literature there, judge will still sympathize with the person who has become PL negative. Yes. That is 100% true. Whatsoever, even though Ravi may say that 70% of use ophthalmologists, there the onus is shared between compounding pharmacies and the doctor. Here it is not. Nobody, believe me, will protect you. Even though you may be working for Chaitra or whosoever, Chaitanya, not Chaitra, whatsoever, even Center for Science for that matter, it is you means you alone. Even my friend Dinesh will not come to save me if I have endophthalmitis with Avastin. So ultimately, therefore I agree with Malika, please save yourself first. Yes, if anybody differs with this, he should make a comment.
My point is also, which disease is so blinding that we need to give this and create an endophthalmitis?
तुम्हारी बात मान लिया ना, तुम्हारी बात तो मान लिया. So I think we will
I think it was a long day.
Yeah, long day. And I first of all thank Cochin Ophthalmic who have thought of this concept, and Gopal for making such a vast program and asking me to make it concise. But believe me, whatever time we spent, it was still worth it. And all the speakers, did a fantastic job. And that's with thanks to everybody. Gopal?
Yeah, it's a 5.5 hours now. And I think we have covered comprehensively 360 degree of anti-VEGF treatment for the medical retina specialist. This will remain in YouTube. And I think this will be a one piece which will stay there, and which all medical retina specialists will see often again and again to actually have the lot of information in this. I think everybody did really well. I told 10 minutes, but most of the faculty spoke for about 30 minutes, and it's excellent preparation which is shown in that. And I thank Chaitra and Natasha for staying till the last. They had come dressed up in the morning, and thank you very much for staying till the last. And we have one person who is driving and on WhatsApp. You see, Dr. Thomas Cherian is driving, and he's on Zoom meeting with us.
Thank you, Thomas, for this.
It is a very sacrificial.
Okay.
So thanking Bayer also for supporting this program, and thanks all the faculty, Dr. Lalit in particular, for controlling this program in such a way that this will remain forever in the minds of all of us. Thank you very much.
Thank you, everybody, and all of you. Be safe, and see you soon at some physical meeting also. Okay.
Thank you, Gopal. Thank you, Lalit sir, everyone.
Sorry, Natasha, for delaying you, but I was compelled. Thank you. Thank you so much.